CSI
We are good to go, sir.
Good afternoon, everyone. Welcome, everyone. And on behalf of Ahmedabad Physician Association and Cardiodiagnostics, CardioCon 2022 is here. We actually are hybrid in quite a few methods, but actually, practically, it is more of virtual. I have with me Dr. Jayesh Trivedi, my whole organizing team. But most importantly, we have our chief guest and guest of honor. Our chief guest is Dr. Vijay Bang, and he is president of CSI, and I will be introducing him with the pleasure. Neelam, next slide, please. That's myself. Next slide. So Dr. Bang is honorary professor and head of cardiology at Grand Medical College, JJ Hospital, Mumbai, since from 1985 to 2015, with 35 years of experience in cardiology, more than 10,000 coronary interventions, including therapeutic experience, instrumental in starting IVUS FFR in 2006 as professor and head of JJ Lilavati Hospital and Research Center, Mumbai. He's been PG teacher, examiner for DNB, president-elect, and chairman of Scientific Committee of Cardiological Society of India 2022. He's also president committee of CSI 2023. He'll be instrumental in starting, also sponsoring prestigious global webcast project of National CSI. He's founding president of Cardiovascular Academic and Research Foundation, registered with Charity Commission of Mumbai. He's founding chair and course director of India ACT Conference, which annually conducts interventional cardiology conference every year with international and national faculties from all across the world. He's founding director, moderator, International Cardiology CME, founding course director, National Cardiology PG course, also published numerous page chapters, articles, editorials in national international journal, and he's been awarded and enjoys the honor of starting angioplasty program in Kenya, Nairobi, 2000, following which he imparted angioplasty training to the cardiologists in that country up to 2006, for which Foreign Minister of Kenya awarded him commendation to Dr. Bang for interventional cardiology services in 2006 in the letter addressed to External Affairs Ministry of India. He is jury of award committee, Sir JJ Group of Hospital, as presented to Professor Dr. Vijay Bang with Excellent and Ideal Services Award with Gunwant Medal in 2006, A.V. Gandhi Award for Excellence in 2006, and he's been appointed Chief of Specification Committee for Purchase in 19 Cath Labs Eco Machine TMT for PMSSY Fund by Government of India. His International Award for Excellence, Gold Medal by WCCPCI in 2013. And I think this is just half of it, as I said. It's always a pleasure to have you, sir, and we look forward to have you as mentoring and delivering also the state-of-the-art lecture, the oration that we have scheduled for today. Next slide, please. So with this, I welcome Dr. Bang, and I would like to felicitate him with a flower of bouquet virtually and also with a shawl. Thank you very much, sir. Claps for him. Next slide. Now I request Dr. Kamlesh Patania to welcome. Dr. Kamlesh is APA President, and I would request him to welcome Dr. Shri Rajendra Shah, CMD owner, Sal Hospital, Shah Lovers Limited, and Sal Education Campus with flower bouquet and a shawl.
Welcome, sir. Welcome, Rajendra, sir.
Thank you.
Next slide.
Thank you.
I'd request Dr. Prashant Vazirani to welcome Dr. Anil Kulshresha, President-elect, with flower bouquet and welcome me with shawl.
Welcome, sir.
Next slide. Now I would welcome the person who's been partnering us, Dr. Kamlesh Patania, President of Ahmedabad Physician Association. Welcome, Dr. Kamlesh.
Thank you. Thank you, Conway.
Next slide. I request Dr. Mukesh Ladda to welcome Dr. Jitendra Anand, Secretary, Ahmedabad Physician Association.
Welcome, sir. Welcome to Cardiac.
Thank you, sir.
Next, I would request Dr. Kalpesh Ansora to welcome Dr. Jayesh Trivedi, former president and our anchor for the program today.
Sir, welcome, sir.
Thank you, sir.
And then I would request Dr. Jignesh to welcome me as the chairman of the scientific committee.
This is my privilege.
Kamal sir is the
Thank you.
only person who handles everything in this
Alright.
Cardiac 2022. Welcome.
Thank you, Jignesh. I would request now Dr. Jitendra Anand to welcome CEO of Sal Hospital, Dr. Nitin Bhai Shah.
Welcome, sir.
Nitin Bhai, thank you for supporting. And I would also request Dr. Jignesh to welcome Dr. B.B. Solanki, who's a GMC observer. Gujarat Medical Council has granted 2 credit points for day 1 and 3 credit points for day 2 for the conference Cardiacon. Thank you.
Welcome, sir.
Next slide. Now I would request Shri Rajendra Bhai to give a welcome and bless us with his guiding force for a few words of wisdom.
Thank you, Kamal bhai. It is my great pleasure to associate with your Cardiacon 2022. I appreciate all the effort made by your Association of Physicians and Kamal bhai. It is a great work. I welcome President Sri Vijay Banga. I also welcome Mr. Anil Kulshresha and Mr. Patania to help you in this event. Since long, Kamal bhai is associated with us and he is a great cardiologist. He is working very, very hard to organize this kind of conference every year. And it is really great pleasure for the society as well as our institute that such cardiologists are with us and working for the society. Acquire knowledge. This is the platform where you acquire the knowledge and you share your knowledge with your colleagues. So indirectly, it is great services to the society. Every year, I am attending this conference with him, and really he is doing great job for everybody. And since this cardiology faculty or the importance of cardiology department for the country is very, very important. The majority of the people are facing cardiology problem, and you people are the only people who try to resolve it by one way or another way. So your services one cannot forget, or society cannot forget your services. So let's hope all the best for your this Cardiacon 2022. I congratulate again the Association of Physicians as well as Dr. Kamal Sharma to put so many effort to organize this. Thank you very much. Thank you.
Thank you very much, sir. You are a guiding force for us, and it's always been a pleasure that you've been supporting APA in succession now for every year. It's always been your support that has helped us. Thank you very much, sir.
Thank you. Thank you.
With this, now we shall be moving to the very important function of inauguration. I request all the dignitaries to do the virtual lighting of the lamp and also declare the conference open. Please.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
So just like the lighting of the lamp, which reflects the lighting of knowledge, knowledge is what we are trying to percolate and distribute. So as they say, Vidya is that wealth that only increases as you give more. It's neither that's na Rajharyam na Brat Brajyam, that neither can be stolen nor can be divided amongst brothers. It only can increase when you, nor the king can steal it from you. It's the only thing that can increase when you give it and share with the others. So that with that philosophy, CardioCon is what it intends to do. Now I would request our chief guest, Dr. Vijay Bang, whose extensive introduction I've given. I request him to declare the conference open. And then we would be taking his keynote address where he's talking about the challenges as a president. And when he speaks not for just himself. He speaks for the Society of Cardiologists. He speaks for every interventionist. And he's also showing us the path with the leadership. He's going to talk about the emerging and the conquered frontiers in intervention cardiology, the path ahead. So Dr. Vijay Bang, please declare the conference open and then we can have your I request you to continue with your keynote address as well. Dr. Vijay Bang.
First of all, grateful to all of you for inviting me to be a chief guest for this excellent program, scientific program. I think this is one of the best conference I could see, and scientific program is extremely well set to go. And faculty, so many faculty is there. I think more than 100 faculty is there. And that is very good for our conference. And ultimately, as you said, we distribute knowledge. And that's the best thing to do, is to distribute knowledge. And it's a great honor and pleasure to say that the conference is open now for academic deliberation.
Thank you very much, sir. Thank you. So now I invite Dr. Vijay Bang for his oration, which is he's consented to be giving. And as I mentioned, the topic is about the present and the future, what we have done, where we stand, and where we are headed for. We are seeing that the cardiology has become extremely dynamic in times to come. Things are changing. Angioplasty is not something that is going to be in vogue forever. Things are going to change much beyond. And that's what I think Dr. Bang should guide us. Dr. Bang, over to you.
Can you see my slides?
Yes, sir, we can. You can make slide share, whole screen visible, sir.
Absolutely. No problem. Let me check whether my slide. Okay.
Yes, it is fine, sir. You can go ahead, sir, please.
It's a great pleasure and honor to deliver a keynote address on emerging and conquered frontiers of interventional cardiology, the path ahead. I will do my best to give this message, not only as an interventional cardiologist, but also as a CSI president-elect for this year and chairman of the scientific committee. We all know that interventional cardiology is all about devices, innovation in devices. And it creates a path-changing and game-changing frontiers. We know that in coronary space, catheter intervention has done a remarkable job saved thousands of lives, particularly through PAMI and ACS interventions. But story is not different for even revascularizing left main lesions in stable coronary artery disease and proximal LAD lesion or equivalent coronary artery disease. Story is the same. There is no difference in that. And it's not only that, it is proved to be extremely game changer in structural heart disease, particularly. Because that space, there was a need for another intervention procedure, which is catheter-based. Because surgeons could not have managed all those cases which are high risk to the surgery. And those are managed by catheter intervention in structural heart disease, particularly TAVI and mitral valve interventions. They have proved to be extremely fruitful, extremely good, and reduce the mortality by 50%. There is no interventional procedures which reduce the mortality by 50%. Now, to start with, I would like to go into history a little bit so that we get to know how to inspire ourselves. Dr. Soames performed, while he was doing the aortogram, inadvertently his catheter got deeply engaged into right coronary artery and patient arrested. He pulled out the catheter and patient was resuscitated after the full CPR, but he didn't get depressed. From there, he realized we can do selective coronary angiography. So he developed Soames catheter and started doing selective angiographies. That's remarkable intelligence of a man. In adversity, he turned out to be a winner. And that is how the overall interventional cardiology process has begun. Because had there been no angiography, interventional cardiology had not begun at all. Then Judkin came in 10 years later, 1967, and developed a pre-shaped Judkin catheter, and they are proving the test of the time even after 50 years. That's a remarkable achievement. Then in 1964, Charles Daughter, interventional radiologist, he thought of doing in femoral artery, he thought of doing sequential larger catheter dilatation and modifying a plaque. And through that, he was very happy. The result was literally better. It was not so acceptable, but it definitely looked better. Nobody was impressed in America with his adventure, but in Europe, Dr. Zettler was impressed, and with him, Grundzig was working. So he inspired from there that he has to do something in this space. So in 1974, he performed first balloon angioplasty in peripheral artery. And that is how the journey has begun. The next thing that he did is he performed intraoperatively in America in 1977, the balloon angioplasty in coronary artery, intraoperative. And then in 77 September, he performed 16 September 77, he performed the first balloon angioplasty in the cath lab. And the result of that angioplasty, you can see it here. And every 10 years, the LAD angioplasty, which was done in 77, is checked by angio, and it is patent. And the patient picture is here, if you all can appreciate. The patient picture is here, and this patient is still alive. So it's an amazing journey. And what he did is he developed the balloon catheter in his kitchen. You can see the glass of wine there. You can see the glass of wine there. And then this was his first LAD plasty, and we showed a remarkable result. And this patient still survives, and he doesn't require any intervention in the LAD at least. He has undergone other intervention of RCA, but not LAD. Then that time, after this was his left main was his fourth case, without the surgeon support, no surgical backup. And he performed this balloon angioplasty with this result, and even that patient is doing well till today. So this is amazing, but now we took almost, he did it in 77 or maybe 78, And we took 2009, 2010 to start our process, 2010 to start legalize our left main angioplasty. Then Grudzik presented 4 cases in AHA, and not only he's a father of interventional cardiology, but he's also father of the live teaching courses. So what he did is, you can see the amphitheater here, and he invited the interventional cardiologists from all over the world, Europe, America, and all were sitting in the hall, and from the remote cath lab, he performed the angioplasty and taught them how to do angioplasty that time. So he has opened the gate for revolutionized the gate for learning and revolutionized the gate for learning. And his concepts were very simple, that he thought it's like footprint in the snow. Doing angioplasty will be like a footprint in the snow. So he did this, and result was good. But 1985 was a disastrous year. All the grandfathers of angioplasty, Dr. Soames, Dr. Grunzig, Dr. Daughter, and the Dr. All 4 of them expired in the same year. Grunzig expired in a very young age with a plane crash. The interesting part is his balloon. This was the balloon he developed. And you can see there are 2 ports. Through one port, he will inject the dye, and through other port, he will monitor the pressure and also inject the dye. So, and then sequentially, he will do the balloon dilatation. You can see the pressure difference before the block, and this is after the block. Means there is a pressure difference in the distal to the block. And then he did a balloon angioplasty, pressure difference has reduced. Then again, he did until the pressure equalize, distal and proximal pressure equalize. In 1982, Simpson got the idea of putting a wire inside. This was without the wire. Dr. Grunzig did without the wire. Whereas intracoronary wire was developed in 1982 by Simpson, and over the wire balloon was developed, and that increased the number of angioplasty remarkably. In that year, remarkable number of angioplasty was done. That gave birth to intracoronary imaging, followed by restenosis was identified as the biggest challenge for interventional cardiologists. Then atherectomy devices were developed. Then intracoronary stents. Then restenosis was addressed by drug-eluting stents and brachytherapy. And then PAMI was developed by Hertzler. First PAMI was done by Hertzler. The interesting part, angioscopy was done in 1985. And it was intraoperative. Means during the surgery, angioscope was passed, and this was seen by Grundfest. Later, it was taken to the cath lab by Spears in 1988. But 1988, intravascular ultrasound imaging was done. And that's the time they realized that there is under-expanded stent, which Dr. Colombo suggested to optimize it by high-pressure balloon expansion. And that is how Antonio Colombo became very famous. Then in 1990, intracoronary Doppler was done by Hartley by attaching a Doppler at the hub of the Soames catheter. And Doppler, but that was only a academic exercise. But clinical benefit of that came in. Clinical benefit of that came in the 1996, where fractional flow reserve was done. You can see the guiding pressure here, pressure from the guiding catheter, and this is the pressure beyond the block. Initially, the pressure difference is low, but as you give adenosine, the pressure difference is wide because the distal artery pressure with adenosine dropped. And this is how the fractional flow reserve came in the picture. And that time also, the critical looking lesion, FFR was negative, and non-critical looking lesion, FFR was positive. So this is a great history, which has now transformed the area of interventional cardiology in many ways. Restenosis was a bigger challenge. Many therapies were developed at that time, and to address that, that time POBA used to be called as PTCA, but now we call it POBA. So this is a very interesting part, and they have found out that number of angioplasties have gone up, but similarly restenosis rate is also gone up, and they spent $4 billion only managing restenosis. So atherectomy devices came in the picture, directional atherectomy came, but it was not very useful, followed by laser atherectomy came, and then the biggest accomplishment, rotational atherectomy. But that time rotational atherectomy did not give that good result. Following that, stents were developed and first peak study was done. And you can see instant neoatherosclerosis in the pig artery. And across the branch, the stent was deployed, and they could note that the flow across the branch is good even after deploying the stent across the branch. So that is how the angioplasty began. And then it came in human artery with the daughter doing a first stent in 1969 in a peripheral artery, and Sigvard did in the coronary artery in 1987. Sigvard is a brilliant cardiologist. He's also a first-time doer of the septal ablation in Hocum and supposed to be very good. Then stent was developed, and stent seems to be better than a PTCA. We can see this result, but still the restenosis rate was very high. So we needed some more devices. Brachytherapy was developed, but then that was not enough. Brachytherapy was successful, but that was not enough. So then slowly we evolved to drug-eluting stents, and drug-eluting stents gave excellent result in that, but restenosis remains the challenge. Then developed the thrombolytic therapy. Timigrate was developed, and then Hartley performed first PAMI, and PAMI results were far better. Improvement in LV function was remarkable, and mortality was low in the patients whose PAMI was performed earlier. So that is how Hartley started. And then stenting was better than POBA in acute in PAMI. And PAMI was better than lysis. So this was all everything. And then adjunctive therapy like GP2B3A developed. But most importantly, because of all these advances, there is a remarkable reduction in mortality from 1980 to 2000. 41,745 patients saved the life, and 50% of life saved accounted to interventional cardiology procedures. So path ahead was good, but there were several challenges even with the drug-eluting stent. So bioabsorbable stents had to be developed. Bioabsorbable stents also produce challenges. Thought that it will give good vasomotion, but vasomotion was equal to that of the stent. Even stent had a vasomotion, which is numerically though different, but statistically almost a non-significant difference. So then absorb stent was having a late thrombosis problem. Then drug-eluting stent progressed from first DES to second DES, and then BRS. So at the moment we have this second generation stent, we know Resolute and Zans, but Synergy is the third generation stent, which is the only stent which is of the third generation. Then of course FFR revolutionized stable coronary artery disease, and 19 studies suggested that only FFR guided PCI is a superior PCI because it's appropriately indicated. And then the microvascular dysfunction was identified by use of FFR and IMR. And several conditions like INOCA, heart failure, preserved ejection, cardiomyopathy, several conditions are included in 2021 in this space. The intravascular imaging has revolutionized. It provided the morphological detail on cath lab table. We could understand what is the pathology going on. And precision in angioplasty developed with assessment of morphology, followed by sizing, diameter and length of the stent, and then optimization of stent all together, and it produced better result. All the three meta-analysis studies showed that there. Then not only that, the intravascular imaging Also, particularly OCT, having a high resolution, gave the good idea about how this dissection, malposition, all other details are identified during the procedure and can be corrected. So there is the result of the procedure is good. There are no complications. Then the scoring was, calcium scoring was done. Calcium is always a challenge, thrombosis and calcium, two biggest challenge for the coronary interventionalist. So many atherectomy devices developed. They have rapidly progressed. And today we know that IVL is also there. So there are multiple atherectomy devices and they are all very useful, but they are adjunctive devices. So, and then because of this, the intravascular imaging and calcium devices and hemodynamic support, even complex cases which were denied surgery due to high ST score, they were also done with this, with a high syntax score more than 32. They were done by PCI. So we know that Impella hemodynamics is better. Then robotic PCI, of course, everyone knows in Gujarat, Ahmedabad, Tejas Patel has made a largest number of series in the world on robotic PCI. And that reduces the radiation tremendously. And now there is a different dimension to it, that is tele-intervention. You can do it from very great distance. Then, of course, renal denervation for resistant hypertension. And it's initially, though it was not successful, later it found to be successful. Then came the paradigm shift to structural heart, remarkable innovation and remarkable benefit to the patient. And the intervention, catheter-based intervention were developed in aortic, mitral, and tricuspid position. Not only that, even left atrial appendage and patent foramen lower were closed to benefit the patient. Now coming to the TAVI, a little detail. The TAVI, we know that once the patient of severe AS becomes symptomatic, the 50% mortality is there in 2 years. So, but surgery reduced this mortality. Surgical AVR reduced this mortality. But there were so many patients who were not fit for surgical AVR due to high ST score, and they were remaining untreated. So there was unmet need, definitely. And that unmet need was provided by none other than Dr. Alain Cribrier, who developed the first aortic valve and deployed it. In 15 minutes, patient was extubated and was smiling. And in soon 7 years, 3 generations of TAVI valves were developed. 9,000 procedures, TAVI procedures were done. And if you see the mortality, all-cause mortality is almost equal to that of the surgery. But the advantage is now today in 2021, it's a day procedure. It's a sedation-based procedure, no anesthesia, no ICU. Just do the procedure, put in the ward, and you can discharge the patient same day or maximum next day. Then there was a issue with the paravalvular leak, which was there with surgical AVR and TAVI both. And they have addressed that issue very well here, and that was reduced, paravalvular leak was reduced. Not only that, the TAVI and medical treatment, when compared, the TAVI produced 50% reduction in mortality. And same way, TAVI and surgical AVR, almost same mortality, but the stroke-wise, remarkable difference, which was statistically significant. And this, over a period of year, 4 RCTs were done and meta-analysis was done. It emphasized that even mortality is better with the TAVI and stroke rate is also better with the TAVI. So why not do it in low risk surgical AVR also? So those patients were started doing. 3 trials were done in low risk patient of TAVI, and all 3 trials were positive. So low risk trial above the age of 65, we can consider TAVI also, because valve age is same in surgical and TAVI valve, same age. Then paravalvular leak, as I said, is a big issue, and now it is addressed by different intervention, and improvement in the devices has reduced the paravalvular leak incidence remarkably. The projection is in almost 3 lakh procedure will be done per year after 25. So many devices have been developed. They are all US FDA or CE mark, and they are all very good devices. Then paravalvular leg devices were also developed. They are all in use, and they are remarkably benefit to the patient. Then same unmet need was seen in mitral regurgitation cases. Mitral regurgitation was severe, but many patients were not surgical candidate. They're surgically not fit due to high test score, and there the catheter-based intervention was done. And we can see that only 50,000 surgery was done. In fact, incidence is 250,000, and 2 million patients are in prevalence. So doing intervention, catheter-based intervention might help some of these patients from dying. Yeah, and MitraClip picked up that very well, though it's a very difficult valve to intervene. Delivery is difficult, fixation is difficult, sealing is difficult, even function is difficult. So, but MitraClip turned out to be the winner here. And you can see that when you compare MitraClip results with CRT, ICD, and drugs, MitraClip beats everything. Number of hospital admissions have reduced. Mortality is also reduced. But it is used both in America, it is used for degenerative mitral valve disease, and in Europe, it is used for functional mitral valve disease. And then came the era of tricuspid valve intervention, and that is mainly for the organic TR and even for functional TR with the dilated annulus. And in this also there was clip, like a MitraClip, and annuloplasty was also a direct and indirect. And two types of valves were developed. One is put on the valve itself, that is called as the orthotopic, and heterotopic, which is in IVC and SVC, what we call a trick valve. And that also produced better result. RV function improved with that. And it is supposed to be excellent innovation and intervention, catheter-based intervention in the space of tricuspid valve. Then came these patients who have this atrial fibrillation and develop stroke. Is debilitating to have a stroke. You can see that T was done on this patient. There was a thrombus in the appendage, and many of these thrombi are dislodged from left atrial appendage. 90% stroke occurred from here. So why not close this in case the patient doesn't tolerate the NOACs or DOACs? Only in this subset of patient, not all patients of atrial fibrillation, you need to do the left atrial appendage closure device. Only in patients who are not able to tolerate NOAC in non-valvular AF. Then came the same indication for patent ductus arteriosus, patent foramen oval, and that device also developed. And initially it was not successful, but now there is, in a selected patient, you can consider this. And this is supposed to be good. Now coming to the future directions. This is a very important space, and we need to cover this very well. And artificial intelligence is something which is going to take over interventional cardiology. It's because it improves the diagnosis through machine learning. ECG, you can artificial intelligence in ECG signals. If artificial intelligence interface, same way in echo, cardiac MRI, and CT, all can improve and redefine the diagnosis of the disease in early stages. So it's a very good, very good artificial use of artificial intelligence, and it's supposed to do wonderful work in this area. Not only that, it can help us maintain the data, it can help us do the procedure from the distance, and even voice mediated command can be given to the patient while the patient being operated. So artificial intelligence has developed remarkably, and it improved if you see isolated surgery and CABG. You can see valve surgery and CABG in both. Monitoring with artificial intelligence devices, it has helped in assessing predicting the outcome, and outcome is better assessed, and you can see that this is remarkably better. Then there will be a breakthrough. Already there is a breakthrough in the congestive heart failure space with the devices. One is sensors pulmonary artery will have a sensor which will monitor pulmonary artery pressure and wedge pressure. The LV remodeling devices, contractility modeling devices, microvads, and interarterial shunts. These things are going to develop very fast, and they are already in the scenario. And some of them are in the pilot study stage. Some of them are already approved for commercial use, and they are supposed to produce excellent results. Now, coming to this is a parachute device which is placed in a patient who's got anterior wall MI and developed aneurysm. So this goes perfectly and sits there, doesn't produce any arrhythmias, preserve torsional contraction, restores conical shape of the LV, reduce LV EDP, reduce LV volume, and even partition the scar completely. So this is supposed to improve the hemodynamics in patients with aneurysm, LV aneurysm or area which is not mobile, a kinetic area of the valve, large area of the left ventricle. Then pulmonary artery pressure can be monitored. If we monitor the pulmonary artery pressure, we can reduce 30% rehospitalization in 6 months. And in fact, in real world, it was 38% reduction in. So just putting a pulmonary artery, monitoring a pulmonary artery, we can titrate the doses of the drugs and improve the condition of the patient. The another heart failure devices is to unload the cardiovascular system with the volume, lymph, and the volume. And that is done through the through the shunts, and also through a transvalvular pump. We can see the pump here. And both these are at the moment investigational, but supposed to work very well. Plus, there are wearable devices which will help us monitoring the patients with heart failure, and also the pacemaker, which is called as bursting pacemaker. It can reduce the sympathetic drive and improve the patients with heart failure. Similarly, these are shunt devices. These three are shunt devices, and they are very useful. Now, imaging modality, multimodality imaging, intracardiac echo will come in a big way after diagnosis will be very easy with AI application. And this is going to be a complete revolution in imaging. Not only the interventional OCT AI use has already started. It's called as software. It's called as Ultron 1 software. It helps in detection of the EEL and also the calcium. And it helps in sizing of the length of the lesion and the diameter of the artery. And it can assess, so we can do a morphological assessment first, followed by sizing, and then deployment, review the deployment of the stent, and it can produce very good result. Then calcium scoring will produce also is excellent information that we get from this. Now, not only that, now in future, live cases will become easy with cloud-based service deployed in the cath lab, and it can reach to the classroom, conference room. It can reach to different location, physician's place, recovery room, and we can see that these patients, other people can learn intervention while sitting in the classroom. So, and then at the moment, patient has to go for multidisciplinary consultation for certain procedure like mitral cleave. It requires TAVI. It requires multidisciplinary consultation with the anesthesiologist, cardiac anesthesiologist, cardiac surgeon, the interventional cardiologist, and cardiologist. All four are the part of the team. So they can virtually meet and discuss this case in presence of the patient and can give a good diagnosis. Similarly, tele-intervention, as I said, this is extension of the robotic PCI. Then this is thing which is now commercially available in America. We do angioplasty, and we open the epicardial artery. But what happens to the microcirculation? Unless we improve microcirculation, we cannot stop the injury to the myocardium. And reperfusion injury, we all have heard, cause more damage than causing a reperfusion, doing a pump. And there's a device which has come, and this device is supersaturated oxygen delivery device. And this will, through the catheter, after the pump is done, this will be connected to the catheter, and directly supersaturated oxygen will be delivered in the LED. It's only done for anterior wall myocardial infarction. So if you do this, you can improve, if you do this, you can improve the endothelial swelling, you can improve coronary blood flow, reduce infarct size, free radicals, and also by doing this, we can reduce infarct size and reduce hospital admission and heart failure. So this is a very important device which will come in the picture. Now there is also a progress in the stent, which is called as bioabsorbable electronic scaffold. It has been tried in Korea, and it has electronic which will read the pressure, the temperatures, and will tell whether patient has developed restenosis or patient is developing thrombus, and that will help in the management of before the patient develops the infarct. So there are some remarkable improvement, and we need to continue and progress. There is no end, and more innovations in interventional cardiology are expected, and it will change the complete scenario. Another most important intervention that is expected is the percutaneous VAD, which I showed macro VAD across the valve, and that may be improved in such a way that there is no need of cardiac transplant. Only deploy that device and it will work like a cardiac transplant. So that is the kind of projection or vision that that is expected to come from all this intervention. And I thank you very much for your kind attention. And I hope that people have understood that there is still a lot to come in interventional cardiology, and it can improve this space. So I tried my best to stick to the time so that I don't give any pressure to the organizer. And I hope it was good for all of us. And let's see.
Thank you very much, sir. Thank you. It was wonderful talk, and as expected, sir, and you've done fantastic justice. You've shown us the path ahead. It started right from the first intervention case that you were sharing. And you also talked about the future, and you've covered it beautifully. I had shared, let me tell a secret to all our audience. I had shared Dr. Brunwald's video with sir, and I thought it will be of value. How on retrospect, I find that probably Dr. Brunwald should go through your presentation and he should update. Yours was more updated than what Dr. Brunwald was talking about recently in one of the settings, and when he was talking about cardiology next decade. But very well covered, sir. I think AI and distant and telemedicine is something in future that's coming up. Sir, I would also like to know from you that you were talking about the project that you are chairing actually as a part of CSI for distant healthcare in terms of cardiology. If you can just share some light on that project that CSI is intending to reach and that you're chairing that program.
See, the idea is to ultimately benefit the community with our services. If the patient is not benefited with our services, we have not achieved anything. Patient should be benefited. That is, academics is fine, innovations are fine, some good procedures we are doing, those are also fine, but patient should benefit with all this. So remote education of the patient, particularly in terms of hospitalization, early hospitalization for acute MI so that PAMI can be done. At the moment, what we have is a 5% PAMI, 95% pharmacoenergy. And in America, 95% PAMI, 5% pharmacoenergy. So we should at least reach 50%. So community education through a website will achieve that goal, hopefully. But we need a person of that caliber to talk to the community, because community doesn't listen to cardiologists. Community listens to preacher leader, the government. They don't listen to people like UN. We only can suggest and take it forward. Another space is out of hospital cardiac arrest. Out of hospital cardiac arrest. It's a very serious issue. We have no infrastructure to save that patient. We can save that patient if we give a community education for CPR and DC version, cardio version. So all these things we need to educate people, and of course modification of all the risk factors which lead to coronary artery disease. That is smoking, obesity, hypertension, diabetes, and lipids. So all.
Thank you very much. So thank you. It was wonderful, enlightening session, and I look forward to meet you in person with hope with the fourth wave going off. And it would always be a pleasure to be working with you and collaborating with you. Thank you for the honoring us of being the chief guest for the function. It's given a big boost of morale to the Ahmedabad Physician Association that the CSI president could come in and deliver this state-of-the-art oration. Thank you very much, sir.
Thank you very much. Thank you.
Thank you, sir. Bye-bye.
Bye-bye.
So with this, I invite Dr. Jayesh Trivedi, who's the anchor today for the Hall A. And Jayesh bhai, I'm giving you session 5 minutes ahead of time. And I think all the faculties are there. We can start rolling Hall A, and so that we can stick to time and we can have it. Over to Jayesh bhai.
Yes, you are right. Actually, Kamal, we have a lot of international speakers who are also going to join us. So we have to be very strict about the timings. Very rightly said. Now I would like to request Dr. K.K. Goyal, Dr. J.T. Brahmbhatt, Dr. Varun Sibal as a chairperson, and Dr. Bhavesh Patel, Dr. Smitesh Das, and Dr. Pragnesh Vora as a moderator. I would like to request Dr. Bhavesh Patel to kindly introduce the subject. This is related to young acute ST elevation myocardial infarction, lytics versus PPCI. So I would like to request Dr. Bhavesh Patel.
Anybody, chairpersons, please introduce the speakers. Next slide, please. Chairperson or moderators, please introduce the speakers.
Smitesh, you can also introduce, please.
Good evening, everyone. Today for our first session is Dr. Aman Chaturvedi. He is practicing as he has passed out for DNB cardiology from Apollo Mains Hospital, Chennai, and now working as an interventional cardiologist at Sal and Sanjeevani Hospital. Welcome to you, sir. Our second speaker is Dr. Mukesh Ladha. He has passed his DM cardiology and is practicing as a consultant interventional cardiologist at Sal Hospital, Ahmedabad. He's having an experience of more than 8 years, has performed more than 10,000 cardiac interventions, is proficient in primary angioplasty, complex coronary interventions, peripheral interventions, and cardiac devices like pacemaker, AICD, CRT implantation. He has been an investigator in multiple clinical trials. He's a teacher and has diploma in clinical cardiology at Sal Hospital, has national and international publications to his credit, has presented various papers and interventional cases at national and international conferences, has been invited as a faculty in national conferences, is certified as AFESC and International Associate of SCI. Our third speaker is Dr. Sandar Patel, who has passed from his DM cardiology from UN Mehta Institute of Cardiology, is a director of Aradhya Heart Care OPD Clinic, is performing interventions at multiple hospitals like HCG MediSearch Hospital, Jivraj Mehta Hospital, AIIMS Hospital. He is well-versed in complex coronary interventions, structural cardiac interventions, peripheral interventions, and has publications to his name in Indian Heart Journal, Heartline Journal, and Sudan Heart Journal. Welcome to you, sir.
Sir, all speakers are requested that they remain in time because we have discussion also for 10 minutes. So please be in time. Thank you. Go ahead, sir. Speaker number 1.
Am I audible? Hello? Am I audible to you?
Yeah, Aman, you are audible. Go ahead.
Yes, sir. Can you hear? Please do it.
Aman, you have to share your slides.
Yes, you are audible now. Please go ahead.
Dr. Aman?
Dr. Aman?
Yes, I am there.
Dr. Aman?
Dr. Aman is there.
Yes, yes. Hello?
Yes, Dr. Aman.
Yes, tell me how to do it.
Yes, you are audible.
Sir, Dr. Aman, your voice is bit low. So can you please increase your voice?
Yeah, sure. Can you hear my voice now?
Yes, now perfect, sir.
This is perfect.
Just open your presentation.
Okay, I have done that.
Yeah. Come again, Zoom screen. There is green icon, share screen button.
Yeah.
Share screen button, sir. Green icon.
I think if Aman is having issues, Dr. Mukesh, you can start with your presentation, please. Mukesh, share your screen. Let Aman figure it out. And Dr. Mukesh can go with the talk too first, please.
Yeah, I can. My slides are visible, sir?
Yes, it is visible.
Yeah. So good afternoon all to CardioCon 2022. Yeah, the first topic is the primary PCI versus thrombolysis in the acute MI setting. And my topic is to speak on the primary PCI in anterior wall MI. This gentleman, 23-year-old male patient, fully vaccinated for COVID-19, presented with acute anterior wall MI within a 2.5 hours. And it in class 2 clip with an almost normal hemodynamics and ongoing rest pain. So after giving a loading dose and the statin, what should be the ideal therapy, fibrinolysis versus the primary PCI? That we have to decide. And before selecting a reperfusion therapy, we know that this patient is within a window period, and that we have to see the extensive anterior wall MI. That means patient myocardium, a big myocardium is involved, and massive MI, and the risk of bleeding if patients go for lytic therapy, and the total ischemic time from the symptom onset to the reperfusion means the opening of the artery, and the time required for the transportation to the cath lab, and our patient is already reached to the cath lab enabled center. So the proper, the ideal treatment for this patient, we have to select from the thrombolysis and the primary angioplasty. But there is no doubt in my mind that this patient is the ideal candidate for selecting for the primary PCI, because according to the guideline, if patient diagnosed with the STEMI, if you can open the artery within a 120 minute, then that is the ideal therapy, that primary PCI. And I am sure that my friend Dr. Aman and Dr. Sandhap, they also can do primary PCI within a 30-minute time period. So this is the ideal way, this is the ideal treatment. This patient, if go for primary PCI. The reason number 2 is that if these patients go for fibrinolysis, then the chances of opening the artery, the chances of the TME3 flow, that is only 50%. In contrast, the TME3 flow can be achieved up to 96% in the primary PCI, and that is the biggest advantage, and that decides the prognosis of this patient. That's why I'm suggesting the primary PCI in these patients. If you go with the data, you see within the first 2 to 4 hours, even with the best molecule which available as a fibrinolytic therapy, you will achieve TME3 flow in 62% of the patients, and that's why the primary PCI is better. If you see after doing the primary angioplasty, you are sure that the artery is open, is flowing very well, and you are 100% sure that this patient is going to be benefited. In fibrinolysis, you have to rely on the certain clinical criteria and data. So I would suggest, and again, the reason 3 number is the reinfarction. The reinfarction means the reocclusion rate of the artery may be as high as 10% in the hospital and up to 30% by the 3 months. And as the time passes, after 6 months, death and the reinfarction is almost 10% in the fibrinolysis group compared to the 4% in the primary PCI group. So the reason number 4, I would say the stroke. The hemorrhage is another a big factor. Intracranial bleed, even though it is a 1%, but if young guy, if develop bleed, that is the biggest catastrophe if it is young in his own family. So I would suggest that this is the again number 4 reason. If you compare the almost negligible risk of stroke in primary PCI compared to the 3.3% in the lysis group. And if you are selecting for fibrinolysis, you have to exclude almost absolute as well as relative contraindication. And if suppose this patient belong to that category, then there is no choice rather than sending patient for the primary PCI. And reason number 6, the thrombolytic therapy is more time sensitive, because as the time passes, the thrombolytic therapy is less effective. And in this, in one of the major paper that has been established, that if you thrombolyze the patient within a 30 minutes, that effectiveness is more. And as the time passes, and after 2 hours, the effect of the efficacy of the thrombolysis is reduced. And in that scenario, the primary PCI has great role. Now, what are the clinical evidence suggests? The data itself says that the Prague study, the largest study and first study which has been done between the primary PCI and the thrombolysis, almost all the patients were enrolled in 3 different groups. The group A, the thrombolysis group, the group B, the thrombolysis, and followed by the angiography and plasty, and group C, the PCI directly. And if you see, almost 1,500 patients enroll and compare, and that shows that group A, the mortality is 14% compared to group C. That means the in primary PCI 7%. So means anyway, if patients go for fibrinolysis, you are almost 50% of the mortality you can save by doing primary PCI compared to fibrinolysis, and that is the biggest advantage. See that 23% of the mortality in thrombolysis group compared to 8%. So that means the biggest advantage you can give, that is the death benefit, that is the mortality benefit in primary PCI group. Even though patient is thrombolized, the 7% of the patient, they go for the rescue PCI because of the chest resting pain or any other reasons. So these are the favoring data in terms of primary PCI. Now coming to the Prague 2, this is the larger study, almost a similar kind of study comparing thrombolysis versus the PCI. And again subgroup analysis was done between 3 hours and 3 to 12 hours, and that shows that after 3 to 12 hours there is significant difference in the mortality, almost 6 to 15%. That death benefit is almost more than double. The reason number 8, again a landmark trial, that is Dynamic trial, that it is a Danish population study that again compared between the thrombolysis versus the PCI, and that has shown that there is 75% reduction in the reinfarction, and 30-day mortality is 24% in the fibrinolysis compared to 6% in the primary PCI, almost 4 times mortality reduction in primary PCI. Now, this is the largest follow-up data, the Dynamic 2 trial, the 16 years follow-up of primary angioplasty versus fibrinolysis, and that shows that even patients who went for primary PCI, they do really remarkably well in terms of all-cause death, rehospitalizations, cardiac death, even after primary PCI. So the benefit of the PCI immediate as well as long-lasting, and that should be the ideal therapy in this patient. Now, this is the interesting study, that captive study that has been compared between the pre-hospital fibrinolysis versus the PCI. In our health setup, the pre-hospital fibrinolysis is not possible, but this is the FAIR study that has shown that some benefit is there in mortality in terms of thrombolysis, but that is the pre-hospital thrombolysis. Anyway, the composite endpoint favoring the primary PCI compared to thrombolysis. Even though the mortality rate is less, but the least mortality was in the primary angioplasty group, and again, this is the major benefit. Now, if you compare all the major clinical trials like Prague, CAPTIM, DANIM 1, 2, and Prague 1, 2, that there is that all the trial favors the reinfarction, favor the primary PCI, stroke also favor the primary PCI, death, which is the major advantage in terms of any kind of benefit you want to give, that favors the primary PCI. So that meta-analysis conclude that even when transfer to an angioplasty center is necessary, the primary PCI remains superior to the immediate thrombolysis. And this is again a different case scenario where ST elevation, the patient presented to the non-capable center, and then compare between the fibrinolysis versus the patient sending for the primary PCI. Even you are sending patient for primary PCI, then also you can reduce mortality by 5.1% compared to 7.7% if you do fibrinolysis. Now, the last thing, that is new concept, that culprit versus the complete revascularization, and that you can do only by angioplasty. and that in all the major trial, these are the small number of study, but really gives a great benefit and great reduction in all cause of composite death and MI. And that shows that the complete revascularization could be beneficial once it allow for the fast reestablishment of the blood flow, increase the viable myocardial area, and leading to an improvement of the left ventricular ejection fraction, and the reducing vascular complications through the lesser need of punctures, reduce hospitalization time, and prompting an increase in cost effectiveness. So I would like to conclude that the primary PCI is superseded by many reasons, like higher rate of patency, greater number of TIMI3 flow, lower rate of recurrent ischemia, reinfarction, emergency repeat revascularizations, and almost negligible intracranial hemorrhage, and the massive mortality benefit and less hospital stay, and is more effective rather than if you lot of contraindications and complications with fibrinolysis and the least effective therapy. Thank you so much.
Thank you, Mukesh. Very well in time. Now I would like to request Dr. Aman Chaturvedi, if you are ready, sir.
Yeah, I am ready, sir.
We'll take discussion afterwards. Dr. Aman Chaturvedi, are you ready, sir?
Can you see my slides?
Yes, sir. Just put it in slideshow mode, sir.
Can I be seen?
Slideshow, sir.
It is in slideshow mode.
Yeah.
So I am very thankful to the organizing committee that they asked me to present a topic today, and I am very grateful to Dr. Mukesh that he presented such a nice talk today. He is really a nice speaker. So I'll be arguing on the Indian scenario of the current situation. If we think about the Indian scenario, then why will we prefer a pharmacoinvasive strategy over a patient in such a case? So what do the guidelines suggest? The guidelines suggest that if the patient is reaching the hospital in the time frame of 120 minutes, or the door to the balloon time is less than 120 minutes, then only you can think about doing a primary PCI. Otherwise, if it is possible, you should think about doing a fibrinolysis followed by a primary PCI. This is the 2017 guideline, what it is saying. And what is the time to muscle? The more time you waste in doing any intervention or any revascularization strategy, the more muscle you are wasting. Even if you thrombolize a patient in the ambulance, or if you do pre-hospital thrombolysis, or if you do a thrombolysis just in the ER, that will be saving the muscle. So that will be more beneficial for the patient. So this is my second point. So if you see this graph, it is showing that how much time is going on and how much muscle and how much mortality is increasing. So as the time is increasing...
Excuse me, Dr. Aman. We are not able to see your... You should go with the slideshow. Can you see 62% written down in your computer? Just behind that is a slideshow mode. Go to the slideshow mode first. We are seeing your first slide only.
You are able to hear me or not?
Man, you are audible.
Okay.
But you have to keep slideshow on. That is not there. Slideshow.
Yeah, you can, if you're not able to do Aman slideshow, you can just keep showing like this, maximize your screen. If you can do that, you can just click on the right side, lower bottom. It shows slideshow. Just go to the right on the bottom side. There is a slideshow.
Sure, but I don't think it is coming over there.
No problem. You can maximize it and just show these slides. No problem. Just go ahead for the sake of time.
Right.
Yeah.
Okay. So if you see this slide, you can see that as the time increases, there will be increase in mortality and there will be increase in death if you don't revascularize the patient. And the other thing is that go to little time. Go to little time is hardly marginable, or it is means it hardly takes almost 20 seconds with the newer anti-thrombotic agents. And newer, it will take 30 minutes to, and that will increase the chances. See the hospital mortality percentage, thrombolysis in less than 30 minutes, it will be almost 7% mortality in the. Then the other thing counts is that the total ischemia time. So in our case, the patient has presented almost like 2.5 hours after the chest pain started, and his first medical contact and the admission time, documentation time, and everything, if you account, then it will take around 4 hours, 4 to 5 hours for completing everything. If you don't go into documentation, then also it is going to take around 3 hours. So then also, if you do thrombolysis just before doing a primary intervention, then it is going to be beneficial. Now, if the patient has a cardiologist, or there is any complicated procedure going on already in the cath lab, or there is a TARI going on, or there is a primary PCI already waiting in the ICU, then what other options do we have? We don't have any other option. We have to go for primary thrombolysis, then we have to think about going for a angio and rescue PCI. Then the fifth point will be efficacy and patency of thrombolysis. So many trials have shown that the newer antiplatelet thrombolytic agents like tenecteplase, reticlase, and tissue plasminogen activator have almost the efficacy of 85% to 70%. So, and they will give almost like TIMI 2 to TIMI 3 flow. And following that, we can go for angiography and angioplasty. So then also our time will be saved in that, because giving an injection will almost take like 10 seconds for giving a bolus of tenecteplase or reticlase, and continuous infusion or a second bolus of tenecteplase or reticlase. In our patient, the TIMI score is like 6. So his mortality is around 16% in 30 days. So it will be very hazardous to keep a patient waiting just for the documentation or other parts of the thing. Another issue is that there are no reflow or no flow phenomena happening without thrombolysis. Even if you do a primary PCI, take the patient for stenting and take the patient for plasty or anything like that, even after crossing the balloon or even after crossing everything, there is no flow in the LED. So what you can see in this picture is there is no flow in the LED. If you thrombolize this patient, there will be increased flow, there will be reduced thrombus burden, and you have more chances that a nice an example of a patient in whom primary PCI was done and there was no reflow, and high ischemic burden was there and there was no reflow, and almost like there is scarred anterior myocardium, and you can very well judge that there will be a poor prognosis in the coming months. Then the other thing is that pathophysiology of STEMI. In our current scenario, what we have been given, it is a 23-year-old young male. The most common etiology will be a plaque rupture. And the plaque rupture will be mostly a red thrombus. It won't be a white thrombus, it won't be a stagnant thrombus, it will be a red thrombus, and it will respond very well to thrombolysis. And many of the cases it has seen till now, they will have a resolution of the thrombus burden and a resolution of even the stenosis even after thrombolysis. Even if you do thrombolysis and do a CAT after that, the patient will be very well and there won't be any plaque or any stenosis, any residual stenosis left. The sixth point will be cardiac necrosis in STEMI. The more time you waste, it is a basic concept. The more time you waste, the more muscle you lose. So if you lose the muscle, there is no sense of doing any intervention procedure at this. So the basic thing is that as soon as the patient is coming, You don't have time, just thrombolize him. Take him to the cath lab, take him to the interventional area and do whatever you want to do with him. But thrombolize him. Clinical trials, like Mukesh sir was pointing out many clinical trials, what he had said. There are many clinical trials which are supporting pharmacoinvasive approach also. So this was the first trial. The fast MI trial that also showed the same thing, that even if you do thrombolysis, even if you do thrombolysis followed by PCI, they are going to have almost like the same outcome. Then the Gracia 2 trial came, it is also showing like the primary endpoint of the study was composite of death and which showed significant combination, that major bleeding and no significant difference between the two groups. Then transfer AMI study came, then Minneapolis study came, then STEAM study came, then STEAM conclusions came, STEAM update came. What the update says that as the time increases, like if you see this graph, you can very well recognize that as the time increases to the doing a reperfusion strategy, either be it thrombolysis or either be it primary PCI, as the time increases, you are going to have a decrease in LV function, and primary PCI won't be better if you don't do time strategy. As soon as the time increases more than 50 minutes to 60 minutes, it is not going to be better. So better it is going to be that you do a pharmacoinvasive study. Finish trial came. Then some few other points is easy to administer. Major adverse complications are not that much. We say that there are too many major adverse complications, but it is less than 1% with the newer agent. Then relatives and social issues. You take time to explain to the relatives the cost issue, the explanation to the family members, the explanation of mortality and morbidity. It takes time. And it decreases chances of multiple stents once you do a CAG. And even if you want to send a patient for a bypass, you don't have to, like, the culprit vessel will be re-thrombolized.
One last 15 seconds, please.
Yeah, I am done, sir. I am done. I am done, sir. Hello? Hello, sir?
Thank you so much. He has done very well within time. I would like to request Dr. Sandarbh Patel for the next lecture. Dr. Sandarbh Patel.
Yes, sir. Good evening. Thank you very much, Dr. Jayesh, sir, and the organizing committee for allowing me in the initial session of this wonderful conference. Sincere regards to Dr. Kamal Sharma, sir. Excellent talk by Mukesh bhai and Aman bhai. And also I saw a little bit of hint of Dr. Kamal sir's style in Mukesh sir's presentation, which is, of course, saying this is an honor for Mukesh bhai, as we have seen Kamal sir many a times. Coming to the topic, my point today would be TPA is preferred agent for lysis in COVID-19 era. So a lot of my points have been covered by Aman bhai very nicely, that why we should go for thrombolysis. So my work is pretty easy. I may have to skip some slides also. The background of the patient we know. With TIMI score of 6, this patient doesn't fall into much high risk category. That is one important point in a STEMI when we consider whether to go for thrombolysis or PCI. So this patient is not in a very high risk category. Thrombolysis can definitely be considered. He is a young male. Most of the time we see that in young male there is high thrombus burden. Sometimes when we do angio in place like UN Meta where it is thrombolized outside, there may be thrombus burden. We give tirofiban, thrombus goes away. That part is important. It's a COVID wave scenario. In Omicron, many people are comfortable with cath, but in last year, April, May, when I was sometimes willing to do a cath lab procedure, but there was no cath lab which was taking COVID patients. So that is also important thing. Of course, as I said, there is no cardiogenic shock. The time duration part has been taken care well by Aman Bhai and Mukesh Bhai. As this patient is at 2.5 hours in hospital, perhaps by within completion of 3-hour time span, we may be able to give fibrinolysis. As we know, at every 40 seconds, someone, even young or older, may be dying with cardiovascular disease. Now, COVID-19 is a very highly contagious disease. Proximity dependent spread is there, with aerosol maybe remaining viable for hour to many hours also. So once you take such patient in cath lab will be out for few hours. So other non-COVID patient may suffer. Most screen for COVID-19 tests may be negative up to 30%. And 80% of patients of COVID infection are asymptomatic. So even in Omicron era, when this is not severe, but 80%, many asymptomatic patients may be there. So COVID screening is definitely necessary. So all this COVID screening and part will also take its own time, and time is muscle with ST elevation MI. So we should ideally do COVID screening. At the same time, we should not do delay. What can be done? Thrombolysis is ideal. Infection of healthcare workers is a major concern. Italy, Spain, USA, India, a lot of healthcare workers get infected. Even with PPE, personal protective equipment, total safety is not there. Confirmed or suspected case to cardiac cath lab will expose all the staff and also disable the laboratory, as I said. Necessary delay after hospital arrive occur due to the triage protocols during this COVID-19 era. Important focus of today's debate should be PCI is definitely preferred. I also agree. And being an interventional cardiologist, anyone would agree that PCI would be preferable to thrombolysis when there is a cath lab there is a hospital like SAL with this patient where beautiful cath lab is there. But COVID-19 scenario, triage protocols, and also other things in Indian subset, we have to explain the relative in detail, window shopping, opinion, this, that takes 1, 2, 3 hours. Why waste those 3 hours and why not thrombolyze? Early reperfusion is always important than the mode of reperfusion. Immediate fibrinolytic therapy in emergency department may mitigate the system-based delays, of course. And then we see various recommendations from various institutes across the world in COVID scenario. So patient without thrombolytic contraindication first start intravenous thrombolysis, and then segregation to various department, ICU or ward can be done. Reperfusion of STEMI in COVID era. Expert dealing with COVID-19 epidemic in China or place like USA have been preferring over last 2 years the fibrinolytic therapy. Blanket policy of PPCI in all patients will be hard to justify, and there are operational issues. So scenario or situation in these times favor fibrinolytic strategy. Of course, this part we have seen high risk, low risk, preferably thrombolysis, and if contraindications or if failed thrombolysis, we can go for PCI. In stable patient with confirmed or suspected COVID-19, PCI can be deferred as first-line therapy, and fibrinolytic therapy should be given. Patients in one study who were treated with PCI, 21% had stent thrombosis. So this factor should also be considered or kept in mind. Patient is fully vaccinated, but still he could have got COVID. And whenever there is COVID, in compared to routine scenario of 1% stent thrombosis, this 21% stent thrombosis, and stent thrombosis in a young patient would be even more devastating than the actual disease. How can we balance this? So isolating the patient, confirmed or suspected, starting the thrombolytic therapy would be preferable. If acute STEMI is there, as said, consider fibrinolytic therapy if no contraindication. If we see the current recommendation, low risk patient considered for thrombolysis. In high risk patient, if all PP is available, healthcare personnel are well versed, then only primary PCI is preferred. Now, this was about what should be the treatment, primary PCI, thrombolytic therapy, in my view. Then which agent? Fibrin specific agent should be preferred. Fibrinolytic therapy more frequently aborts the myocardial infarction, less personals are required, and up to 75% will achieve the infarct artery reperfusion. Even TIMI 2 flow or 1 flow will help salvage a lot of myocardium. Fibrinolytic therapy and pharmacoinvasive strategy offer a logical, effective, and simple alternative to complex ergothelium of primary PCI. This is, of course, factors favoring the fibrinolytic-based pharmaco-invasive approach, non-PCI or even PCI-capable setup in COVID scenario, low risk, no absolute contraindication to fibrinolysis, and less than 3 hours, which is our case. And if we see in-hospital mortality rate of patient hospitalized with acute MI, before and during COVID pandemic period, then in COVID pandemic period, the mortality is higher side. In STEMI patient, fibrinolysis is comparable in hospital and 30-day primary composite endpoint in COVID-19 pandemic era. So previous data, we have to forget and see what is the scenario in COVID. So there fibrinolysis is also comparable. ACCHA also says that appropriate timely use of some form of reperfusion is important in COVID pandemic, rather than the best ideal choice as per guidelines of previous times. So proposed redesigning of STEMI care would be dual goals: timely reperfusion and healthcare personal safety. Hospital without PCI capability, go for fibrinolytic or transfer if contraindication. PCI capability is there, then if PPE and all is available, you can consider fibrinolytic for low risk stable patients. Rapid and safe discharge can be there, and monitoring the system performance is also important. So this fibrinolytic agent would be class 1A or class B, fibrin specific agent particularly. If we see about TPA or the alteplase, it has shown superiority in mortality reduction compared to placebo, also compared to streptokinase. Accelerated TPA followed by heparin reduces the mortality and a significant reduction in mortality. As we know, alteplase is more fibrin specific, direct plasminogen binding, no allergic reaction, plasma clearance is quick. Thrombolysis for acute MI, alteplase versus thrombolysis is, as I said, superior. If we see the major trials of comparing 30 to 35-day mortality among fibrinolytics, then we see that alteplase in Gastro 1 is superior. We know that reteplase is not showing any particular superiority to alteplase. So over and all, fibrin specific agent like alteplase when given with accelerated regime would be much interesting. So in nutshell, COVID-19 era, early reperfusion with minimum risk to the patient as well as healthcare worker is the way forward. Safety of healthcare worker is utmost important when already burdened healthcare infrastructure, as we see in Indian scenario. Time-tested fibrin-specific agent like TPA serves the purpose, achieving the coronary reperfusion in high majority of patients with time conservation. Thank you.
Yes, we can go ahead with the discussions. If there are any questions, it is being said that here in this case particularly, patient has been fully vaccinated 3 months back, and now he has developed antiviral myocardial infarction. So the antibody level of COVID, spike protein antibody level must be good enough. This is what I understand. So now you can discuss out.
With due respect, sir, I read one article, over more than 1 lakh patient study of AstraZeneca and some other vaccine. They had studied Delta and the previous strain. Then at 9 to 12 weeks, the antibody level after 2 doses of vaccine had gone significantly down, and they had studied the patients who had double vaccinated and hospitalized. So hospitalization course with COVID was as severe as non-vaccinated people. That's why the booster recommendation and all. So I guess 3 months is an important time period where perhaps some antibody level may have waned, and this patient is a potentially COVID infected patient.
And then the other point that I like to say is that a young patient having a MI, acute level MI, it won't be like a heavy plaque burden or something like that. It will be some plaque rupture or having a acute thrombotic event. I think it will be better in the scenario.
Yeah, Sandar, I know Sandar Bhai and Dr. Aman has put their thought in a right way. And I would like to say that this patient, young patient, massive anterior wall MI, already reached to your center with the cath lab facility, then definitely there is no doubt in giving a major benefit, and that is the major advantage, that is the death benefit that you can give by angioplasty. Second thing, now initially when COVID started, that time everyone was to do the procedure and all the cath lab intervention was quite difficult. But after giving all as COVID doses, vaccination doses and booster dose, and I know that our even the medical officer are well aware of how to screen the patients and how to go ahead with COVID protocols. And this is just in minutes, not in hours. That can be done in minutes also. So I think that without any doubt, angioplasty is the better option. But I would like to be happy if this patient is far away where the cath lab facility is not there. Then definitely the pharmaco-invasive has role. And that time you can choose that therapy, fibrinolysis therapy followed by angioplasty.
Sir, what about thrombolizing the patient initially and just bringing him to the cath lab?
Then it would be then it would be a facilitated PCI if you are doing in a cath lab center, and the results for that are not that great. They support pharmaco-invasive where the cath lab is not there, it's quite far away. And definitely we usually see high thrombus burden is there, and after successful lysis also, as sir has also told, that reocclusion rates are quite high, and we do need to do an angiography because thereafter we can identify the anatomy, and also we might need intravascular imaging like IVIS studies, OCT, to identify how the plaque is.
Yeah, that is fine. That is fine. If you do thrombolysis within 3 hours, if you do PCI or if you angiography, that is also means it is advisable to do a PCI or an angiography within 3 hours of thrombolysis. That is fine, but if you do immediate thrombolysis, won't it reduce the thrombus burden? Won't it reduce the ischemic muscle? Won't it reduce the myocardial damage? And in a young patient like this, I think it will be advisable to have a initial thrombolysis followed by a PCI.
Yes,
I also agree to Aman bhai very much that nowadays we don't talk about door to balloon time also even. We talk about door to wire time. So the concept is that when the wire is passed, there is some whatever flow comes with it, passing the wire through the lesion, that will also help salvage the myocardium. So I guess the good thrombolytic agent like tenecteplase or reteplase or even alteplase, that will establish enough flow majority of times to akin to at least passing a wire. So that will salvage a lot of myocardium. And most of the times we do follow COVID protocols. Now the way we almost gone and all is fine. But otherwise, even doing a rapid antigen test spends 20 minutes. So we'll almost go beyond 3 hours of thrombolysis period and all. And in young patients, when certainly also thrombotic burden is high, and if COVID situation there, it will be even higher. But then many times during our procedure, if thrombus is we are not able to tackle the thrombus, we give intracoronary thrombolysis also. So doing all that thing in place of that, why not give IV thrombolytic?
Yeah, that's what I am saying.
So the only thing that I would like to mention or ask rather to Dr. Raman and Dr. Sundar is that the guidelines, if we just stick to our own clinical vignette, the case given to us, the patient is a young male, his saturation is 96%. Nowhere we have been given a situation where he's supposedly infected from COVID. The standard guideline norm should be that if there's a non-PCI center and if you can thrombolyze the patient within 10 minutes, that is the gold standard. You can do that. You have a PCI center. There is no reason not to take this patient up for PCI purely for an academic discussion. If we are having a cath lab enabled center, and even if we consider it to be a COVID situation, the recent registries of AHA and Euro PCI, they mentioned that if you manage COVID patients and if your healthcare personnel is sufficiently trained enough to manage a COVID patient with STEMI, PCI is the gold standard from the limited registry. There are no guidelines purely for the fact that the world is evolving, learning about the COVID itself. So we'll take a while to come up with a guideline with reference to COVID. But if we just stick to the current situation, best clinical vignette, my personal say would be more for PCI than fibrinolysis. If you recommend fibrinolysis, I would love to know why and exactly not a PCI for this particular patient.
Look, I'd like to give an explanation that like we don't stick to the guidelines completely. Huh? We don't have to stick to the guidelines. Guidelines are made and they are changed every day and the other day. They will change. So what our experience is and what the experience of other cardiologists are saying that if you repurpose the patient, it is going to save the muscle. No? It is a simple concept.
Okay, my simple question to all of you is that it's a COVID thing. So do you think that D-dimer values would matter in taking that call? If this patient was, say, with a D-dimer of, say, 5,000 versus, say, 500, and he's come to you right away, and if you can do a point of care D-dimer, would you still consider a TPA as a better strategy? Because now we have data for that as compared to analytics versus PCI, primary PCI, if the time delay is going to be huge. Open to all the chairpersons, moderators, as well as speakers.
Absolutely, sir. As you pointed, if you have evidence of probably having a concomitant hypercoagulable state or a thrombotic burden that is going to be affecting more than just cardiac issues or coronaries, TPA would be a better strategy given the circumstances. If not, there is no reason not to take this particular patient up for PCI.
PCI would be first choice from my end also. And regarding the time delay, it has been specifically mentioned in all the trials, whether it's stream registry or whether it's in Tamil Nadu registry, where in Tamil Nadu they use STK, but the time window was less than 3 hours. And most of the patients thereafter were did underwent for coronary angiography and angioplasty thereafter. So only lysis will not help. And obviously, if it's a young patient, we have to assess the coronaries. If it's an plaque burden, I have seen we see usually patients presenting with such scenario, and then there is evolving thrombosis. It comes to LMC. Patients can go into sudden cardiac arrest. Definitely, bolus lytics are the preferred strategy, and definitely tenecteplase and alteplase much more are preferable compared to retiplase. But one thing, even in the periphery, when these agents are transferred, the risk is whether cold chain is maintained or not. Many of the times they come and they don't work. STK is not available in USA, and most of the patients, when we go on the topic of debating about the cost, well, PCI can be done at a cost of less than 1 lakh. When you go with retiplase and all, the costing of hospitalization, everything comes around 60 to 80,000 in between if the patient has to be managed, even without angiography sometimes. So cost, if you are using newer agents, won't be the issue when going for primary PCI.
Even though if you thrombolize the patient and then guessing that this patient may do well, even though there is a risk of arrhythmias and all other things. So rather than guessing, you are giving a definite result in primary PCI, and that is the definite treatment.
And the point is definitely well taken. If it is in a periphery setting where cath lab is not available, we have to lyse the patient. In fact, in stream registry, yes, it was documented that when you are transferring the patient, tenecteplase was used. It was a preferred agent. But yes, again, the problem is with the cold chain. And suppose if it was an inferior wall MI with shock, you can't go with STK upfront. If RVMI is there, patient will deteriorate. You have to go only with the bolus lytics agents at those cases.
So all I also wanted to mention was on the similar lines that rather than going for a facilitated PCI and then eventually converting it to a rescue PCI, it's better to go upfront with PCI in this particular situation.
True.
Yeah, but definitely if it's in periphery, you have to go with lytics. Don't waste time. And then transfer to a PCI capable center. And as Dr. Vijay sir has clearly told in his inaugural lecture that we are doing only primary PCI in 5% of the cases, that has to change. That scenario has to change. So effectiveness of primary PCI is not yet demonstrated very effectively in India, though cath labs are coming all over.
Getting a D-dimer level also will take time. I think we can't wait for the D-dimer level to come and then decide whether to thrombolize or go for primary PCI. As a interventional cardiologist, all of us, I think, in PCI enable center, primary PCI, and in non-lytic hospital, lysis.
True. And I just want to share.
I think Aman and Sundar be like Bazigar. Haar ke aage bhi jeet hai. You are interventional cardiologist. You have to do primary PCI.
I would just like to ask all the interventional cardiologists, what is the use of thrombosuction devices? Because it has been 3 years, I've done more than 1,000 angioplasties. Around 1/3 of the cases are primaries. Till now, I didn't have no reflow when I have done the patient with proper, if you are using GP2B inhibitors and with newer drugs like ticagrelor or prasugrel is there. So cases of no reflow are comparatively less as compared to earlier when you used to see around 2016 or 17 when they were
True, because if you see in last 5 years, hardly almost 4 or 5 times I have used thrombosuctions. Rest of the time, the things solve with just a plain balloon only. So you are right. The use of thrombosuction is drastically reduced. Even with newer drug like cangrelor, that is also a wonderful drug. We can use in the primary PCI, and that is also a new edge.
I'd like to add a point that the use of thrombosuction has reduced from class 1 indication to class 2, class 3 indication. So you don't have to do thrombosuction. It is like almost like contraindicated to do thrombosuction even in heavy thrombus burden.
So I think our discussion is almost over because we have a speculated time. So during that time, sufficient discussions have been made. When we meet again, we will have further discussions on the same topic. Now I would like to go to bout number 2. Thank you so much to all my speakers and and we are thankful to all chairmen also who have participated.
Thank you so much, Kamal Bhai and Jay sir.
Now I would like to request Dr. Gaurav Gandhi for the second bout, Dr. Sanjay Wagani, Dr. Keval Kanabar. They will be doing as a chairmanship, and the moderators are Dr. Jitendra Anand, Dr. Devang Shah, and Dr. Ronak Bhai. I would like to request Dr. Gaurav Gandhi to kindly introduce the speakers. We have 3 speakers, and the topic is on atrial fibrillation, NOAC. Dr. Ronak, you can introduce the speakers. Dr. Ronak Shah. Dr. Ronak Shah. Dr. Gaurav Gandhi. Okay. The first speaker is Dr. Sunil Thanvi. He is going to talk on dabigatran as NOAC. That is the most widely studied in this scenario. Dr. Ronak Shah, would you like to introduce Dr. Sunil Thanvi? You have to unmute, Dr. Ronak. Kindly unmute your laptop. You are muted. Hello.
Can you go to the next slide? Please finish the introduction of all. Next slide.
Dr. Sunil Thalve is a professor, head of the Department of Cardiology, former assistant professor in cardiology at the Research Center for nearly 6 years, former in charge of professor in cardiology at various centers, even in Karamsad Medical College also. Huge reoperative skills, and he doesn't need any introduction amongst the cardiologists or even physicians also. He is very popular, soft spoken, and very clear about his ideas. So I would like to request Dr. Sunil Thanvi to kindly go ahead and give his excellent talk. Another is Dr. V.S. Prakash. He is from Bengaluru. He has done his MBBS MD medicine cardiology, MD medicine from BMC Bangalore, and he has so many research papers under his belt. He is heart specialist and interventional cardiologist at Bangalore. Currently works as an MSR Ramnath Narayan Hospital as a coronary interventionalist, and patients with heart rhythm disorder. He has been expertise in this. Heart failure patients, including biventricular failure. He has received so many awards. I would like to go to the third speaker is Dr. Jay Shah. Dr. Jay Shah doesn't again need introduction because he's very popular. I know him since years together, and he is a very good, wonderful interventional cardiologist, DNB, DM. He's practicing at Mithakali and founder member and vice president of Krish Heart Institute. He's a teacher in DMB cardiology students in HCG, attachment at Star Hospital and Life Care Institute. He has so many fellowships, national, international, and he is principal investigator in so many studies. He's a co-investigator again in multiple studies. He's a coordinator in CREATE study. Apart from that, he is a wonderful singer. I remember him like that.
Thank you, sir.
I would like to request Dr. Sunil Thanvi to go ahead and deliver a lecture. If he is not available, in that case, Dr. Jai Shah, please. Dr. Jai Shah.
Okay. So good evening, sir. This is Dr. Jai, and thank you so much for giving me this opportunity. Can I share my slides?
Yes, sir.
Yeah. Okay. Are you able to see the screen now?
Yes, sir.
Yeah, okay, fine. So thank you very much, all the dignitaries, Dr. Jayesh Trivedi, sir. And first of all, I would like to congratulate Dr. Kamal Sharma for a unique platform of having a debate on a particular clinical scenario. And the role which has been given to me is a 77-year-old male, 60 kg of weight with a history of paroxysmal atrial fibrillation, without having a past history of any embolic phenomenon, but having a Chadwick score of 4, Hesbled score of 2, had underwent angioplasty of right coronary artery for acute infravall MI with 95% proximal lesion almost 2 years back, that is, to be very precise, 22 months back. Apart from the standard care of therapy, the optimum anticoagulation strategy would include, and in this case scenario, I would like to stress upon the scoring system. To be very frank, when we are talking about a very elderly population, like more than 75 years of age, we need to be a little more vigilant regarding the overall scoring system, because the whole area or the whole treatment strategy would depend on that particular thing. So here, if you look at the Chadwick score, which has been given 4, but if you look at the overall scoring system, the history which has been given to us, you can make out that the score would have been 3. So either the patient is having diabetes or hypertension along with the underlying history. And if the patient is having hypertension, then definitely the Hesbled score cannot be 2. It will directly going into the Hesbled score of 3. So this is possible only if you have a coexisting hypertension, whereby Hesbled automatically becomes 3, which is suggestive of high bleeding risk in an advanced age population with a stable coronary artery disease, where angioplasty was being already been done around 22 months back, and patient is having an episode of atrial fibrillation, even though it is a paroxysmal in nature, because we all know that elderly population, the overall prevalence and the incidence of development of atrial fibrillation as the age progresses from 2.8% in more than 65 years of age to 6% in more than 75 years of age to almost 10% in more than 80 years of age. So here I would like to give a due importance in this particular case scenario to 1, advanced stage; 2, the possibility of development of futuristic incipient incidences of atrial fibrillation with special emphasis on the Hesbled score of 3. And that would be, I would be more concerned regarding the prevention of stroke in an elderly population because of the risk of development of atrial fibrillation or in recurrence of atrial fibrillation. Because we all know that angioplasty has already been done. It has already been past 1 year of an ACS event. So the patient is now in a stable condition. And the trade-off between bleeding and the ischemic events is such that there is a temporal component to the balance of bleeding and the ischemic risk. So how can we titrate the patient to have a high ischemic risk and low bleeding risk, or high bleeding risk and low ischemic risk? In our patient case scenario, I would say that after doing an angioplasty, after 22 months on eventful, the procedure, and the patient is elderly, I would say that this patient is at low ischemic risk but as high bleeding risk, because even though the Hesbett score is 4, where the chances of stroke development may be high, but at the same time, Hesbett is 3, where the bleeding risk, which is a cumulative one, and it is higher with the long term, and a patient who is receiving a potent antiplatelet therapy, definitely the chances of bleeding would be there, and you need to be very, very vigilant in preventing any sort of bleeding from the for that particular patient. Now, I'm going to give you certain important points why I'm saying so, and why I'm choosing apixaban, which is available in 5 milligram and 2.5 milligram twice daily doses in elderly population. Now, which are the risk factors here? High stroke risk because of the Chadwick's 4, high bleeding risk because of the Hesbett 3, presence of CAD with a past history of PCI. So patient is in a stable CAD, or you can say that after a COMPASS trial for rivaroxaban, patient is in a CCS condition. But elderly population, you need to just be very sure about the overall risk and the benefit ratio as compared to the ischemic and the bleeding risk ratio. Whenever we are talking about an elderly population, and here we are talking about advanced age, that means the age more than 75. Multimorbidity, the history of, or rather the possibility of development of risk of fall, risk of GI bleed, polypharmacy, vascular dementia, frailty, all these things are taken into consideration when we prescribe any sort of oral anticoagulation therapy in an elderly population. And one thing is very clear, whether it is Aristotle or any other trial like RELY or Rocket AF, all this trial of all these NOACs, they have proven one thing, that factor Xa inhibitor, they are definitely superior than warfarin. So vitamin K antagonist is definitely out of question when we are talking about non-valvular AF, whether it is safety or whether it is efficacy. So in that case, when we are talking about summary of major efficacy and the safety outcome, even though we know that there is no possibility of head-to-head comparison, it does not exist between rivaroxaban and apixaban, even though there are fewer recent articles which are being published between rivaroxaban and apixaban, which we are going to see in subsequent slides. Apixaban is, as of now, probably the most safest molecule available as far as the oral anticoagulant drugs are concerned, whether it is stroke and systemic illness where efficacy is concerned, or there is a presence of major bleed or ICH, or for that matter, even an all-cause mortality, which is better as compared to warfarin, and which has been proven with apixaban. And if you look at the Aristotle trial, you can see that the net clinical events rates are low with apixaban as compared to placebo, where the standard care of therapy is concerned. Whether the stroke or the ischemic embolization, all-cause mortality, major or all-cause bleeding or intracranial bleeding is concerned, as the age advances, the benefit increases. In elderly population, I think apixaban has definitely proven its efficacy as well as safety. Now, coming back to the data where all this comparison is being done between Riva, Debi, and apixaban, the data of major 4 trials, they've shown that in an elderly population, the efficacy is same as that of dabigatran, or for that matter, even in an elderly population, it is same as that of even rivaroxaban. But what about the safety? Safety, here you can see that in more than 75 of age, rivaroxaban is inferior, or it is not producing a better benefits as compared to apixaban. And apixaban, more than 75 of age, definitely it is going to give you a better result, irrespective of the age criteria. The safety profile or for major bleeding is definitely better with apixaban as compared to dabigatran. Dabigatran, we all know that it is very efficacious as far as the stroke prevention is concerned in 150 milligram dose. But what about the safety? In elderly population, more than 75 of age, dabigatran produces more bleeding, which is statistically significant. So that is the reason meta-analysis of multiple randomized control trial have proven that in an elderly population, which NOAC is better as far as the comparison is concerned. I think apixaban scores over rest of the NOACs. And now coming back to some of the real world evidences in elderly population, we all know that Aristotle is the trial which has shown data about elderly population having better benefits with apixaban as compared to warfarin, whether it is stroke or systemic illness or major bleeding is concerned. Apixaban and other NOACs, they are being managed or maintained irrespective of the doses, where you are using reduced dose, either with dabigatran, rivaroxaban, or apixaban. even with the reduced dose of apixaban and of dabigatran, they are associated with a lower risk of major bleeding as compared to a reduced dose of rivaroxaban. And with that, if you look at the meta-analysis in a patient with all this category with more than 75 years of age and having an episode of atrial fibrillation, apixaban offers to be a better combination as far as the efficacy and the safety data are concerned. There's a very important or a statement which has been given as an international consensus validation of FOTA label. FOTA means fit for the aged classification, where this class was being given an A class, which is an indispensable, and that has been given to apixaban. And that is the reason more than 75 years of age, all the experts, they are saying that apixaban 5 mg twice daily should be the first choice, followed by second choice of rivaroxaban 20 mg or dabigatran 110 mg twice daily. Here we all know that the patient is at high risk of stroke because the Chadwick score of 4, but at the same time, patient is having a Hasbard score of 3, which makes him at a higher risk of bleeding as well. So irrespective of a Chadwick's score or a Hasbard score, there's a data which is shown by Dr. Lopez that apixaban had less net clinical events with lower chances of development of stroke, systemic embolization, or major bleeding. Irrespective of this scoring system, apixaban has reduction in the major bleeding and in the intracranial bleeding as well. Now, when we are comparing rivaroxaban versus apixaban with underlying major ischemic or hemorrhagic event in patient with atrial fibrillation, you can see that even with a reduced dose of apixaban, it is going to give you the best benefit possibility as compared to rivaroxaban, whether it is ischemic or hemorrhagic complication. And whenever we are using standard dose, then also apixaban scores over rivaroxaban in this particular study design. Another important point which was being studied very recently in December 2021, which was being published in JAMA, and that was being done by Todd Mean. And it has shown that the data for apixaban, as far as the safety is concerned, they are superseding, or rather they are having a much better benefits as compared to rest of the molecule, and especially rivaroxaban. Effect of apixaban versus warfarin as far as the safety is concerned, I think in CAD cases, definitely apixaban scores over rest of the vitamin K antagonist or molecule. And in nutshell, if I wanted to say that apixaban had 55% and 60% low risk of association of GI bleed, which is more common with dabigatran and with rivaroxaban. Yes, sir. Yes, sir. It will take hardly 1 minute now. In the very elderly population, and that is the reason I think apixaban scores over rest of the molecule. And as we know that elderly population, they are developing or they are at more risk of development of altered EGFR, where even there is no dose adjustment is required as per the underlying EGFR. And that is, these are some of the benefits which we are seeing with apixaban. So with that, I would like to end my talk, and I would say that one thing is very clear, that how can you titrate the therapy? How can we stratify the risk for the underlying patient? Here we are talking about a patient who is 77 years of age, elderly population with Hasbard score of 3 and an increased chances of development of atrial fibrillation. The dose which is not requiring a multiple titration and the dose which has already been proven is apixaban as compared to rivaroxaban. Whenever we are using rivaroxaban in such type of scenario, then rivaroxaban in which dose to be used, that is also an area of debate, which I am going to give after the talk of rivaroxaban and dabigatran respectively. Thank you so much.
Dr. Jai, we would like to request Dr. V.S. Prakash sir to please go ahead with his presentation. We'll take discussion afterwards.
Yeah. Thank you. Thank you. Thanks for this kind invite. I thank Dr. Kamal Sharma for having me on this wonderful conference. And I think I would share my slides. Yeah, just a second. My slides are visible, sir?
Yes.
Yeah, thank you. Thanks, sir. I think I with due respect to my previous speaker, I think he did a wonderful job really establishing the importance of apixaban in this kind of situation. I will not go into the case scenario because he did elaborate on that, but I'll just make a little deviation. His emphasis was on the elderly and the risk of bleeding. let us see whether we have any other way of looking at this patient. I would kind of mention that what is more important here, one second, let me just move my slides. Yeah. That's my disclaimer. And yes, he did emphasize on, see, one important thing here is the Church-Vaskar 4. Another important thing was diabetes. And we have underlying coronary artery disease, PCI, and an elderly, right? We understand that. Now, let us look at the RCTs, which are our major support for Novax versus warfarin. If you look at this patient, elderly with a Church-Vaskar 4 and a diabetic, which RCT represented this person very well? It was the Rocket AF. Rocket AF had 40% of patients being diabetics, and the Church-Vaskar score was 3.7. So we understand that now we have evidence with regard to rivaroxaban in this subset of patients. Diabetic patients, see, why are we worried? Diabetic patients who have AFib have higher risk of death and cardiovascular events as compared to those without AFib. 61% increase in the relative risk with deaths and cerebrovascular events. We have not spoken about that at all. What does the Rocket AF tell about this? Very clearly, if you understand, rivaroxaban significantly reduced cardiovascular death by 20% in this subset of patients, diabetic patients. What about apixaban? See, the problem, apixaban versus diabetic versus non-diabetics, the risk of bleeding was more with apixaban, 3% per year versus 1.9%. So very clearly, ESC gave a warning. ESC 2020 said bleeding risk with Novax is similar in diabetics and non-diabetics, except for apixaban. So they put a marker, red herring there. Now, why are we talking so much about diabetes? See, we know diabetes has injurious effects. Macrovascular complications, coronary artery disease, peripheral vascular disease, stroke. Not only that, microvascular complications, nephropathy, neuropathy, retinopathy. What is that got to do with our particular molecule, rivaroxaban? We have a large real-world data, the RIVA-DM. More than 1 lakh patients were evaluated in this real-world data, where they not only looked at the safety, efficacy, as also the risk of bleeding. They also looked at renal outcomes, limb outcomes, ophthalmic outcomes. That is the evidence we have with rivaroxaban. Here, very clearly versus warfarin, it scored in all these aspects, not only efficacy and safety, also in reduction or worsening of renal function, of major adverse limb events, and diabetic retinopathy. Hazard ratio, if you see, has always been on the lower side compared to warfarin. So we understand emerging data suggests that rivaroxaban may help not only to reduce stroke, but also diabetic complications in patients with AFib throughout the body, all the micro and macrovascular complications. Let's look at now underlying coronary artery disease. What do we have here? We know this patient has undergone PCI 22 months back, so he is a stable coronary artery disease. And what does that mean according to the ESC 2020 guidelines? All that you need to do is use a single agent and Novak. You don't need dual antiplatelets or even a combination therapy. Do we have evidence for that? Yes, in the form of the AFIRE trial, which was conducted in Japan. And here again, these patients had undergone PCI or CABG more than a year prior to the trial. And here very clearly, rivaroxaban standalone versus a combination therapy clearly stood out with regard to reduction in the major bleeding, and also efficacy-wise, it stood up with a hazard ratio of 0.72, again establishing we have real-world evidence working for rivaroxaban. Age is a very important factor. My respected opponent did mention what evidence do we have with regard to age. Again, Rocket AF had the maximum number of patients beyond 75 years of age, 44%, versus apixaban was only 31%. And so what does this show? If you look at the elderly people more than 75 years of age, if you're looking at all-cause mortality, if you're looking at non-hemorrhagic strokes and life risk of bleeding, all this again, patients in the elderly more than 75, rivaroxaban did better compared to the younger, clearly showing that rivaroxaban is safe in the elderly and probably performing better compared to the young. So back to our case, in such a scenario, rivaroxaban is the most evidence-based NOAC because we have enough data. And not only that, also widely used and having consistent results. So my backing would be for rivaroxaban in this particular scenario, patient being diabetic, having multiple complications, undergone PCI, we have maximum evidence with rivaroxaban. Thank you.
So can I make one point, sir?
So we will take it afterwards.
Okay,
Thank
fine.
you so much, sir. Kindly be with us because we will have a discussion afterwards.
Sure,
I would like to
thank you.
request Dr. Sunil Thanvi to please present his case.
Yeah, thank you, Dr. JHB. Yeah, hi Kamal. Congrats for a very nice conference. I think it's a very nice concept, this bout thing. I'm here for the first time, but I'm really impressed by the way things are going. And I think it's a very apt topic to discuss about because we have so many NOACs now. This particular scenario that has been given to us is a very day-to-day sort of a situation wherein we face such patients and we need to take a call as to what would be the best option in these patients. So I'll be pitching in for dabigatran today. I've heard Dr. Prakash and Dr. Jay, and I'll be putting my thing forward for dabigatran. Next slide. I think when we talk about dabigatran, it's one of the most widely studied NOAC till date. We have been using it for donkey years now. And I think in various scenarios, it has been studied. And it has always come out trumps, whatever data has been there for this particular molecule. Next, I'm not going into the case details because I think they've been discussed very well. But the point is, he's an elderly male, has undergone an angioplasty about a couple of years back, and he is at high risk of stroke with a moderate risk of bleeding. Now, if you look at the read-all PCI that was there, you can see most of the patients, maybe nearly 77% of patients, which were less than 70 years of age in Japan, but less than 80 years of age in USA and rest of the world, were on dabigatran 110. And while dabigatran 150, 99% of patients were there. If you look at diabetic status, again, they were in the range of 37, 38 to 40%. So it was quite a decent number of patients in diabetes too. And of course, the CAT score mean was roughly around 3.7 to 3.8, which again goes with this particular case. And the modified Hesselberg score was around less than 3. So I think this is an apt indication what we're talking about. Nace indicator PCI was there in about 52% of patients. And DES was placed in about 84%, which is a normal practice that we do in today's world. Next. So 3 points next. Next. So there are 3 points I need to highlight as far as this case is concerned. Next. Now, when you look at the various pointers that are there, we are looking at age now. And if you look at, either major or clinically relevant non-major bleeding, if it is a patient less than 75 years or more than 75 years, we can see that the data as compared to warfarin is almost the same. If you're looking at death or thromboembolic phenomena or inflammatory vascularization, definitely less than 75 years, it favors dabigatran. More than 75, there's some data for benefit towards warfarin, but it's still a very gray zone. Next. Next, we are looking at renal impairment, which is not, next slide. Yeah. Renal impairment, again, as we see that at a create clearance, which is a 32 less than 50, which may be quite common in these elderly patients, especially if there's a diabetic. Nobody has talked about this. And even if the create clearance is, less than 50, and there is a 32 less than 50, still dabigatran would be the drug of choice that we might use as compared to rivaroxaban or even apixaban for that matter. Next slide. Acute coronary, next slide. So in acute coronary, again, if you look at major or non-major bleeding, in ACS or non-ACS, dabigatran 150 definitely has a better outcome as compared to warfarin. While even for death or thrombotic phenomena or unplanned revascularization, dabigatran again is superior as compared to warfarin alone. Next, to look at the PCI complexity, whatever the complexity that the patient is in, the data is very clear that even with a low dose of dabigatran dual therapy, or whether it's a high dose dabigatran 150 milligram twice a day dual therapy, still is much better than warfarin triple therapy as compared to, in various complex situations, whether it's clinical complexity or whether it's procedure complexity. In other case, dabigatran has found to be much more beneficial as compared to warfarin alone. Next. Next slide. Yeah. So this shows the time to first event in days. Dabigatran 50 milligram dual therapy, dabigatran 110 milligram dual therapy, and warfarin triple therapy. You can see that the event rates are much less as with dabigatran as compared to warfarin triple therapy patients. Next. Next slide. Yeah. So overall, if you look at redual PCI, there was significant reduction of major bleeding events without compromising ischemic events, and the patient profile typically, as we see in this, is high risk of stroke, high risk of bleeding, elderly, BMI, even if it is on the higher side, will still help. ACS, PCA complexity, whatever stent type, renal impairment, diabetic patients, definitely dabigatran still has an upper hand. And other consideration, choice of P2 inhibitor, whatever it is, previously on VKS, still we can give. Time in therapeutic range, whatever it was, and of course, presence of proton pump inhibitors. Still, this shows that dual antithropic therapy with dabigatran is still superior as compared to triple therapy with warfarin. Next slide. If patient develops risk of increased bleeding in the future, needing reduced dose of NOAC, what to do? The patient has a GI bleed, but still requires an anticoagulation. Next slide. Can we go down on the dose of any other NOAC? If you look at the recommendations, if you look at the data, this is from the European Heart Association, Rhythm Association, 2021, which clearly says NOAC at standard dose, there are only two things that they can give. One is dabigatran 110 milligram twice a day, and of course, apixaban 5 milligram twice a day. Rivaroxaban reduced dose is not really indicated when you need to cut down on the doses. Consider dabigatran 110 milligram twice a day. Other dose reductions are off-label and not studied in unselected patients. Reassess alternative strategy for stroke prevention. Maybe we can think about a left ventricular occlusion, but we cannot really consider going down on dose of other NOACs. So this is again where dabigatran helps you, where you feel that the dose needs to be reduced for clinical event rates. Probably this is one molecule where we may not hesitate from going down to from 150 to 110 and still give the benefit that the patient should be getting. Next slide. So this is a slide which says that even at 110 milligram, as compared to warfarin, the event rates are much, much less, and therefore the patients will still benefit if the patient has a lower dose. But with other NOACs, this is not the case. So I think this is again one area where dabigatran definitely helps us in continuing the molecule, but at a reduced dose and still giving the benefits. Next. Danish history of comparison of low dose and NOACs very clearly showed us that apixaban 2.5 milligram twice a day demonstrated a trend towards higher rates of ischemic stroke or systemic embolism versus warfarin. Next. Reduced dose of apixaban and rivaroxaban showed increased mortality versus warfarin. Next. When talking about any bleeding, in fact, dabigatran 110 twice a day was the only molecule which showed significantly less bleeding events versus warfarin. Next. So I think the data is very clear out there that, in patients like these who are on antiplatelets, who are frail, who are diabetic, elderly, who might be having underlying renal issues, probably giving even a low dose of dabigatran would still be beneficial as compared to other molecules. Garfield AF, a very classic study, which looked at various factor inhibitors versus dabigatran versus VKS and no NOAC. So it was almost a similar subgroup we have chosen for this, and the data very clearly said. Next slide. That as compared to VKA, NOACs overall showed significantly lower rate of major bleeding and all-cause mortality, while for non-hemorrhagic stroke or systemic embolism, the rates were almost similar. But if you look at dabigatran, major bleeding was less, non-major stroke or systemic embolism was almost at par, and all-cause mortality was definitely the least as compared to other molecules. Factor Xa included all the other 3 molecules. So vis-a-vis other molecules, any NOAC, no NOAC, VKA, factor inhibitors, Garfield have clearly showed that dabigatran was much superior as compared to other molecules. Next. So are all NOACs the same? We are coming to the end of this debate, and this is a slide which very clearly tells us dabigatran 150, dabigatran 110, rivaroxaban 20 or 15, and apixaban 5 or 2.5. If you look at the dosing frequency, of course, RCT's major bleeding versus warfarin, you can see reduction was 20% with dabigatran, apixaban is 29%. ICH was warfarin, again, huge reductions are seen with dabigatran, while not so great with other rivaroxaban or apixaban. Stroke system embolism versus warfarin, again, it is huge with dabigatran 150 milligram, but not so with other molecules. And ischemic stroke versus warfarin, again, dabigatran 150 milligram definitely shows much more superiority as compared to any other molecule. Next. So in a nutshell, superiority of molecule is not at all a concern. I think, dabigatran is one of the best molecules that has been studied in this particular, patient subgroup, and it has given us the best possible safety and efficacy data. Now comes the crunch point. We have talked about reducing the doses. What if the patient bleeds? What if you need a reversal? Is there any reversal agent available for any of these agents? No, it is only dabigatran for which we have a reversal agent widely available. And within 1 hour, even in Ahmedabad, you can get the molecule and reverse the bleeding and get the patient operated, or for whatever reasons you need to reverse it within an immediate span of time. Next. Next.
Sunil, last 1 minute.
Yeah, sure, sir. Just a couple of slides more. An FDA or analysis of more than, 5 lakh patients, standard dose of NOAC and warfarin very clearly showed that dabigatran 150 milligram, ICH, thromboembolic stroke, death, definitely very significant. Next. Versus rivaroxaban, again, you can see it is quite significant. Next. Versus apixaban, again, it shows significant reduction for ICH, similar for stroke and death. So I think this for increase for apixaban as compared to dabigatran alone. So next slide. So these are real world evidence now. And of course, the reversal molecule, adagrasib, that is available widely. And whenever it is required to be reversed, we can definitely do that. It's specific targets dabigatran, helps the patient, saves lives. Next. So to conclude, I would say that results from RCTs consistently demonstrate a favorable safety and efficacy profile in both the doses, patients with AF. Real evidence supports the safety and effectiveness of dabigatran, both the doses, providing insights into treatment outcomes in everyday clinical practice and varied settings. Evidence from studies like Garfield AF adds to the evidence of significant benefit and safety with dabigatran in the real world. So I would not hesitate in keeping this patient on a dual antithrombotic therapy with dabigatran, either standard dose or lower dose, depending on the clinical scenario, and give the patient benefit of both PCI as well as the patient being on for stroke prevention. Thank you very much for a patient listening. Thank you again.
Thank you, Sunil. The forum is open for discussion. We'll have a discussion for 10 minutes time. Please go ahead. Yes, Jay, you wanted to tell something.
Yeah, I just wanted to tell one thing, that the history which has been given to us as a part of BOUT, it has not mentioned diabetic status. Number one. Number two, so as you have assumed that patient might be having diabetes, because we all know that once the patient is having diabetes, the whole scenario would be changing. Then the chances of more high thrombotic risk will be there. But as Kamal Bhai has specifically mentioned, that patient is 77 years of age, then past history of angioplasty, 22 months back, with Chadwick score of 4. But with Chadwick score of 4, you cannot have a Hesberg score of 2. It has to be 3. And there, the choice which has been left as per the scoring system is just the hypertension. Now, whenever you have a hypertension, you are more concerned about the development of future stroke because of the underlying atrial fibrillation in a stable coronary artery disease patient where already angioplasty is being done for a single vessel disease 22 months back. And that is my area of debate, that in that scenario, would you like to choose the most safest molecule available, which does not require any dose titration, which does not affect with any dose, drug interaction or food interaction? Likewise, you see it with dabigatran. And as far as the advanced age is concerned, because age itself is an independent risk predictor for high bleeding in such type of scenario. So I
think I always keep this loophole in the scoring, and Jay always picks it up and harps upon it. So I always keep one of the risk factors missing.
Sorry to intrude. I think Dr. Jay, you're missed. He's a diabetic.
No, it's not been mentioned.
Please read.
No, he's diabetic. He's diabetic.
The history which has been given to me.
So my question.
Same thing. If we are talking about the same patient, he's a diabetic. You very clearly mentioned a diabetic, 77-year-old diabetic patient.
But the history which has been given to me in
then we may be
I think that diabetic, non-diabetics does make a big impact. We understand, and what Dr. Jay is talking about, he's right, because the first debate when it was framed did not mention diabetic, and Dr. Prakash, we added diabetic. We also acknowledge that. So there might be an overlook, but understanding the science that
we are all winners.
So the point is well driven, that if the diabetic or hypertensive, the scenario does change between the science. It's not all NOACs become equal, number one. Number two, I would like to ask all three of you, including Dr. Thanvi, how does this 22-month change if you make it, say, 2 months or 12 months or 6 months in the current guidelines of NOACs? Because if you had a patient you've put a stent and the guidelines do talk about taking it off, then does the table tilt more in favor of dabigatran, Dr. Thanvi, if this was more recent as compared to apixaban? Just for the sake of igniting further discussion.
Yeah, see, I am totally sold up on the idea of the fact that for a dual antipsychotic therapy, I think dabigatran has the best possible data available to date. And I think that is where it scores. Coming to Jay's point, I think I'm sure he missed that the first sentence mentions a diabetic male. Nevertheless, but still, elderly patient, diabetic patients, post-ACS, if you look at whatever indications are there, dabigatran has been studied very extensively, both in randomized trials as well as real-world scenarios. And it has been very clearly shown that at 150 milligram, it is the best molecule to prevent systemic stroke or embolism as compared to any other NOAC available. So if you're talking purely about, cutting down on stroke and systemic embolism, I think dabigatran is a drug of choice that should be used. Right now, coming to the age, 77, actually 80 is the cutoff, right? More than 75, 80 is actually the cutoff. This is a 77-year-old male. Again, it's a gray zone where, I would still err in favor of giving a dual antibiotic therapy with dabigatran, given the fact that even if he bleeds, you might cut down on the dose, you might have a reversal agent on hand, which might help. Of course, we assume that, it may not be needed, but you never know. The patient might need to go again for a repeat procedure, may require, surgery, may land up with an ICH because it's hypertensive. So see, there are certain considerations that are there in my mind. So as far as I'm concerned, I'm still sold on the idea of giving dabigatran. I definitely agree apixaban has good data in elderly patients, but I think the balance is there for both. And I wouldn't hesitate in adding dabigatran as far as I go.
So ultimately, it will be left to the physician's discretion.
I agree. It's a totally individual approach.
It's an individual approach, and
see, honestly, there is no head-to-head comparison.
Yeah, it will never happen, sir. It will never happen.
Yeah. See, the thing is, all comparison with warfarin and all which you are trying to. We do understand that each molecule has its own kind of niche indication. We have more data with diabetes with regard to rivaroxaban, and more data with regard to elderly with regard to apixaban. And GI bleeds, definitely, I think dabigatran and apixaban score over rivaroxaban, that issue. But, I think it's a kind of individualistic decision that, as you say, finally, it's patient specific. And then you need to take a call as to which molecule would be the best here.
Yeah.
But one thing is very sure that all these AF patients, we as a fraternity as well as physician, they have to use this scoring system just to make sure that, this is why we are choosing this molecule. So the scoring system is really going to be very helpful for deciding the strategy.
So I'll add a caveat to that, Jay, saying that all of us have to use NOACs first.
Yes,
then talk
correct.
about
No,
still-
yeah, unquestioned. There's absolutely
That is
no
beyond doubt. It's
no
been
debate
proven.
on that.
Yeah, there's no debate on it.
There's still so much of hesitancy regarding using an oral anticoagulant in AF patients. Most of them would be either be on aspirin or clopidogrel for whatever reasons, and ultimately we are not giving the benefit of anticoagulant to this patient. So on this forum, I want to make it very clear: aspirin clopid doesn't work. It has to be anticoagulation. The molecule will depend on the clinical scenario, patient-specific characteristics, and individual preference. I would add to that because we are all comfortable with a particular group of molecule. So I think
the most important aspect, I agree with you, is the risk of stroke is more worrisome to a patient rather than the risk of bleeding. So obviously, you definitely want to use a drug which is more efficacious with regard to, but at the same time, and we also understand the risk of bleeding is much lower with NOACs versus warfarin in all the three NOACs. So I don't
the point is well taken that NOACs are going to be the main cornerstone of therapy. So warfarin we need to forget. As Sunil B has told, aspirin and clopidogrel we need to forget the role. And after 1 year, I think it's better that we need to go ahead with the monotherapy. of NOAC.
Perfect.
So I think there is a consensus about the anticoagulant therapy, NOAC. Thank you so much, sir, all speakers and chairman and co-chairman. Now we will go ahead with the next topic.
Thank you, everyone. Fantastic
Thank you,
debate.
Thank you so much.
You would like to add something?
I think Devang Bhai is saying he is more confused at the end of the talk. So can somebody summarize, chairperson?
Devang said that
I think when you have a lot of debaters who end up with putting their points, so Devang Bhai is saying he is more confused. So chairpersons, Gaurav, Sanjay, Keval, you want to summarize?
They left long back.
So I think what the conclusion I am trying to draw is that if you're dealing with an acute C event where you need to be choosing DAPT in the acute setting, probably dabigatran is weighing heavily. Diabetics, you have more data for rivaroxaban. Renal failure, you have more data for rivaroxaban. Apixaban is definitely safest, no doubt about it. If you're looking at somebody who's got high Hess blood and you have to position it, probably that. This case scenario has mixture of all three, and that's why we actually created this debate. Dr. Devang Bhai, I hope I'm clear. Yeah, so now he says that he is very clear. Thank you very much. Thank you. We move to next session. Bye-bye. Thank you.
Devang has clarified himself. He is clear now. Thank you, Devang. Now we will go to the next topic. Thank you so much to all my speakers and chairman.
Thank you.
We'll go ahead with the bout number 3. For that, I would like to invite Dr. Alap Patel, Dr. Dinesh Raj, and Dr. Amit Chaudhary as chairpersons. And the moderator will be Gyanendra Singh, Dr. Mustafa Rangwala, and Dr. Anand Patel.
And Dr. Sankit Saraiya as the chairperson.
And Dr. Sankit Saraiya. Okay.
Yeah, over to Dr. Alap, Dr. Sankit, and Dr. Amit to introduce our speakers. Next slide, please.
I would like to request Dr. Gyanendra Singh, I think he is already there, to introduce the speaker. Please, Gyanendra. Or Dr. Anand Patel. Anand, you are also there.
Dr. Alap?
Yeah.
Kindly introduce the speaker, please.
Yeah. Dr. Abhishek Tripathi is working as an interventional cardiologist at Zydus Hospital Zydus Hospital Ahmedabad. He has done his MBBS in 2002 from GSV Medical College Kanpur and done MD from BG Medical College Ahmedabad in 2007. He has done his DNB cardiology from Batra Hospital and Medical Research Institute, New Delhi. And presently, he is associated as consultant cardiologist at Narayana Multispecialty Hospital, Ahmedabad. Worked as a junior consultant cardiology at Batra Hospital and Medical Research Center, New Delhi for 1 year. He also had the experience of assistant professor of cardiology at Nizam's Institute of Medical Science, Hyderabad from April 2012 to May 2014. So our next speaker is Dr. Sarath Chandra. Dr. K. Sarath Chandra is one of the most experienced international cardiologists from India. He had completed his DM from PGI Chandigarh in the year 1989. Currently, he is working in Hyderabad. He is one of the early international cardiologists of India and did first device closure of congenital heart disease in Hyderabad, and also the first case of rota in 1994. He has performed thousands of coronary angioplasties and has special interest in the lap intervention. He has performed coronary intervention abroad, even in China and Vietnam in 1998 and 2004 respectively. He was the chairman of the National Intervention Council of India during the year of 2008 and 2009. He was the editor of Indian Heart Journal from 2012 to 2014. He was the president elect in 2017 and president of Cardiology Society of India for the year 2018. Our next speaker is Dr. C.K. Pandey from Mumbai. He is the gold medalist throughout his UG and the PG career. He has done the fellowship in international cardiology, FSCC, FSCI, FESC, FCSI, FIA, FISC, and FICC. He has done his electrophysiology from Brisbane, Australia, from 1993 to 1997. He is the recipient of many awards like Fellowship Award in 1995, Olympian Health Award in 1997, Rashtriya Man Seva Puraskar in 1999, and National Prime Time Award in 2016. He has up to 100 publications in various national and international journals, and he has delivered more than 500 lectures in various national and international conferences. He has received the Inspiring Cardiology of India Award by the Economic Times in 2020. Currently, he is the Vice President of Indian Academy of Echocardiography, and currently he is working as the Consultant Cardiology and Head of the Department of Cardiology in PG Hinduja National Hospital, Mumbai.
Thank you, Dr. Ala. We would like to request Dr. Abhishek Tripathi to start his topic.
Yeah, thank you. Thank you so much. So I need you to allow me to share my screen. Am I audible?
Yes, sir.
Yeah, I'm not allowed to share my screen probably.
Sir, now you can share your screen, sir.
No, it's not showing. It's just showing whiteboard. So it is.
You've already started sharing, Abhishek. We can see your screen.
Okay.
You started. Now it's again disappeared.
Fair enough. Is it visible?
No. Now it's not. It was and then it disappeared. Can you try sharing again?
Okay. Let me try it again. Is it visible?
Sir, you can choose whiteboard.
Yeah.
You have to choose your PPT, sir.
Yeah, I'm choosing my PPT.
No.
Can you see now?
No,
it's just showing a white screen.
That's what I'm saying. It is.
No, that's the blank white screen. Just try to change the slides.
This one?
No, it doesn't move. It doesn't move, and it's just a blank white screen. I think you, Neelam, can you help him out?
Sir, first of all, you open your PowerPoint, then.
I have already in my screen. I have already opened my PowerPoint.
So you
okay, in that case, we can request Dr. Sarath Chandra to start his topic, please.
Yeah.
Meanwhile, they can. Okay.
Is it visible now?
Yeah, it's visible now. Abhishek, go ahead, please.
Fair enough.
Make it full screen. It's visible.
Yeah, sure. So thank you so much. Thank you so much, Kamal bhai, for giving us this opportunity. And the most difficult thing, you have put me against Dr. Sarath Chandra, under whom I was under training in Nizam. So welcome, sir. Good evening. So the topic today, as we all have discussed, the patient profile, 65-year-old diabetic, hypertensive, 66 kg weight has been given very precisely more than 60. Age has been given less than 75 to make it more discussion oriented. There is history of coronary angioplasty to LAD with death 7 months back on clopidogrel aspirin with recurrent mild hematuria, maintained hemoglobin, workup revealed BPH. GFR remains around 60. So the now question is, patient who is already stable with some history of hematuria, bleeding, hemodynamically stable, no significant anemia. Patient on clopidogrel and aspirin within 1 year of angioplasty, should we change antiplatelets or what? Should we continue with aspirin clopidogrel or should we change? So my choose would be that why this patient came to follow-up. Was it a regular follow-up? Was there any ischemia, some worsening condition? Anemia was already mentioned, it was not there. So other consideration should be taken into picture. My take would be I would switch from aspirin and ticagrelor combination. I will touch the reason one by one. As we all know, the nascent platelets, reticulated platelets, they are higher in granules and they have very high reactivity than older platelets, and they are mostly associated with cardiovascular disease and events. If you see in healthy subjects, the number of activated platelets are not, and number of granule platelets are not that high. If the patient becomes unstable, like anstemy, and when progressing towards STEMI, the number of immature platelet fraction, it grows significantly high. Why it is important? Because we have to see which are the molecule available, which works more precisely on immature platelets, granulated platelets. If you see the mechanism of action of ticagrelor versus the thienopyridines, they're irreversible. They bind to ADP P2 Y12 receptor, whereas ticagrelor reversibly binds. So it is free to bind again and again to different ATP P2 Y12 receptors. Not only that, ticagrelor binds to P2 Y12 receptor as well as it inhibits ENT1 transporter. So what does it do? It inhibits the uptake of adenosine and makes it more and more available, which helps in cardioprotection, vasodilatation, further inhibition of platelet aggregation, modulation of inflammation. It also causes dyspnea and improve endothelial function. So we can see ticagrelor doesn't only act to P2 Y12 receptor inhibition, also it causes more and more availability of adenosine. So now if you see, I'll skip. So ticagrelor is the only molecule out of the prasugrel and clopidogrel which is not a prodrug. It doesn't need liver for activation. So it is not dependent on cytochrome P2 C19 system for its activation. And this is why it is important, because in Asian community, we have pleomorphism of the cytochrome P2 C19 enzyme. So because of the pleomorphism, some people are there rapid metabolizers, some are late metabolizer, and some are intermediate metabolizer. And depending on that, the availability of this thienopyridine varies from person to person in Asian community. Whereas ticagrelor largely remains uninhibited because of this cytochrome system. Here you can see, like if you see this thienopyridine versus the BD dose of ticagrelor. Initial binding, like when you have given the dose within 30 minutes, this binding is there in both the groups, thienopyridine as well as in ticagrelor group. In 12 hours time, what happens? That because of this repeat binding, a reversible binding, ticagrelor keeps binding to nascent and new nascent platelets. However, by 12 hours time, the nascent binding of platelets decreases in thienopyridines. And when this is the time when ticagrelor is given again. After 24 hours, once the peak effect of the dose is waning off, you can see again the binding of nascent platelets. Once those are uninhibited, that is besides the point. In acute ACS, once the nascent platelets are being generated again and again, the binding remains more complete with ticagrelor compared to thienopyridines. So ticagrelor is superior to prasugrel, as have been seen in pharmacokinetic data, that compared to prasugrel, if you see the non-reticulated site platelets, both are equally effective. But if you see nascent platelets, granulated platelets, ticagrelor is far more effective than prasugrel. However, these are the pharmacokinetic data. Now, once daily dose is insufficient in patients with high platelet activity. Here you see the prasugrel is being given daily dose. At the late part of the prasugrel dose, the activity of platelet activity again goes high. Whereas ticagrelor, even during late stage also, the effect of platelet activation is low. So this is to summarize, like the reversible binding is there with ticagrelor, not with thienopyridines, and it is active without metabolism, and the mean half-life remains around 7 hours for the active drug because there is no prodrug. So what is the confident factor like ticagrelor? When we are using ticagrelor, we are all using it without too much consideration. When we are using prasugrel, we always keep counting age less than 70, weight more than 60. There is no history of any stroke, trauma, or ICH anywhere in the past, even any kind of ischemic stroke also. While using ticagrelor, we don't see much. Even if patient is thrombolized just 4 hours back, we are using. Even if patient has been loaded with clopidogrel, we are using. So there is not much consideration, not much fear factor around ticagrelor as much as it is around prasugrel. So ticagrelor is a broad applicable antiplatelet, which can be used in ACS patient across the range, whether the patient is being managed medically or intervention, angiography, diagnosis, angiography has been done or not, his line of management has been decided or not. We can use ticagrelor invariably. In patients with moderate to high risk ACS patients, where the risk of ischemia is high, again, it can be used irrespective of the line of management. However, prasugrel is recommended only when the PCI has been decided, and the PCI only in the PCI setting, not in the medical management line. Now again, ticagrelor shows decreased CV mortality versus clopidogrel in plateau. However, prasugrel has not demonstrated decreased CV mortality. The MI risk was low in Triton TB38 and Trialgy ACS, but the CV mortality was not significantly lower. Again, the another benefit, ticagrelor can be used beyond 12 months, like in Pegasus TB54, it has been seen. It can be used in 60 mg BID up to 36-month time also. Prasugrel has to be used for 1 year. The data is for 1 year only. And ticagrelor shows less stent thrombosis compared to clopidogrel in RCT as well as real-world evidence also. So, as we have mentioned, ticagrelor can be used in wide range of ACS patients, irrespective of their line of management. However, in prasugrel, mostly in Triton TB38, if you see, it was being given in cath lab after angiography the diagnosis was known that if the patient doesn't need bypass, it was being given. And the contraindication, as I mentioned, we have to see the patient age. If it is more than 75, you can't use. If the weight is less than 60, ideally should not be used. In India, we are using 5 mg also sometimes. And contraindicated, if there is any previous history of even ischemic stroke is there, it is contraindicated. So we have to see all these things, but in ticagrelor, you need not to go for these. So this is just to summarize, like if patient is having ACS, there's no contraindication with ticagrelor, please use it. In prasugrel, you have to see the history of TI, stroke, need for CABG, coronary anatomy, medical management versus non-invasive management, weight, age, and all these things, pre-treatment with clopidogrel, prior thrombolized or not. So all these things you have to take into consideration before loading the patient with prasugrel. So it makes life easy with ticagrelor compared to prasugrel when you are starting also while managing in long term also. ACS guidelines, it has class 1 recommendation for patients to use ticagrelor in ACS patients with moderate to high risk of ischemic events. So in all patients with moderate to high risk of ischemia, it can be used. Ticagrelor can be used. Prasugrel is used only when the patient has been planned for PCI or in patient previous ACS who are not thrombolized, being managed medically and now coming up for angioplasty. Clopidogrel is used only once the ticagrelor or prasugrel cannot be used. Similarly, the latest ESC guideline, it mentions ticagrelor is preferred P2Y2 inhibitor irrespective of management study. As I mentioned, like if ACS patient is there, whether medical management, invasive, delayed, pharmaco-invasive, anywhere we can use ticagrelor. Prasugrel, once the PCI is intended, then prasugrel can be used. That time prasugrel, ticagrelor both can be used. But prasugrel, we have to make certain that it has been studied mostly in the PCI setting. So recommendations are there for the PCI setting only. And for other things like the DAPT duration for clopidogrel can be used beyond 12 months. Ticagrelor can be used beyond 12 months up to 36 months. However, with prasugrel, there is no data to use beyond 12 months. So if you see the benefits of compared to clopidogrel in plateau, the ticagrelor has been shown to decrease both composite endpoint of CV death and MI, as well as CV death individually and MI individually. However, in Triton TB38, the composite endpoint was decreased out of only reduction in MI. There was no reduction in CV death. The MI was significantly decreased compared to clopidogrel. So the non-CABG related major bleeding was high in both ticagrelor as well as prasugrel compared to clopidogrel. However, CABG related major bleeding was high with prasugrel. Fetal overall bleeding was high with prasugrel. It was not high with ticagrelor. Intracranial bleeding was not studied, not recorded in patients with prasugrel, so it cannot be compared here with ticagrelor. So it is approved for long-term, more than 12-month protection, as we just mentioned in Pegasus TB54 study. Now, coming to stent thrombosis, in plateau invasive, it was seen that in stent thrombosis, there was significant 36% reduction was seen in stent thrombosis compared to clopidogrel. Definite stent thrombosis, significant reduction, probable or definite, significant reduction, and in all possible, probable, definite, there was significant reduction was observed over 1 year period compared to clopidogrel. So the timing of stent thrombosis, like even till for the first 30 days, for first 1 month, in subacute stent thrombosis, there was 40% relative risk reduction was there. Up to 30 to 360 days, like late stent thrombosis also, 52% risk reduction was there. So this is the reason where we will consider, even if the patient is stable, if the patient is less than 1 year of angioplasty, patient is clopidogrel, you may still consider shifting the patient from clopidogrel to ticagrelor. Zero stent thrombosis was observed in patients with ticagrelor, while in clopidogrel, around 9% stent thrombosis was observed. This was a small study. Now coming to the bone of contention, the last study, ICER React 5, which pitched ticagrelor against prasugrel, and the prasugrel was shown beneficial as far as the MI reduction was concerned and stent thrombosis was concerned. But if you see this study in detail, you will find that in STEMI patient, both the group were randomized and they were loaded with ticagrelor prasugrel beforehand, before angiography. However, in ANSTEMI, ticagrelor was given beforehand. However, prasugrel was given after angiography once it was decided the patient is going for angiography. Now, angioplasty. Now,
last 1 minute, sir.
Okay, so I'll just finish. So if you see in this study again, there was out of 85 patients, 1.3% they did not receive ticagrelor. However, in prasugrel arm, 13.9% they did not receive prasugrel. So the exclusion rate was much higher in prasugrel group compared to ticagrelor. Finally, also if you see, around 1.1% were excluded from safety analysis. However, in prasugrel, 11.6% were excluded from safety analysis. So when the exclusion criteria is exclusive, number of patients was so big, difference was there. It can skew the entire result of the study. MI, again, we can see MI difference was there. Definite stent thrombosis difference was there. Primary endpoint difference because of these two factors were there, but death from any cause was same. Stroke was same in both the groups. And the bar, major bleeding, 3 to 5, was also same in both the groups. There's no major difference. So the major limitation of the ISAR React 5 was that this was an open label study conducted in 2 countries. However, Plateau was a double-blind placebo-controlled study conducted in 40 countries. There was a disparity between, if you see the endpoints, if you see the major study of prasugrel, like which was tritone 38 versus ISAR React 3, the ischemic event was 10.7% tritone 38. Here it was only 6.9%. However, as far as the ticagrelor is concerned, in Plateau as well as ISAR React 3, ISAR React 5, in both studies, the ratio, the percentage was same. It was 9.3 versus 10.2%. So somewhere, because of this open label kind of study and the randomization with sealed envelope and the quality of follow-up was also telephonic follow-up mostly, there was the bias cannot be excluded completely. This may be the reason where the ischemic events were probably reported lesser in ISAR React 5 for prasugrel compared to ticagrelor. Then again, for safety, normally it is considered the molecule which is potent anti-ischemic effect will have more bleeding. However, if you see here, the significant number of patients were excluded in prasugrel group, 11.6%, compared to only 1.1% in ticagrelor group. Before
you need to wind up.
Yeah. So I think if Sharad Chandra sir in any case going to include this ISAR React 5 summary, as we all know, ticagrelor has an ease of using. We can use it in any given number of patients. The number of contraindications are very less. Post-traumatized patient, already loaded with clopidogrel patient, we can use it safely. Irrespective of line of management, we can use in these patients. It decreases CV mortality, MI, as well as stent thrombosis compared to clopidogrel. So in my patient, in my choice, I will switch this patient from aspirin clopidogrel to aspirin ticagrelor. Thank you so much.
Thank you, Dr. Abhishek. Dr. Sharad Chandra, please go ahead with your presentation.
Yeah, thank you. Thanks, Kamal Sharma, for giving me this opportunity. Abhishek, my old friend at Nizam's Institute, I must say you've done a very good job in this with regard to this subject. Now let me share my screen. Okay. You're able to see my slide?
Yes, sir.
Okay. You're able to see the slide, right?
Right, sir.
Right. Okay. All right. You know, the case details that were given to me are slightly different from what have been given to Dr. Abhishek. I have been asked to speak in favor of prasugrel in this particular situation. So let us see what exactly are the case details given. Okay, right. Here you have a 65-year-old diabetic hypertensive who presented with ANSTEMI. Now, when you say a diabetic hypertensive, you are straight away saying it is a high-risk patient. His weight is 66 kilos, which is not an issue with prasugrel or with any of the other drugs. He had past history of coronary angioplasty to ostial LAD, which is a very important location, a rather dangerous location of the stent, which has been implanted in the past. The DES was put in the ostial LAD 3 years back, and he has been on clopidogrel and aspirin all these days. And now he presented with ANSTEMI, which means that there is some kind of a resistance to aspirin and clopidogrel. This itself is a very high-risk feature, as we all know very well. He gave history of 2 episodes of bleeding in stool, which is stated to be due to piles, but his hemoglobin has always been normal. Now, what is the importance of that? Now, we cannot really say what is the cause of the bleeding. We don't have more details. Obviously, this patient has to undergo upper GI endoscopy and later a lower GI endoscopy if there is a need? And did he have black colored stools or did he have fresh blood? Depending on that, you can take a call on which investigation you would do first. So, but at the same time, the hemoglobin has always been normal, which indicates that probably the bleeding which the patient had in the past has not been probably a major bleeding. And his eGFR is 60 ml per minute, which indicates that it is a fairly acceptable renal function. And we know between these three drugs, there is no issue in relation to kidney function when it comes to usage of any of these three drugs. In fact, with ticagrelor, it is said that if the patients had normal renal function, they did not show benefit with ticagrelor over clopidogrel as given in the old Plateau trial to which Abhishek was referring. So the question is, which P2Y12 inhibitor would we use in this patient? Okay, now let me show you a comparing table between the 4 P2Y12 inhibitors which are available in our market today. The clopidogrel, prasugrel, ticagrelor, and cangrelor, the last one to join the bandwagon. The clopidogrel and prasugrel are irreversibly binding agents, while ticagrelor and cangrelor are reversible. Clopidogrel and prasugrel are prodrugs, while the other two are not. The half-life is about 7 hours with prasugrel, and with ticagrelor it is 8 to 12 hours. Type of binding is competitive with clopidogrel and prasugrel, while it is non-competitive with ticagrelor. The route of administration is oral for most of these drugs except cangrelor. And we know clopidogrel can be given once daily or even twice daily. Prasugrel is almost always given once a day. Ticagrelor is always given twice a day. Now, onset of action is rather delayed with clopidogrel of 2 to 8 hours. On the other hand, with prasugrel and ticagrelor, it can start as early as 30 minutes, and with cangrelor within 2 minutes. Now, if you want to compare prasugrel to clopidogrel, the study one has to look at is the Triton TIMI 38. This is a fairly old trial, but it is a very modern trial in the sense it is a very properly done trial. It is more than 10 years or 15 years old now. And let us recollect the data of Triton TIMI 38. This is published in 2007, prasugrel versus clopidogrel in patients with ACS. This patient of ours is a case of ACS. And it randomized 13,000 plus patients, 6,000 to prasugrel and 6,000 to clopidogrel. And they were followed for 6 to 15 months. And the primary endpoint is death from CV causes, non-fatal MI, non-fatal stroke. Safety endpoint is major bleeding. Now, the results showed that the primary endpoint, which is a combination of CV death, MI, and stroke, is clearly in favor of prasugrel. 12.1 percentage points with clopidogrel and 9.9 percentage points with prasugrel. And the primary efficacy endpoint is what I just mentioned. Okay, now, if you look at stent thrombosis, there is a huge benefit in relation to stent thrombosis when it comes to usage of prasugrel. Significant reduction in the prasugrel group in the rate of stent thrombosis. It is 2.4% with prasugrel and 1.1% with 2.4% with clopidogrel and 1.1% with prasugrel, which is statistically significant. Now, look at this balance of efficacy to safety. And here again, prasugrel scores over clopidogrel. Major bleeding was observed in 2.4% of patients receiving prasugrel and 1.8% of patients receiving clopidogrel. Now, you need to look at the diabetic subgroup results in relation to Triton TIMI 38, because our patient is a diabetic patient. And you can see here, the prasugrel reduced the rate of primary endpoint by a much greater percentage point. It is almost 5 percentage points less compared to clopidogrel. So you have a diabetic patient, prasugrel clearly scores over clopidogrel when it comes to treating the patient by percutaneous means. That's what most of us do when the patient presents with an STEMI. It is 17% versus 12.2%. When the whole group is taken, of course, there is a benefit. But when you take this diabetic subgroup, the benefit is even greater and very glaring. Now, if you see the TIMI major non-CABG bleeds, there is no significant difference between clopidogrel and prasugrel. So prasugrel therapy in patients with ACS with scheduled PCI shows that significantly reduced rates of ischemic events, including stent thrombosis, increased risk of major bleeding, including fatal bleeding. But the overall mortality did not differ significantly between the two groups. Benefit was much more significant in diabetic patients, particularly if they are younger and male patients. Now, when we want to compare it with ticagrelor, obviously, you need to look at the data of ISAR React 5. Unfortunately, all these years we have been taught, and most of us interventional cardiologists believed that prasugrel is a more dangerous drug than ticagrelor. Rather, ticagrelor is a more safe drug. The push given by the marketing forces that be was much greater with ticagrelor, and therefore ticagrelor has become very popular all over the world, including India. And Indian doctors, as you all know, they play for safety more than anything, and that's how ticagrelor has been very popular in India. But the data from ISAR React 5 is what you should really look at it. There are limitations of ISAR React 5 as exemplified earlier by Abhishek, but let us look at the positive points of this particular trial. Intracoronary stenting and antithrombotic regimen, rapid early action of coronary treatment 5. Now, earlier we were always comparing plateau data with Triton data. This is not correct. You do not know really what is the type of patients that have been randomized, and comparing the data of one trial to another trial just because they have been compared to clopidogrel is not correct. The correct thing to do is to compare a trial, is to look at the data of a trial where ticagrelor is compared to prasugrel when their patients are randomized on one-to-one basis. And you can see here that this is an investigator-initiated, multi-center randomized clinical trial was conducted to compare the efficacy and safety of ticagrelor and prasugrel again in ACS patients, which is very relevant to the patient data that is given to us. Ticagrelor versus prasugrel in patients with acute coronary syndrome, published in 2019, very recent trial. Now you can see here that this is not a small trial. Once again, there were nearly 4,000 patients who were randomized in this, 2,000 to prasugrel arm and 2,000 to ticagrelor arm. And you can see here, prasugrel has scored over ticagrelor. The primary endpoint, once again, is a composite of death, MI, stroke, and safety endpoint being bleeding. And you can see here that cumulative incidence of safety endpoint, once again, there is not much difference. Prasugrel has nominal greater advantage over ticagrelor, but this is not statistically significant. The incidence of primary endpoint was significantly lower among those who received prasugrel than among those who received ticagrelor. Incidence of major bleeding was not significantly different between the two groups. Now, if you look at this data, the cumulative incidence of primary endpoint at 1 year, 9.3% versus 6.9% with prasugrel. A primary endpoint event occurred in 184 of 2012 patients who were randomized to ticagrelor and 137 of the patients who were randomized to prasugrel. And the cumulative incidence of safety endpoint at 1 year, 5.4% versus 4.8%. Now, to further look at the data of ISAR React 5, the primary endpoint, as I said, is 9.3 with ticagrelor, 6.9 with prasugrel.
Last 1 minute, please, sir.
I've taken much lesser time. Just give me a couple of minutes, but I'm almost close to completion. Death is lower with prasugrel. MI is lower with prasugrel. Stroke is nominally lower with prasugrel. Definite or probable stent thrombosis, once again, is lower. And the combined endpoint is clearly in favor of prasugrel. Bleeding, contrary to what many of us believed that it will be more likely to be with prasugrel, was not the case. When you really looked at it, the bleeding events were less with prasugrel compared to ticagrelor. Definite stent thrombosis also was nearly 50% less compared to ticagrelor. Now, among patients who presented with acute coronary syndromes with or without ST elevation, prasugrel was superior to ticagrelor with respect to composite endpoint of death, myocardial infarction, or stroke. Fewer myocardial infarctions in the prasugrel group than in the ticagrelor group. This is not just the data of ISAR React. You can see the data from some more slides, which I am going to show you. This is the regular trend that the chances of myocardial infarction are less in the prasugrel group than in the ticagrelor group. this is a sub-study of STEMI patients in the ISAR-REACT. ISAR-REACT included a wide variety of patients of ACS, but when you look at the STEMI subset of ISAR-REACT, ticagrelor was associated with higher incidence of myocardial infarction. Now, prasugrel is a preferred antiplatelet agent in primary PCI STEMI, diabetes mellitus with ACS, recurrent ACS while on clopidogrel, at risk for stent thrombosis. Now, out of these 4 criteria, 3 are easily correct in relation to our patient. He's a diabetic, he developed ACS while on clopidogrel and aspirin, and because the stent was located at a very important point, he may be running a risk of stent thrombosis or a severe in-stent restenosis, which may be making him more prone for events. So our patient clearly is a case for prasugrel than ticagrelor. I'm coming to the last couple of slides. This is a study from Leeds, UK. It's a real-world study which compared a huge number of patients who were treated with clopidogrel, prasugrel, and ticagrelor, and prasugrel is associated with a lower 30-day mortality compared to clopidogrel and ticagrelor. Now, this is another data from about this is a meta-analysis of 70,000 patients, of whom 40,000 were on either ticagrelor or prasugrel, and about 36,000 were on clopidogrel. And what did it show? It showed that prasugrel shows greater reduction of CV mortality by 15% and 18% compared to clopidogrel and ticagrelor, respectively. Prasugrel was more beneficial in reducing MI, MACE, and definite or probable stent thrombosis than ticagrelor and clopidogrel. 31% greater reduction in stent thrombosis than ticagrelor. I think since the time is nearly over, I will close my talk, and if any questions are there, we can discuss. Thank you very much.
Thank you so much, sir. We would like to request Dr. C.K. Ponde. Everybody, all speakers are kindly requested to remain in time because we will have international speaker also. They will be having problems otherwise. Please, you kindly understand, please. Thank you.
Just sharing my slides quickly. Are you able to see the slides?
Yes, sir.
Are you able to see the slides?
Yes.
Hello?
Yes, sir. Yes, sir.
Perfect, perfect.
Clearly, sir.
And can you hear me well? Thank you.
Yeah, yes, sir.
Yeah, I think we have heard 2 stalwarts here before me, and I hope that I make some my simplistic slides will make us some bit of sense in these slides which I'm going to show. So I think the case scenario, correct me, Kamal, if I'm wrong. 65-year-old diabetic, hypertensive, weight was 66 kg, EGFR was 60. He had a PCI with DS 7 months ago. I think Dr. Sarath Chandra was given some different case scenario. I'm not so sure. Was on DAPT with aspirin and clopidogrel and presents with mild hematuria. He's investigated, and the cause is found to be BPH. That is what was my case scenario. Am I correct?
Yeah, that's correct.
Okay, fair enough. So what we don't know, what was the clinical setting? Was that ACS or CCS? The PCI was done with ACS or CCS? And what was the complexity of the PCI? And whether he had single vessel disease or multi-vessel disease? Those are the variables which are blinded to us purposefully by our dear Dr. Kamal Sharma. So let me take frequency and prognostic impact of bleeding events in this ADAPT-DES study. 9% bleedings were genital urinary. And in the past 2 decades, the ischemic events because of better and better P2Y12 inhibitors have reduced from 18% to 9%, halved almost. But the bleeding has increased because of more potent P2Y12 inhibitors. DAPT, what are the problems with the DAPT? The problems with the DAPT are higher bleeding. Risk of bleeding is continuous and exceeds the ischemic events risk 30 days after the index PCI. Bleeding events increase the risk of MACE further, and any major bleeding increases mortality. So the case in question is not really about aspirin, clopidogrel, or ticagrelor. It's about balancing the risk of bleeding versus the risk of ischemic events. And that is the bottom line. So why bleeding increases mortality? Because major bleeding leads to transfusion. There is prolonged storage of transfusion leads to activation of inflammatory cascade. And of course, because of bleeding, you may land up in ceasing or stopping the DAPT for a short duration, exposing the patient to the risk of stent thrombosis. Now the main question and the fundamental question and the billion-dollar question here is, do we need DAPT beyond 6 months in a patient who had a PCI with a DS? Forget the setting. ACS, CCS doesn't matter. Do we really need that beyond 6 months? Guidelines say whether it is stable coronary artery disease or acute coronary syndrome, if you have a high bleeding risk or a patient who bleeds, 6 months of DAPT is just about adequate. You don't need to give DAPT beyond 6 months. So indeed, choosing the duration of DAPT was an art of medicine where the science did not exist until 5 years ago, until the stop DAPT trial came. But now we have science, and I will show the science. So when you compare ischemic risk versus bleeding risk, let us say you have done ACS, you have taken during PCI, preloading you have not done, etc., etc. You have done risk stratification, you have done bleeding prevention by DAPT intensity, PPI, counseling, etc. But the patient yet lands up in bleeding. When the patient lands up in bleeding like our patient has, you have to shorten the DAPT. So there is no question of continuing the DAPT in this patient beyond 6 months. You have to de-escalate the DAPT. So you cannot think of giving aspirin with ticagrelor. No question. That question doesn't arise. What question is, if at all monotherapy, which monotherapy? So, is our patient is at a high ischemic risk? So, if you have 2 or more of these factors, he is high ischemic. Our patient has only one factor, that is diabetes. So, he has moderate ischemic risk. Do we know the complexity of our PCI in this patient? No, we don't know. Whether there were 3 stents implanted, 2 lesions treated, total length was more than 60, we don't know that. Even assuming it was there. Look at this slide. Beyond 30 days, the risk of ischemic events geometrically comes down and reaches nadir by around 4 to 6 months. Whereas the bleeding risk remains so. It comes down below 30 days, but remains higher than the ischemic risk beyond 30 days. So the point here is, we are at 6 months after a DAPT in a patient who had no ischemic events in the first 6 months and has landed up in bleeding, which is, although minor, is recurrent. So now, when trials were done, comparing the hypothesis that 3 months was non-inferior to 12 months, succeeded. 3 months non-inferior to 12 months, succeeded. 6 months non-inferior to 12 months, succeeded. On the other side, when you tested a superiority hypothesis, that 24 is superior to 6 months, failed. 12 months superior to 12 months, failed. 30 months superior to 12 months, there was a lot of problem in this trial. We all know that DAPT trial. And then 36 months superior to 12 months, failed. So in this, the topic trial, replacing P2Y12 inhibitor with clopidogrel 1 month after PCI in an unselected group of patients, unselected, mind you, ladies and gentlemen, without considering the complexity of the index PCI, without knowing what kind of ACS, trop positive, trop negative. After 1 month, when the patient is 1 month event free, shifting the patient to clopidogrel from a more potent P2Y12 inhibitor reduces bleeding without any additional ischemic event risk. This trial opened the Pandora's box, and then trial after trial. Look at this. Telos AMI released in 2021 ACC, ticagrelor versus clopidogrel in stabilized patients with AMI. So patients remain stable for 30 days, shifted to aspirin clopidogrel. What happened? The bleeding risk came down. The cumulative incidence of composite endpoint of death, MI, stroke came down. So the conclusions was, in AMI patients, no adverse events after de-escalation. Stop DAPT trial showed among patients undergoing PCI, 1 month of DAPT followed by clopidogrel monotherapy compared with 12 months of DAPT with aspirin and clopidogrel resulted in significant low risk of composite cardiovascular and bleeding events. Mind you, these were not the patients who bled. These were the patients who were otherwise stable. Irrespectively, they were shifted to clopidogrel monotherapy. And here, there is a patient in my plate who is bleeding, recurrent, although minor bleeding, hemoglobin is maintained, and the cause is BPH, not a sinister cause. Host exam trial. aspirin versus clopidogrel for chronic maintenance therapies. What happened here? The aspirin had higher event rates, bleeding wise, and higher event rates, ischemic wise. Now, Dr. Tripathi might come and say, why not ticagrelor monotherapy? Let me compare Twilight. Look at the Twilight bleeding risk. 7.1% tica versus aspirin and 4% tica alone. Whereas clopidogrel alone, the bleeding risk was 3.7%. I agree that these were high-risk patients, much higher-risk patients than the TELOS AMI trial. However, the conclusion was clopidogrel monotherapy as compared to aspirin monotherapy significantly reduced the risk of composite all-cause death, non-fatal MI, stroke, and readmission also due to ACS and BAG type 3 bleeding. So please remember, don't dump clopidogrel yet. Don't dump clopidogrel yet. You can escalate, you can measure your bleeding risk versus ischemic risk by this very simple flowchart in your clinic or in your cath lab. What I will do in this patient. If the setting was of ACS and a very complex PCI has been done, like left main or LAD-D1 bifurcation with decay crush, etc., I would probably continue this DAPT, which is going on, aspirin and clopidogrel. There is no need to escalate the P2Y12 inhibitor here because 6 months the patient had no ischemic event, no stent thrombosis. And I also know the cause of bleeding is a minor bleeding, and the cause is not sinister like CA or GI cancer or something like that. Otherwise, I will shift to clopidogrel monotherapy. That will be my take. So my final slide is, we know we have versatile tica here. We know we have aggressive clopidogrel here, prasugrel here, but the king will still remain the king, and that is clopidogrel. Thank you very much.
Sir, we would like to keep this forum for open discussion.
Yeah, so the scenario had changed. I don't know, somewhere, Dr. Sharat Chandra. But anyway, the important thing was to understand two aspects. One was single antiplatelet versus dual antiplatelet. Can we have the slides, Neelam? So beyond what time we can stick to one? And then if we are sticking to one, which one of the three? So Dr. Sharat Chandra, your take, if it was supposed to be, say, only prasugrel, why not? Please unmute yourself, sir. So you're muted. Dr. Sharat Chandra?
Okay, I'm here. Now, what is the question? Did you say, can you just repeat the question?
Yeah, if it was not for a dual antiplatelet, just a single antiplatelet, why not prasugrel?
Well, we don't have data with single antiplatelet therapy with prasugrel, so I cannot really comment on that. I'm very impressed with ticagrelor monotherapy when I looked at the data of Twilight, and one should not forget there is another trial called the TICO trial, which is very, very similar to Twilight trial. And there also, there was extremely encouraging data in relation to ticagrelor monotherapy. And TICO trial was done in ACS patients. So, the days of, using long-term dual antiplatelet therapy are more or less over. We all know today that it is the combination with aspirin that actually increases the bleeding risk, particularly the upper GI bleeds. So this is one point I would like to say, that use after 3 months, as shown in Twilight and TICO, of a ticagrelor monotherapy, probably with prasugrel, if somebody does a trial, then we can probably support it. Second point, I'm very impressed with in relation to this dual antiplatelet therapy and bleeding risk is that it is not enough to say that if your patient has a bleeding problem, I will cut down on one of the drugs or both the drugs or whatever. It is also important to look at the source of the bleeding. There is a very good data from Poland where they had 6,000 patients of genitourinary bleeding, and they found that most patients had some cause for bleeding. This is the case with my own experience also. So I would say, instead of coming down on life-saving, important, effective antiplatelet therapy, you also look at the source of bleeding, and probably by treating it, you can reduce the chances of bleeding in future. It is a combination of antiplatelet therapy plus the source of bleeding that is responsible. it is easy to stop the antiplatelet therapy and then reduce the chance of bleeding. But then lurking very closely around is a thrombotic event. So all these patients who develop bleeding while on antiplatelet therapy, they should be investigated thoroughly. Thank you.
I will also completely agree with Sharat Chandra sir that if at any point monotherapy comes, probably ticagrelor will stand better than all the available monotherapy. And bleeding points, bleeding source definitely should be well vetted. Like we most commonly see the gum bleeding and all, and it is not because of the antiplatelet, it is because of the poor gum hygiene and then oral hygiene. That is mostly the source. One question to Pense sir, like he said, he will prefer to go with clopidogrel monotherapy rather than aspirin and anything else. So we know regarding the resistance of clopidogrel in Indian community, and it's a good amount. This the percentage, if you see, varies from almost 40 to 20% across India. So are you still content with starting clopidogrel monotherapy after 6 months versus aspirin monotherapy after 6 months versus ticagrelor monotherapy after 6 months?
Yeah, that's a good question, Dr. Tripathi. I agree with you. I was given to support clopidogrel. Definitely, I presented some data. But in Telos AMI and the Hathway trial, both these trials have shown unselected group of patients being de-escalated to clopidogrel alone after 6 months. See, most important factor here is after 6 months. So 6 months, patient didn't have any ischemic event, and by 6 months, majority of the newer generation DES, they get endothelized. And ischemic events are very, very minimal after 6 months of therapy. So that is one point. And second point is the in vitro resistance. Our own paper in 2009 first and 2016 in quite two respected journals showed that there is very poor correlation between the laboratory resistance versus the clinical resistance to clopidogrel. That is my biggest problem so far. So many patients show laboratory, they are not responding to clopidogrel, clinically they respond, and the other way around. So it is very difficult to choose a drug that way. I think we should go by randomized control trial data here. And I would be very happy for a ticagrelor monotherapy, but I will not be happy to add another P2Y12 inhibitor to aspirin beyond 6 months in this patient at any cost. And if the patient's clopidogrel aspirin has worked for 6 months, why not clopidogrel alone will work after 6 months? That will be my take.
So the two quick points, sir. Two quick points. Like we mentioned that after 6 months, all the new generation DES open to both Ponce sir and Sharat Chandra sir. So like we mentioned, after 6 months, the internalization is good, and we don't need 6 months beyond 6 months. But we know that there are the newly not that old. We have coined the word very late stent thrombosis. There's stent thrombosis beyond 1 year also. We are seeing in our practice also. Number one point. Just one side, we are looking for a lesser and lesser duration of antiplatelets. Second side, we're not even sure how long it does really take in different scenario of patient. Number one. Number two, Twilight and Tico, they were all for the Western population. They were not for Indian population. Number three, we have really observed that after coming this ticagrelor and prasugrel in picture, this rate of MACE, re-MI, rehospitalization, and this unplanned hospitalization has really gone down. So these molecules are definitely helping us. If you see the real world practice, real world evidence. So I think everything should be taken into consideration. Real world evidence as well as the randomized control data.
I think if you ask majority of the interventionalists, the fulcrum, I mean the majority of the opinion will turn in this case towards tica monotherapy alone, followed by clopidogrel monotherapy, and followed by continuing aspirin clopidogrel irrespective of 75.
No, that's fine. I agree. But I think in a patient, if this scenario was to become 3 months, I would stick to prasu as the alone one. Maybe won't you or won't you? If it's a mild bleed, Dr. Sharat Chandra, if it's a recent MI and you want to do a single antiplatelet and it's a proximal ostial LAD, the kind of case that you said, and it was not a GI bleed, as Dr. Ponde was trying to point. If choosing one, would you still stick around with prasugrel and take off aspirin if it's acute bleed?
Let me elaborate on this. If you take molecule to molecule, I have no doubt prasugrel is the most powerful agent. We have had our own experience, like what Dr. Ponde said. A long time back at Nizam's, we did in vitro platelet aggregability testing, and Prasugrel, you will be surprised to know that platelet aggregability can be as low as 0 or 2% or 4% in most patients. And that happens in a very short time after the administration of the loading dose. So what is important is that we all know that prasugrel is a very powerful agent. Ticagrelor is also equally powerful probably, but if you really look at the data of Triton TIMI 38, the kind of stent thrombosis reduction with prasugrel compared to clopidogrel is very impressive. 35% reduction of stent thrombosis in a diabetic subset. So if you ask me a question that if you have to use only either prasugrel or ticagrelor, I would go in favor of prasugrel if you have to use only one drug. Yeah.
I think for the sake of time, we need to move to the next session. We had a wonderful session. Thank you very much for highlighting. And I think we brought out the important aspect of single antiplatelet, which one to choose, where is the evidence, which patients to understand and believe as the high bleeder risk or low bleeder risk, a mild bleed in a hematuria, a high risk versus non-high risk. So that's why we tried to balance it out, the case scenario in that one. Thank you very much. Thank you all the speakers, chairperson and moderators. Thank you. Over to next session.
Thank you so much.
Now we'll proceed to bout number 4. This is related to heart failure. Can I have our chair, co-chair? Yes, the moderators are Dr. Falguni Vora. I can see Falguni on the screen. Dr. Chetan Nayak, Dr. Jignesh Sheth, and chairpersons are Dr. Satyam, Dr. Sunil Gurumukhani, and Dr. Karthik. I would like to request Dr. Falguni Vora to kindly introduce our speakers. We have 3 speakers, Dr. Anish Chandarana, Dr. Praful Kerkar, and Dr. C.K. Ponde. Ponde sir, we are not allowing to go that easily. Dr. Falguni, kindly introduce Dr. Anish Chandarana.
Yes, thank you so much, sir. Good evening, all. I, Dr. Falguni, consultant physician, would like to thank, first of all, organizing chairman, Dr. Kamal Sharma and his team for giving me this opportunity to be a part of this event. And Dr. Kamal Sharma, your dedication, enthusiasm, and insight are really very much inspiring. And our organization feels very fortunate to have an innovator like you, Dr. Kamal. I would like to appreciate entire team efforts and tremendous work and organizing such a unique case-based debate. Now, I would like to invite Dr. Anish Chandarana. First of all, I will give a brief introduction. It gives me pleasure and honor to introduce today's speaker, Dr. Anish Chandarana. Sir is an interventional cardiologist, executive director at SIMS Hospital, and a former assistant professor at Institute of Cardiology, Civil Hospital, Ahmedabad. Academically, sir has achieved many gold medals at graduate, postgraduate, and doctorate level. His keen interest in clinical, non-invasive, and interventional cardiology led him to become a pioneer in establishing PAMI in Western India. Sir has been a part of many national and international research projects and papers. He is an inspiration for the community in building a healthy heart lifestyle. So I would like to welcome our most talented, excellent speaker and orator, Dr. Anish Chandarana. Welcome, sir, please.
Yeah. I would like to request Dr. Chetan to kindly introduce Dr. Praful Kerkar. Dr. Chetan is there. Okay, Falguni, you do it that.
Yes, Dr. Praful Kerkar is a consultant interventional cardiology at Heart Institute, and sir is Research Guidelines Committee Convener of Cardiology Society of India. He has published several hundred papers and presentations in national and international journals, meetings, including prestigious orations and awards. Sir is CSI guidance document on acute myocardial infarction and heart failure care during COVID. He is the chairman of Board of Studies, Maharashtra University of Health Sciences. Sir is the chairman of Pinnacle India Registry in a collaboration with SEC. He is a former president of CSI Mumbai chapter and organizer for CSI Con 2018. Sir is researcher and trialist, and many research like CREATE, PREDICT, TAU, and PARADIG, etc. Many research papers he has published. So I again welcome Dr. Prafula Kerkar to this CardioCon 2022.
Thank you, Dr. Falguni and Dr. C.K. Ponde. We have just heard up 5 minutes back. He doesn't need any introduction to the audience. He is wonderful.
Yeah, next slide, please.
Excellent. So we'll request Dr. Anish Chandarana to.
Yeah, that's the case. Next slide. An LV dysfunction. Next slide. And these are things that we're going to learn. ARNI, Verisigua, SGLT2, and sequencing of so-called fifth pillar. Over to Dr. Anish.
Yes, Dr. Anish Bhai, please go ahead.
Yeah, good evening, everyone. I think my slides are visible to all.
Yes.
Wonderful. So good evening. Thank you, Dr. Kamal. Thank you, Dr. Jayesh Bhai. Thank you, Falguni. And I must appreciate the presence of all my colleagues on this platform. The case is pretty simple. A female 65 years, NYHA class 3, low ejection fraction. Her angiography and QRS are normal, so she is not a candidate for either revascularization or CRT. Her blood pressure is 100/62, which we commonly see in patients with heart failure. Creatinine is high, EGFR is 38, so she has genuine chronic kidney disease. She had history of heart failure admission before 3 months, and she has been a drug defaulter. So we know that this patient is very, very high risk patient. She has got multiple risks. She has a risk of worsening of heart failure and needing multiple therapies. She has a risk of getting admitted to hospital again in ICU. She has a risk of worsening renal function. And we all know that the highest and topmost risk is she can die anytime because of not only heart failure death, but because of also sudden cardiac death. So in such a patient, I would like to use at number 1 step, the 2 best possible molecule which can reduce the risk of admission as well as death. And they are beta blocker and ARNI. So I would prefer ARNI ahead of any other agents in these patients to be used. Now, we all know that there are 4 pillars which has been discussed, ARNI, beta blocker, MRA, and SGLT2 inhibitors. And at the moment, in most of the patients, my personal choice is to start all these 4 molecules at one go. And by next 7 to 30 days to make as best dose as possible for all these molecules. So even in all the patients where I do get borderline EGFR, where I get borderline blood pressure, my temptation to start all these 4 molecules is very clear because of 2-3 reasons. Number 1, when you start all these molecules, even if they are going at a low dose, they do reduce the risk of heart failure admission and mortality. And then if you put all these molecules on by completion of 30 days, you are going to reduce 75% risk of a patient who is so sick. Obviously, we know that we have to have certain concerns of clinical parameters like blood pressure, heart rate, kidney function, and potassium in selecting and pushing the dose of this drug. As I talk to you, my choice would go to ARNI out of all this is because of many reasons. Number 1, if you talk about the pathophysiology of heart failure, we all know that the theory that overactivation and upregulation of RAS leads to heart failure has been extremely well established and well tested in variety of models. Not only that, we have also seen that if you can preserve the vasodilatory system, that is natriuretic peptide system, by addition of neprilysin inhibition, it potentiates the safety and efficacy of RAS blockade. There is huge amount of evidences that when you give a combination of valsartan, that is ARB, and a neprilysin inhibition, that is sacubitril, not only it improves NT-proBNP, LV ejection fraction, systolic and end-diastolic volumes, risk of non-sustained and sustained ventricular tachycardia, but it also leads to renal preservation and reduction in cardiovascular death and mortality. So the strongest evidence for ARNI came through a trial, Paradigm HF. We all know that it was a very well-conducted trial, more than 8,400 patients. And all these patients had an SBP more than 100 millimeter of mercury and EGFR more than 30 ml. And what was seen is it led to reduction in primary composite endpoint, that is risk of admission and mortality. But to me, the 2 things which are most appealing are it led to reduction in cardiovascular death, and it also led to reduction in total mortality. Now, believe me, there are hardly few molecules on this earth which have been invented which can lead to reduction in total mortality. So something which reduces total mortality can be compared to Amrit. So ARNI is one such a strong molecule which has got a strong data that it reduces all-cause mortality. Now look at all the causes of death. It reduces all causes of death. It reduces the risk of worsening of heart failure and getting death because of that. It reduces risk of sudden cardiac death. It reduces all-cause mortality. And over and above, it leads to so many other soft endpoint benefits, like there is less ER visit, less need of intensification of treatment, less need of ICU care, vasopressors, less need of device therapy, and even less need of heart transplantation. And that's why what I understand, for the first time, perhaps in the history of guidelines, many countries and many guidelines formatting authorities came out with a conclusion that those patients who are having HFrEF, if they are receiving any kind of ACE inhibitors, replace ACE inhibitors, which has been such a well-time tested molecule by ARNI. So such a compelling indication was generated because of such a robust evidences by ARNI. Now, we all know that Paradigm HF was a trial which compared ARNI against ACE inhibitors. So it was an active molecule which was well established, against which ARNI was compared, and it found it was better in reduction of cardiovascular mortality and hospital admission. What if ARNI is compared against placebo? So a wonderful article came in European Heart Journal, a putative placebo analysis of the effects of sacubitril/valsartan combination in heart failure, did say that if you compare the sacubitril/valsartan combination, that is ARNI against placebo, the estimated benefits of ARNI would be 35% reduction in CV death and 50% reduction in admission for heart failure. So such a robust benefit has not been seen with any other molecules. We all know that. We discussed a lot about the adverse effect of ARNI, but let me tell you, all the adverse effects of ARNI are well known, acceptable, and are reversible with changes in dose. When we add neprilysin inhibition to existing angiotensin receptor blockers, not only it enhances the therapeutic effects in terms of CV death and heart failure admission, but it also reduces the risk of renal dysfunction and hyperkalemia. So neprilysin inhibition has capacity to reduce worsening of renal function, the rate of worsening of renal function and hyperkalemia. That's why this is something which is so appealing. Many times we do discuss about hypotension and ARNI. I think we as clinicians and physicians need to understand this concept in a better way. Now, a patient who has been well treated with all the molecules with heart failure, he or she would maintain a blood pressure of 95/100 systolic without any symptoms. So any patient who has got a low BP of 95 with symptoms like asthenia, cold peripheries, or pre-syncope or dizziness or lightheadedness, these are the patients where you have to consider about the dosing of ARNI. While all the patients who have BP of 95 systolic without any other such symptoms should not be considered that they are hypotensive, and you did not change the dose of ARNI, which is so important. So that's why even in such patients where you get low blood pressure with symptoms, you need to first look at what are the other BP lowering medications. Many a times a patient of heart failure is on variety of antihypertensive and other medications which do not have strong data to reduce mortality in heart failure patients, but they are there for some other reasons. So we need to get rid of those molecules. We need to adjust the dose of diuretics. And then even if patient, in spite of the lowest possible dose of ARNI, is getting variety of symptoms and hypotension, yes, there is a chance we have to reduce the dose. What about renal function? If you compare the enalapril versus ACE inhibitors, versus ARNI in Paradigm HF, the rate of reduction of eGFR was much slower in patients who received ARNI. So when you add neprilysin inhibition to valsartan, it leads to more preservation of the kidney. On the other side, if you look at the patients of CKD, now patients of CKD had a benefit, equal relative risk reduction by ARNI as compared to ACE inhibitors and enalapril. In fact, if you look to the absolute number of reduction, it was better because patients of CKD have got higher risk. So a patient who has got higher risk is going to have more absolute benefit by ARNI. And that's why even if a patient has got CKD, ARNI remains a better choice. This slide is quite busy, but it gives certain rational base to compare these three drugs. We know that there are no head-to-head comparison. It will never come, but there are so many things which can be compared across the trials and can be thought in perspective. So number one, can we adapt ARNI in this patient who has been presented to us? The answer is yes. The cutoff eGFR and cutoff blood pressure is matching. Is ARNI effective in this patient? ARNI is perhaps the most effective agent as far as reduction in mortality, quality of life improvement, and risk of hospital admission is concerned. Is ARNI safe? ARNI is reasonably safe. Yes, there will be few patients who might need dose changes, but ARNI can play a wonderful role. So ladies and gentlemen, coming to sort of a conclusive slide, we all know that this patient is very, very high risk, and we need to act fast. And when you want to act fast and reduce the mortality of such a high-risk patients, you need to put aside a lot of if and buts. You need to implement the treatment without thinking too much of other if and buts, because there are huge proven benefits of ARNI. It reduces total mortality. It reduces CV mortality of heart failure and sudden cardiac death. It improves quality of life and reduces less admissions. It leads to reverse remodeling of left ventricle, reduces MR, LVED, and ejection. It improves ejection fraction. It preserves kidney functions. And on the top of the list, it reduces the need of renal transplant and heart transplant. Yes, there are certain small issues with ARNI, and they can be taken care of very easily.
Please.
When patient has got some increase in creatinine, when you add this drug, you have to sit tight. Don't worry. Generally, nothing is going to happen. Few patients might develop symptomatic hypotension. Be watchful. Make a space for this particular molecule and keep watching. So my conclusion is, in this patient, I would recommend strongly to add ARNI in addition to beta blocker. Keep a BP record. Repeat renal function test after 15 days. More than 90% patients will have no major issues. They will tolerate the best possible molecule, that is ARNI. In fact, most of them will start feeling better. Their BP will improve, and there is a chance that you can upscale ARNI in all these patients. Thank you very much for your patient listening.
Thank you so much, Anish bhai. You are absolutely in time as usual. I had a little apprehension, but
thank you. Thank you.
You are always like this. I would like to request Dr. Praful Kirkar.
Well, thank you. Dr. Anish has said what is happening now. 1 second. Screen. Why isn't it showing my?
What saying, sir?
1 second.
So you can share it.
And I'm trying to share screen and it shows some whiteboard out here. I don't know this.
Sir, first of all, please open your PowerPoint, then choose set screen.
Okay, I'll do that. 1 second. Oh, sorry. Yeah. Yeah. Okay, here we go. There's my PowerPoint. Okay, am I audible and my screen visible?
Yes, sir.
Yeah, sorry about that delay. Well, I'm trying to talk about safety first, right? So I'm talking about SGLT2 inhibitor with beta blocker, and then looking at a safer strategy afterwards. Right at the outset, a disclaimer here that vericiguat is currently not approved in India for the treatment of heart failure. Well, one must understand the contemporary approach to the treatment of heart failure, which should be clinically oriented, acknowledge importance of evidence-based therapies, all the ARNI evidence that Dr. Anish has already given. We need to look into that, all right, emphasize on early initiation of the fantastic, fabulous, whatever you want to call these 4 pillars, including ARNI and SGLT2. That is what it is. But we need to be practical and we need to individualize treatment based on the patient characteristics, as also on their tolerances and intolerances. Mind you, there is a patient here, which is so relevant here, is a drug defaulter and the access to meds, of course. And having seen that, let's now move to the real world. Welcome to the real world, as I would say, moving away from the trial data. Because as very admittedly, my worthy opponent says, this is a very sick patient, has got multiple challenges listed out here. And we want to, of course, look at her safety too. We all agree that these 4 foundational pillars should be started as soon as possible. But when it comes to in this patient whose blood pressure is on the brink, 100/62, and more importantly, she has renal impairment, I would definitely not venture to initiate with these 2, the RAS blockade of any kind. And ARNI, mind you, is also a form of a RAS blockade on top of neprilysin inhibition, which is there. And I would, why not? Because there is no convenience of drug dosing out here. You start homeopathic dosing at how many times have we seen prescriptions of Ramipril 1.25 and you go on forever, unable to uptitrate. More so, 50 milligram half BID. You ask the pharma companies, that's the commonest dose that even cardiologists land up giving. The inability to maximally titrate the dose, safety concerns, hyperkalemia in this kind of a patient looms large. And admittedly, Dr. Anish said eGFR less than 30 ml was an exclusion criteria. And I, for one, was the Paradigm Heart Failure investigator as well as the national coordinator for Paradise MI. And in Paradise MI too, both symptomatic hypotension as well as worsening eGFR was obviously seen. So with that in mind, I would definitely want to start on top of beta blocker, which all of us are agreeing to give, an SGLT2 inhibitor, because with beta blocker and any kind of RAS blockade, the hypertension business is going to increase all right. And having said that, why SGLT2 inhibitors? Very few contraindications. I'm sure Dr. Ponde will also go into the details of SGLT2 inhibitors, except for diabetic ketoacidosis or other type 1 diabetes mellitus and hypersensitivity. We do not have any such, and patients on dialysis. And require just a single dose. There is no need to up titrate. Minimal effects on heart rate or blood pressure in this patient, so important. And again, that renoprotection as compared to ARNI, definitely proven in both these trials that SGLT2 inhibitors are renoprotective, albeit a small drop in eGFR, about 3 to maximum 3 ml, you may get. So having said that, I would rather go by the new treatment paradigm and go to the new proposal of sequencing, wherein beta blocker and SGLT2 inhibitor comes first in this sequencing of these 4 foundational drugs. And that too given by a man no less than McMurray, whom thankfully I had there is no bias here. I was able to share a podium with this big man, who, mind you, has given both SGLT2 inhibitors as well as ARNI. And he proposes a paradigm wherein SGLT2 inhibitor first, more so in these kind of patients. And it is not just one outcome trial, unlike ARNI. There is not one but a second molecule here, emperor-reduced empagliflozin, which is also showing identical hazard ratios, 0.74, 0.75, and replicated in this next trial also, that the primary endpoint of composite CV, death, heart failure, hospitalization, and urgent heart failure visit is reduced by about 25% relative risk reduction. So also in the meta-analysis, all-cause death, also you find a clear benefit. So also symptoms and quality of life improvement. So having said that, our patient has got these challenges of the fact that the patient was admitted 3 months ago with a worsening heart failure event, and that patient is renally compromised, drug defaulter, and a low blood pressure patient. Now, what do we mean by this worsening heart failure event? That the patients had to be included in the Victoria trial. Besides being symptomatic chronic heart failure, they had to have had a hospitalization for heart failure within the last 6 months, 84% of the patients, or an outpatient IV diuretic use, and very elevated natriuretic peptide. Again, unlike ARNI, no run-in, washout, no run-in, etc., to look at the tolerability. And that was tested out in the Victoria trial with very Sigwart. And we all know that this is the natural trajectory of a patient with heart failure, punctuated with worsening heart failure events. And this is one problem never addressed in other trials, other major heart failure trials, addressed in Victoria trial. And what did we find from the post-hoc analysis of ARNI trial itself? What do these trials show? That the risk of CV, death, or heart failure hospitalization, the primary endpoint, was 46% higher in patients who had a recent worsening of heart failure. That is, by recent hospitalization, 3 to 6 months or less than 3 months, way too higher, 46% compared to no prior heart failure hospitalization. So this is what is relevant in our patient. And therefore, I'm asking you, why not consider, after having given 2 out of the 3, the other 2 I told you cannot be used here in this renally compromised patient. Beta blocker and SGLT2 inhibitor we already used. Then why shouldn't we consider adding vericiguat? More so because it looks at an unaddressed, medically unaddressed pathway. That is the deficient nitric oxide soluble guanylate cyclase GMP pathway. So let's give another mechanism of action, which in a simplified way, independent of nitric oxide and in synergy with nitric oxide, vericiguat stimulates soluble guanylate cyclase and thereby goes on to increase the cyclic GMP with all its beneficial effects. Now, since he talked so much about natriuretic peptides also do stimulate the guanylate cyclase, but that is a particulate one on the cell membrane. So a similar mechanism in the end, and this is how you get the beneficial effects of vericiguat. at the heart level, the vascular level, as well as the kidney level. And cross-trial comparisons are not permissible. But if you see both the SGLT2 inhibitor trials as well as the ARNI trial are stable chronic heart failure. It's a misnomer, all right, but with hardly any focus on heart failure hospitalization. In fact, heart failure hospitalization within 6 months was there only in 31% patients here, 16% here, whereas 100% focus on worsening heart failure patients in Victoria, 84%. Sicker patients, the primary endpoint event rate in the comparator arm, you can see here 37.8, more than twofold that was seen in the ARNI trial here. NT-proBNP levels massively elevated. Now we're talking about our patient being class 3, class 4, going on class 3, going to class 4. 41% patients here. Compare this with ARNI trial. And mind you, ARNI life trial, which went into advanced heart failure, was negative, just published last year, or rather presented last year. So what did Vericiguat show in the Vericiguat as compared to the placebo arm? The primary composite outcome of CV death and first heart failure hospitalization was down by an absolute decrease, annualized event rate down by 4.2%. You might ask, why am I harboring upon absolute risk? This is important when the risk increases and the primary event rate is very high. Though the relative risk compared to other trials may be only 10%, the primary endpoint I'm talking about. And if you look at the directionality, even there was a trend towards mortality benefit, which did not reach statistical significance. Compare this with DAPA-HF, compare this with Paradigm-HF, and look at the NNTs. Very, very, very acceptable. Small wonder then guidelines. These are the Canadian guidelines. Obviously, everybody agrees to the 4 foundational therapies. We are already giving beta blocker and an SGLT2 inhibitor. We want to stay away from RAS blockade of any kind in this sick patient and want to, because of the recent hospitalization, consider Vericiguat very much in keeping with the guidelines. Then what about renal impairment? Is this patient not renally impaired? Very much. With a creatinine of 1.89, the recommended way of calculating it is using the CKD EPI formula or the MDRD formula. And that works out to 28 ml, as you can see. So also with the Cockcroft-Gault formula, you see for a 60 kg weight, it is same again 20.1. Our patient has to be really obese to have that kind of a creatinine clearance that in his googly Kamal Sharma talks about. So definitely there is renal impairment, and definitely this patient would have definitely not made it to the ARNI trial. So that's what real world scenario. Safety tolerability for this patient who is a drug defaulter, great. No hyperkalemia, in fact, numerically lower. Renal impairment, absolutely not seen. I don't know where he got that figure of whatever 0.3% from. And therefore, Vericiguat comes in here. And as far as low blood pressure is concerned, of course, you need to be careful about low blood pressure. But if you saw in the previous slide itself, that symptomatic hypertension as well as syncope, pre-specified AEs that were looked for were statistically not significant, although numerically slightly 1% higher. So having said that, let's come to the last problem there. In his zeal to wanting to, and both their zeals, wanting to get some kind of a RAS blockade on board for this patient who has been a drug defaulter, mind you, she will run away again. And she is not going to have that kind of a patience for her to be monitored for her renal function or regularly take blood pressures, etc. Side effects and adverse events that I talked about loom large in her, and we need not use these agents, the RAS blockade in this patient. Now, like I mentioned to you, no significant difference in symptomatic hypotension. Vericiguat had a favorable safety profile. The rates of AEs and SAEs were actually numerically lower, in fact, and 90% adherence to the 10 milligram target dose of Vericiguat was achieved here. And in this document from the European Society of Cardiology, a position paper where you tailor therapy, like I told you, it's an art. Ponte was talking about an art in the previous session. Particularly, Vericiguat should be recommended when foundational drugs are reduced, or rather in this patient discontinued for whatever reasons and are not tolerated, what comes in is varisigward. And varisigward, especially in our patient whom I showed you, the renal function is definitely on the brink. So having said that, what are the FDA approved labels for current heart failure treatments? Both ARNI as well as DAPA, you can see, are in stable heart failure patients, chronic heart failure patients, with going from NYHA class to 4, agreed. But the number of patients with NYHA class 3 and 4, very low, especially in the ARNI trial. Now you compare that with varisigward label given by the FDA, that it is indicated to reduce the risk of the primary endpoint following a hospitalization for heart failure or a need for outpatient IV diuretics. Our patient, 84% of the patients in this particular Victoria trial had hospitalization for heart failure, and they are really sick patients, as you can see. And in this sick patients, in adults with
the last 1 minute, please,
EF less than 45%, varisigward scored. So therefore, I would go by this triple drug combination. Thank you so much for your, or begin with beta blocker and SGLT2 and then add on to varisigward. Thank you so much.
Dr. Pandey, your turn.
Yes, Kamal, very much here. So,
now we have Shah Rukh Khan. Huh? By the way, I was flanked between the two Khans. My talk, at least timing wise, is flanked between the two Khans.
Yes. Praful, you have done a great job. Can you hear me well?
Yes, very well.
Okay, so what is our case? 65-year-old female, non-ischemic dilated cardiomyopathy, ejection fraction 20. She has narrow QRS, so she's not a candidate for CRT anymore. Borderline blood pressure, EGFR by MDRD6 comes around 31, and by the CKD EPI comes less than 30, and by the MDRD4 comes around 34, 36. Fair enough. And recent hospitalization. But most important is the last one. She's a defaulter. As you know, every hospitalization, after first hospitalization, the mean survival is 2.6. After second, 1.8. After third, 1.5. After fourth, 1.3. So here actually, because here recent hospitalization, we don't have much time at our hands. We know that 2021 ESC guidelines still say ARNI, beta blocker, MRA at the top, and the SGLT2 inhibitors come later. However, we know that Dr. Praful Kelkar has clearly told us, and Dr. Anish also agreed here, that we need to have all these 4 drugs in 4 weeks on the board to save the ship or save the sinking ship. Having said that, question is not whether we want to have all the 4. Yes, we do want to have all the 4. And we want to have probably the 5th, that is varisigward on the board, particularly in this patient, which Praful has made a very strong point: borderline blood pressure, defaulter, unlikely to stay with therapy, no monitoring required, and with a recent hospitalization and a very EGFR which is on the brink. So here varisigward will definitely come as a fantastic 5th flare, maybe. But in practical approach to this patient, as Dr. Praful said, start beta blocker and SGLT2 inhibitors. After 1 to 2 weeks, if everything is good, hunky-dory, add ARNI. And then after 1 to 2 weeks, probably add an MRA. Why this should be the best approach? Borderline BP, borderline GFR, knowing that she's a drug defaulter, starting drugs that are easy to use, once a day schedule, and will have practically no side effect, is likely to inspire confidence in this patient, and probably she will adhere to therapy. That is the way I will think. And so my choice will be bisoprolol 2.5 once a day and DAPA 10 milligram once a day. Why SGLT2? Again, no rocket science here, easy to use, very few absolute contraindications, overall safe and well tolerated, minimal or nil effects on blood pressure and heart rate, significant benefits in CV outcome, including heart failure, hospitalizations, and cardiovascular death, renoprotective over long term. And these concordant beneficial effects in heart failure outcomes, cardiovascular death, and renal survival. That is one which makes SGLT2 inhibitors such an attractive option in this patient. And minimal hypoglycemia, even in non-diabetics. So DAPA showed 26% relative risk reduction in primary composite endpoint, number needed to treat 21, very close to that of Vericigot. And if you separate them, worsening heart failure reduced by 30%, cardiovascular death by 18%. Mind you, my friends, all-cause mortality, the hardest clinical endpoint to be satisfied in any given clinical trial, DAPA reduced by 17% in DAPA-HF. And on the top of all that, the fact remains, whether you had diabetes or without diabetes, the risk reduction was the same. And what is more important, those who had heart failure hospitalization within the previous 12 months, the risk reduction was even more pronounced, even more robust, even more impressive than those who had no hospitalization or a remote hospitalization more than 12 months ago. So that is another point in favor of SGLT2. So this DAPA-HF was conducted in patients who were optimally treated with beta blocker, RAS blockers, and MRA. And the height of hurdles was formidable. And yet DAPA showed impressive risk reduction in patients who were optimally treated with beta blocker, RAS blockers, and MRA. Dapagliflozin also improved quality of life. And dapagliflozin reduced acute kidney injury. DAPA and Emperor both showed that there is a sustained reduction in the progressive decline in eGFR beyond around 6 months or so with both these agents. So they are actually renoprotective agents. In the initial phase, there is a bit of dip in the eGFR, but beyond 3 to 6 months, the eGFR is much better preserved as compared to the placebo, which is a standard of care therapy. So when you have all these 4 pillars on the board, at 55 years, you add 6.3 years to their life. At 65, you add around 4.5 years to their life. So all 4 must be given one after another. In this patient, I doubt whether with a borderline BP, you may be able to give more than probably 50 milligram BID of ARNI. But even if you are able to give that, I'm with it. I'm not against it at all. I'm with it. After beta blockers and SGLT2, ARNI must be tried with careful monitoring of GFR and potassium, as Dr. Anish Chandarana, my good friend, says. So this has caused paradigm shift in the sequencing conventional versus the newer. And in this patient, I have no doubt I will start with beta blocker and SGLT2 inhibitor first. I raise my case there. Thank you. I hope I was in time.
The forum is
Kamal, you are muted.
But
Chairpersons.
Kamal, you are not sending us anything to eat here.
Sorry?
He's not sending us anything to eat here. He's eating all alone.
Specifically, as you
कमल जोमेटो से कुछ आने वाला है या नहीं आने वाला है वर्चुअल
So, chairpersons, I think we'll take comments from them first and then initiate a discussion.
Yes.
Dr. Satyam?
Yes,
yeah.
Yes. Sir, very wonderful argument talks by all the senior sir, Anish Chandana sir, Ketkar sir, and Ponde sir. And one thing must learn from them, these talks, is how sincere in their talk. Even Praful Ketkar sir is calculating the eGFR in this patient by different formula. So, as a young cardiologist, we can learn the sincerity in every aspect of our life. So apart from academic, this is very important. And for just a discussion, whether ARNI is more effective in ischemic or non-ischemic cardiomyopathy, my question to Anish Chandana sir. And second question, if this patient having diabetes, sir, your choice of SGLT2 over ARNI, or you are still prefer ARNI?
So, I mean, good point. A patient who has got systolic heart failure with ejection fraction less than 40%, irrespective of the fact whether patient is ischemic or non-ischemic. The things apart, a patient with ischemic heart disease would need correction of ischemia if that is going to be helpful. But then ARNI is there on board. Whether patient has diabetes or no diabetes, again, ARNI should be there on board. And maybe 2-3 points which were raised by rightly so Dr. Kerkar and Dr. Ponde. Number one is drug defaulter. See, there are various reasons we all know in clinical practice because of which patient becomes a drug defaulter. One very important is failure of a clinician to explain how effective this drug is. I always take ARNI in my hand and talk to the patient that this is the drug, if you stick for your life, is going to improve longevity and improve quality of life. The choice is in your hand. When you talk so emphatically with so convincing attitude, I'm pretty sure drug defaulter chance goes less, number one. Number two, again, the drug defaulter chance becomes maximum when patient has no symptomatic apparent benefit by a medicine. Believe me, I can ask you all those who are attending this conference, if you have used ARNI in your patient with heart failure, that is perhaps the first ever best drug which patient comes after 10 days and will be extremely gratified and happy that doctor, my life has changed. There is no other drug in the heart failure armamentarium which can produce such a superb benefit. And believe me, patient doesn't understand EGFR, potassium, etc., etc. Again, we are doctors and we have to work on that. But patient understands only symptomatic improvement. And that's where ARNI scores superbly better. So I'm pretty sure rarely my patients whom I put on ARNI with all the explanations of drug and the cost, they ever stop. Cost is same for all these molecules generally. So I think cost becomes a separate point to be discussed. The third point, which generally people perceive RAS blockade and ARNI as kidney deteriorating drugs. They are kidney improving drugs. Why we are not able to put it to our mind, that is quite unfortunate in most of the patients of this EGFR. When I put ARNI, the first person to hold ARNI is nephrologist. And I keep on fighting with most of the nephrologists on phone calls. When I meet personally, they all are friends. But then I personally believe any patient and every patient who has got reduction in EGFR, they are the strongest candidates to be put on ARNI. Now, question about potassium and EGFR is to be handled by a clinician, and that is the role of a clinician. I mean, see, if you want to use a drug which is a superb weapon to reduce mortality, then yes, we have to do some jugglery. But believe me, it's not as common. Out of 100 such patients who are pushed to us, what Dr. Kamal Sharma has raised is 80% will tolerate the dose of ARNI. And coming to last point, that small dose of ARNI also is useful. You look to the paradigm HF, those patients who didn't tolerate the full dose of ARNI, when the dose was reduced, they were followed and they also got the benefit. So somehow there are many patients who do not tolerate ARNI to the full dose. No worry. Give them 25 BD, give them 25, 1.5 BD, give them 50 BD, but it's going to work. I personally believe that ARNI is the strongest molecule to be considered with beta blocker in any patient of heart failure. Taking care of all those issues, maybe out of 100, 10, 12, 15, you will have to stop that. That's okay. But for rest 85, you cannot keep them devoid of ARNI. I'm pretty sure on that.
So my question to all of you, when do you call a defaulter, a long default as good as a drug naive? 2 days, 7 days, 2 weeks, 1 month? When would you consider him as a drug naive? I'm sure there are no data to it, but then if somebody has dropped the drug, how long? Yeah, Dr. Ponde, you're saying something?
For the running period of these trials, if you think and go by that, I think 4 weeks defaulter is considered as drug naive. Anybody who defaults from all drugs, 4 weeks is drug naive patient, period.
Yeah, it's a question of whatever drugs are still on board or otherwise. That drug defaulter, nowadays, they don't use that terminology anymore, what they used to in the good old days, isn't it? So it's a question of how you're defining that defaulting business. Standard way, ARNI, having said ARNI, I'm a big believer in ARNI. It's a debate, it's a different matter. But herein where you have a patient who is not patient with you to understand the creatinine going up and down. It's of course an art, heart failure therapy to give to the sick patients. But having said there, this is the kind of a molecule when I talked about Vericiguat, as for a drug defaulter like her, I'm talking about using something that is safety, tolerability wise, next only to SGLT2 inhibitor and with as much not great as touted big benefits. But we must realize that as we go up the ladder in terms of the risk profile increasing, ARNI also, it was expected that the life trial would show us huge benefits even in advanced heart failure, right? I also presented some abstracts from somewhere presented by the Cleveland Clinic people where they were able to wean off people off MCS, meaning mechanical circulatory supports. And they were touting ARNI to be so big. But compared to Valsartan, what did it do? ARNI didn't do anything. So we have to understand that the drug therapy may not work as well as we go to sicker patients. And that's where probably Vericiguat has missed the bus. They went for the really sick patients, right? And there never will be a trial in the lower risk patients. We've got the primary endpoint still there, that kind of a thing. So it's just one more mechanism. And it will come in, according to me, at a time where you are, by virtue of renal dysfunction, not able to use anything. I remember all of us cardiologists land up using that combo molecule, which was used in good old days in Black African males, correct? And in in males, and that to Black African, not ever used in Asians. And we give a dihydralazine and nitrate combo preparation for people whom we can't get ARNI-like drugs on board. So definitely over there, this is a molecule which will be preferred with a better data, but the guidelines are guidelines after all. They continue to call Vericiguat a class 2B indication, whereas 1,000 or 600 to 1,000 patients, just because there was good old days without a background of other therapies, a mortality benefit, so you will talk about this combo. So I would put Vericiguat in place of dihydralazine nitrate kind of combos, definitely for heart failure therapy. Also because there is an extra mechanism of action that it's acting upon, right?
I think Kamal Bhai is satisfied. That is
one more thing is that now,
questions.
Dr. Ponde, you nicely stayed away from RAS blockade. You are supposed to also say that you are going to start after this.
No, I said
ACE inhibitor and ARB.
No, but I said.
If you are saying no to ARNI, there is definitely no to any RAS blockade, according to me.
No. I never said no to ARNI. I said starting point is beta blocker SGLT2. Patient remains stable, everything remains hunky-dory. There is a term I use. 1 week later, I will institute ARNI in this patient. There was no question.
Absolutely.
All 4 pillars have to come on the board to save the ship. No, so
Yes.
we have to do that. Yes, I agree.
I think we had a wonderful discussion. Thank you, all the 3 speakers. We need to move to the next important session, which is all women in cardiology session. This is a session that we dedicate to women in cardiology. And for that, we have all women faculty. And I would request the speakers and the next slides to be presented, please.
Men folk have to stop their videos.
Slides, please. So we have a wonderful next session coming in here. We have all women in a women patient, all women speakers except Dr. Andrew Choi, who's going to talk about a specialty, and even bigger, my better half is going to be moderating this session. So
go ahead.
Can we have the slides, please? Yeah. So for this session, I would like to invite moderators, Dr. Neha Sharma, Dr. Archana Jadeja, and Dr. Bhumi Patel, and Dr. Aisha Kadar, Dr. Pooja Vyas, and Dr. Nikhila Panchani as chairperson to introduce our speakers. Over to Aisha. Dr. Aisha.
Thank you very much, Dr. Kamal Sharma. It's always a pleasure to be at CardioCon and also at this very special session. It is my pleasure to introduce our first speaker. As you know, this is a debate, and the debate will be on a 52-year-old woman who was hypertensive and dyslipidemic, presenting with atypical angina with non-specific STT changes in inferior leads, and an ejection fraction of 58% with no evident regional wall motion abnormalities. She also has bilateral osteoarthritis of the knee, and the debate is on which is the best strategy for coronary artery disease evaluation, other than invasive coronary angiography. So that's off the table. It's an imaging debate. And it is my pleasure to introduce our first speaker, who is Dr. Sonali Inamdar. She is a consultant interventional cardiologist at the Inamdar Heart Clinic at Pune in India, and also an associate consultant of cardiology at the H.N. Reliance Foundation Hospital and Research Center. She has numerous prizes and publications to her credit, And she will be speaking first, but I would also like to very briefly introduce our other three speakers. We have a stellar panel of international speakers. We also have Dr. Purvi Parwani, who is also a very good friend. She is of Indian origin, I believe from Ahmedabad, but she is now doing very well in the United States. She is an assistant professor of medicine at the Loma Linda University in California, and also the director of Women's Cardiovascular Clinic at that institute. So something to watch out for in terms of debate, because this is her home turf, I suppose. And she also has numerous publications to her credit. We also, to debate on the role of CT angiography, we have Dr. Andrew Choi, who is the co-director of cardiac CT and MRI and associate professor of medicine and radiology at the George Washington University of Medicine. He is a national and international thought leader in cardiovascular imaging and is an author of over 100 abstracts, so very prolifically published in the arena as well. And last but not least is Dr. Renee Bullock Palmer. She is a cardiologist as well as a board certified cardiovascular and nuclear as well as imaging specialist. And she comes from Jamaica, but she is also now, I have the pleasure of knowing her off this as well as one of the winners of the Women as One Escalator Awards. And she's also known to be a phenomenal mentor. So a stellar panel today, and we're really looking forward to the debates. I will hand it over to Dr. Sonali Namdar to kick off the debate today.
Dr. Neha Sharma happens to be Dr. Kamal Sharma's wife. That is a special introduction I wanted to give. Thank you. Please go ahead.
Thank you, Jayesh Bhai, for introducing. Hi, everybody. So just a second, I just want to say that I've been, in last year also, I was on session with Dr. Aisha and Dr. Purvi Parwani last year. And Dr. Purvi is like a family member to me. So hello, everybody. Please continue the session. I'm there.
Are you able to view me and the slides?
Yes, you are visible as well as audible.
Okay, thanks, Aish. So I'd like to extend my warm gratitude to Dr. Kamal Sharma and to Dr. Neha Sharma, ma'am. It's second innings for me in this conference. We had met last year, and it's so wonderful to meet all my colleagues and friends again this year around. So I'll be speaking on the approach to this patient in terms of ischemia evaluation of stable coronary artery disease, and I'll be talking on pharmacological stress echo. Right. Okay, so let's begin. I just want to introduce a little concept known as the paradox of choice, because now we've been inundated with so many choices in our lives and in our day-to-day world. Just as a start, this is a menu card of a restaurant in a ordinary restaurant in Pune, and you can see the immense number of choices that you've got to face. And the problem with having so many choices is that when you have so many items to choose from, you are confused. There's a lot of stress. And this is known as the paradox of choice, in which the more number of choices you have, your happiness quotient goes down. So less is in fact more, and too much choice adds to a lot of conflict. What we suffer from in today's world as physicians, as cardiologists, is something known as the opportunity cost, which means that the attractive features of the choices that you're not making add up to make the choice that you actually do seem less appealing. So similarly, when it comes to the immense number of choices that we have in terms of CAD evaluation of a stable coronary patient, we have anatomical tests like a coronary CTA. We have a host of stress tests like the exercise ECG, stress echo, stress MRI, and stress nuclear scans. I've not mentioned the prices here, unlike a restaurant menu, because the cost, of course, differs from region to region, country to country. So that's up for debate. So let's see, how do we deal with this paradox of choice in such people who come with evaluation for coronary artery disease and who have stable angina. So as Dr. Ayesha has mentioned, that we are talking about a 52-year-old female who has some non-specific changes in her ECG, who's unable to exercise, and who has certain risk factors like hypertension and dyslipidemia. Now, what would be the best strategy? Now, if we go by the old guidelines, we typically risk stratify these patients by going talking about the pre-test probability of such patients. So considering that she has had atypical angina and she's in her mid-50s, her risk before undergoing any further test is at a 6% pre-test probability. However, in 2021, that is last year, new guidelines have come up which have lowered the pre-test probability of these patients even further. If you notice the numbers here as compared to the numbers in the prior guidelines, we see that most of the patients, irrespective of gender and considering both chest pain or dyspnea as a feature, as a presenting feature, most of their pre-test probability numbers is quite low. That is because the overall incidence of an obstructive coronary artery disease in the general community in patients who have stable coronary artery disease is less than 10%. So if we look at our patient, she falls under this particular category in which her risk is in fact less than 15%, and she would in fact fall in the low risk category. However, we cannot just treat patients as numbers. We cannot just go by the pre-test probability in its entirety. We have to consider certain other considerations. We can add a calcium score and improve the pre-test probability or add on to the pre-test probability and get a further understanding of her risk status. Additionally, in these new guidelines, atypical angina is no longer a term. What we have now is either it's a cardiac angina, which is very typical with the central pressure, squeezing, gripping, chest pain, or it could be possibly cardiac, which lies in the center, or it could be a non-cardiac chest pain. So going by her symptoms, we could probably say that she falls in the possibly cardiac category. And let's just assume that she falls into this intermediate to high risk group. Now, how do we approach these patients? If you notice this very wonderfully colored pyramid, which has been proposed by the latest guidelines, it shows that in stable chest pain evaluation, the intermediate risk and the high risk patients are clubbed together, and then we approach them in a similar manner. So the approach to these patients is either by going down the anatomical pathway, that is by doing a coronary CT, or going down the stress testing pathway. Now, there have been certain factors which favor the use of coronary CT versus stress testing. For example, if we have younger patients and who are not on optimal preventive therapy, we can go for a CT coronary angio. But the use of CT is more for ruling out an obstructive CAD, that is more than 50% coronary artery disease. However, if you look at a patient clinically and decide that she's likely to have a higher likelihood of ischemia, you look at which region she comes from. If this is an Indian patient, we know that South Asian patients have higher propensity towards multivessel disease, and you want to rule out ischemia in such a patient, then you go down this ischemic pathway and consider a stress testing pathway. The ESC guidelines also tell something similar, where they say that the choice of the test is based on clinical likelihood, the patient characteristics and preferences, and of course, the availability and local expertise. So you either go down the coronary way, coronary CT way, or you go down the stress testing pathway. So as we all know about the ischemia cascade, when there is a coronary blockage, just before the chest pain occurs, a lot of abnormalities take place in the myocardium. It begins with perfusion and metabolic alterations, which are detected by nuclear imaging, whereas other changes like diastolic dysfunction, regional wall motion abnormalities, and ECG changes happen much later. And these are the ones which are picked up by pharmacological stress echocardiography and also by MRI. As we go down, the tests become more specific. So what are the various methods that are used for stress echocardiography? More commonly, of course, we use an inotropic agent, which is dobutamine, with the help of atropine. It has beta-1, beta-2, and alpha-1 agonist action. And at a lower dose, it has a balanced effect on the peripheral vasculature. And at a higher dose, there is a greater beta-2 response, which leads to peripheral vasodilatation and hypotension. On the other hand, there are some vasodilators like dipyridamole and adenosine, which cause maldistribution of blood flow. This is a less sensitive test for regional wall motion abnormality, and it is better for relative perfusion changes detection. Now, when it comes to a pharmacological stress echo, more specifically a dobutamine stress echo, we can have a big scope of various diagnostics which we can pick up in a particular patient. In addition to the basic parameters like the ECG and the heart rate and blood pressure, we are able to see the regional wall motion abnormality and wall thickening. We can see ejection fraction changes. We can get very nice pictures of transient LV dilatation, which points towards multivessel disease. So measuring the end systolic volume on an echo in a dynamic way, you can see the LV cavity dilating in front of you is something which is very useful, and it gives you a prognostic indication and tells you that there is something wrong. We can calculate the ischemic threshold of that patient. An ischemic threshold is the heart rate at which the first ischemic changes are detected on stress echocardiography divided by the maximum heart rate as per the age of that patient. If it is less than 60%, we can prognosticate the patient and tell that the patient has a higher risk. We can use strain and speckle tracking and also use contrast echocardiography to see the segments in a better way and to delineate perfusion abnormalities. As I mentioned, risk stratification and prognostication is very useful when it comes to the use of dobutamine stress echo. When you have regional wall motion abnormality, the event rates rise up to more than 6%. When there's a transient ischemic dilatation, the rates rise up to 19% annually. We use dobutamine stress echo when you want to assess a preoperative risk. As I mentioned, the ischemic threshold also helps in telling you the prognosis, and contrast use helps to improve the prognostic value. Now, this is a very interesting graph which shows that even if you get a false positive dobutamine stress echo, it does not mean that you just stop there, because it has been shown in this study that even with a false positive dobutamine stress echo, which was shown on coronary angiogram to have a non-obstructive CAD or a normal coronary artery, the survival still decreased over follow-up, which means that this points to the presence of something microscopic. There could be microvascular dysfunction, or the patient could have a subclinical cardiomyopathy, which was unmasked by the dobutamine stress echo test. This particular pattern is not seen with a false positive exercise stress echo. When an exercise stress echo is positive and it is proven to be normal on a coronary angiogram, the survival is similar. It does not dip. Other very important uses of using a dobutamine stress echo is we can find out other causes of chest pain or dyspnea in a patient, like HCM, Takotsubo cardiomyopathy, pericarditis, embolism, valvular diseases. One important issue is when patients have dyspnea, you can do a lung scan immediately, dynamically, and you can find that there are B lines, there are comets, which point to the presence of fluid in the lungs, which have happened there and then because of the exercise that was induced. Also, dobutamine stress echo is useful to detect viability if there is a baseline regional wall motion abnormality. This is an example of a dobutamine stress echo in which various heart rates have been denoted here. This is a 4-chamber view in which the LV is on this left side. Here you can see at higher heart rates, there is a dilatation of the LV cavity. The end systolic volume has increased. And here you can see that the lateral wall has become akinetic. In this particular group of cine images, this is a 2-chamber view in which initially the LV cavity is nice and triangular. It becomes dilated at higher heart rates, and the inferior basal and mid wall has become akinetic. So how do you talk about the performance of various non-invasive stress tests to detect an anatomically significant coronary artery disease? Everything is about sensitivity and specificity. When you talk about a coronary CT, it has a very high sensitivity, but its specificity is quite low. Similarly, when you talk about nuclear imaging tests, they have very high sensitivity, but again, their specificity varies. Dobutamine stress echo also has a good amount of sensitivity, and it maintains a good amount of specificity as well. When you look at something known as the likelihood ratio of a test. That is, when a particular test is positive, does it really mean that the patient does have that disease? You can see that with the dobutamine stress echo, its likelihood ratio is quite high. So it has a very powerful index to rule in a particular disease.
My apologies, Dr. Inamda. I think your time is up.
Yeah,
if you
this
could
is my last slide. Yeah, this is my last slide. So let's keep it simple. Let us avoid decision fatigue. Let us avoid paradox of choice. Let us just choose a test which will help us assess a patient in terms of morphology, physiology, as well as prognosis. The latest guidelines have mentioned that when it comes to stress tests, the test choice should be guided by local availability and expertise. They have not put one test above the other. And when it comes to a dobutamine stress echo, you have to consider the patient characteristics, the accessibility and simplicity of the test, the local expertise, the costs, and also to be a bit flexible and to not hesitate in adding or sequentially adding other tests in case you feel you want more information. Thank you.
Thank you, Dr. Shonali, for a very informative talk. Now we'll be moving to our next talk. And from the red corner, we have Dr. Purvi Parwani. And I'll again take this opportunity to introduce Dr. Purvi Parwani, who is my MBBS senior. And we are both from the same city and from the same college. And her contribution in the field of cardiology has made us all proud. She is an amazing teacher and a wonderful person. And she would be debating on stress CV MRI would be the best strategy in this case. Dr. Purvi.
Thank you, Pooja, for that lovely introduction. It's always homecoming for me, and really happy to see all of you here. So I'll be speaking about stress CMR today. My disclosure is that I'm a multimodality imager. So quite frankly, in any of these categories, if you put me, I can debate and I can tell you why that modality is good because, I know my toolbox. I have many tools in my toolbox, and according to the patient I see, I use those tools very effectively. And, but right here, I am here to present my favorite modality, and that is CMR, no doubt. So what I'm going to do is I'm going to let the science speak for each modality and tell you why stress CMR is a good strategy. So we have this 53-year-old woman. She has hypertension, hyperlipidemia, severe arthritis. We haven't been told why she has severe arthritis, maybe some rheumatic condition. We don't know. She has atypical angina. And as Dr. Imamdar very nicely pointed out, that's not the term we use anymore with new guidelines, but nonetheless, she has chest pain that has been thought to be anginal, maybe not, maybe. And she does have some non-specific ST changes. She hasn't had any previous cardiovascular evaluation. So the question here is best stress modality, and rather than the cardiac cath, which I see happens more often in India than not. So I think the best thing is why this patient has, the questions I want to answer is, what's the cause of this chest pain? Is it truly cardiac or not cardiac? Why does this patient has ST changes? How can I get this information, all these questions answered, if possible, in one modality? Because as we know, cost is a big issue back home. And what does this patient need next? Do they really need the test or do they not? And what am I going to tell this patient about their overall prognosis? Particularly given the risk factors they have, maybe they have rheumatoid arthritis, maybe they are menopausal, and they do have this non-specific ST changes. So when it comes to the best stress modality, I want to go for a test that's accurate, safe, appropriate, has management and prognostic implication, and also is cost effective. So, for the consideration of this debate, these are the points that I'm going to touch upon, whether getting an anatomy in a patient like this, is it going to help us with her ST changes or her chest pain? Are we going to be able to tell her what exactly is causing her chest pain? Are we going to be able to tell her that she affords all the radiation that a CT or a nuclear stress test brings? Or if her dobutamine stress echo is negative, she should go home and rest and forget about having cardiac chest pain. So that's what I'm going to debunk here. And I'm also going to tell you the sensitivity and specificity of each test. So as Dr. Imamdar very nicely pointed out, yes, this patient, if you take the criteria by pretest probability, she kind of falls into the low risk category, but then she also forgot why she has the increased likelihood of having CAD. She already has the risk factors for CAD. She has hypertension, she has hyperlipidemia. We have already been told she has some sort of arthritis. Rheumatic conditions, as we know, are responsible for premature coronary artery disease. And maybe she's menopausal. That information wasn't given to us. She's 52. She's in that age group. So again, for women, this pretest likelihood, in my opinion, doesn't matter, because I'm going to take that individualist approach. And for this particular patient, I think she has increased likelihood of having coronary disease. Now, I'm not using the word macrovascular disease or microvascular disease, because that's what we are going to figure out. As we know, 30% of the women that present with chest pain, they have microvascular disease, and none of the modalities that my opponents are going to pose do give any information on microvascular disease, except PET, which unfortunately is not available in India. So also, as we have already pointed out, that this patient has resting EKG changes, and these resting EKG changes, again, put her in a different category. So although we thought that this patient may be in low to intermediate risk, in my opinion, this patient has clinical likelihood of CAD. All the present models kind of underestimate the women having CAD, particularly the microvascular CAD. So these all things need to be considered very carefully. And as Dr. Imamdar very nicely pointed out, the guidelines suggest that in this case, you can go for anatomical testing or you can go for stress testing. And I will tell you why stress testing is a better approach, but compared to anatomical testing, and within the stress testing, why stress CMR is the best approach. So of course, we have already looked at the sensitivity and specificity, all the modalities kind of, particularly if we talk about dobutamine stress echo, unfortunately, the problem with the dobutamine stress echo is when it is negative, it does not tell me much. It doesn't tell me much about the microvascular disease. When it comes to stress MPI, we all know that if there is no attenuation correction, half of stress MPI that we read are wrong. And of course, I'm going to talk about why coronary CTA is not a good modality. So let's talk about the accuracy. So this is CE Mark trial where they took patients with intermediate probability CAD, and they compared them head-to-head SPECT, and CMR was able to perform better than SPECT in this study. This was the first study. This is the real-world patient that we see. So we already have established in the literature that stress CMR is better strategy than SPECT. When we look at stress CMR, because of this black blood sequence that we use, not only we are able to tell you about the ischemia, but also we can tell you about the anatomy. So it's not just an ischemia test, but if you use one more sequence, you are also able to see coronary arteries very well. Now, when we look at the safety, look at the radiation on the right side. When I Googled nuclear stress tests in India, all that came up was thallium. Thallium is a criminal activity, in my opinion. No one should be using thallium in 2022. Look at the radiation that thallium, and technetium, these isotopes use. If it was my family member or my patient, I would never want them to get that kind of radiation. And also same applies to cardiac CT. Yes, retrospective, cardiac CT perhaps here has way more radiation than, the CTs that we utilize these days. And newer CTs definitely have less radiation, but it's still radiation. And one can argue that if you want to go for an anatomical test, perhaps cardiac cath is not a bad idea, because it's probably, if you use the contrast and the radiation wisely, you can give the lot of information in the same amount of radiation. So to my mind, particularly in Indian subcontinent, anatomical testing, when we look at the cost and the radiation, perhaps cath is a better idea. But when it comes to ischemia, again, the cath won't tell you why this patient has chest pain. It would just tell you that there is no atherosclerosis and there is no obstructive CAD. So in my opinion, safety-wise, other modalities, except dobutamine echo here, kind of take a hit. When we look at the management and prognosis, this was a NEJM article. And this article, Nagel's group from Germany, they compared in a multi-center trial role of stress CMR compared to FFR. And again, compared to the FFR strategy in patients with risk factors, this strategy, were similar. Also compared to FFR strategy, stress CMR performed very well when it came to downstream testing. We all know with CT scan, with a coronary CT, downstream testing is, way more likely, particularly in real world experience, because we all get scared of atherosclerosis. We all get scared when there is an intermediate atherosclerotic lesion, and we want to give that patient benefit of the doubt and make sure there is no obstructive CAD. So in this paper, particularly stress CMR showed not only it was cost effective because it led to less downstream cath, which a lot of Indian cardiologists perhaps won't like, but it's a cost effective strategy even when it comes to FFR. And this again was proven in the real world experience. So this is the registry data, again, multi-centers across the United States, and it showed that not only CMR reduced the need for coronary revascularization, but also this less revascularization was associated with better outcomes. So it wasn't that, it was a false negative study. It actually, a negative study meant that those patients had excellent prognosis. So I think that I have, rested my case here with the management and prognosis. And then let's come to cost effectiveness. So I wanted to talk to this audience about the cost effectiveness in India. Granted, I looked up the prices on Google yesterday, but a CTCA in India cost around 15,000, and nuclear is 42,000 rupees. Dobutamine stress echo is the cheapest, 5,000, because it has been, it has been there long, and a stress CMR costs probably between 8 to 10,000 rupees, according to the Google estimate. Now, I know that I can be wrong, but when we look at the cost-effective analysis that is already done for CMR, what it showed is the no imaging strategy was associated with low quality life years, but when they applied, and the worst cost was associated with angiogram, but when they applied both the cost as well as the better quality of life, it was the stress CMR that that was able to shine in comparison to any other stress modality. So again, it's a one-stop shop. You get one test and you're going to get all your answers. And that's one of the biggest, arguments for using CMR. Now, microvascular disease, again, we know for women, particularly for women that we presented here, microvascular disease, 30% of the women have it, and none of the other stress modality, include SPECT MPI, is able to tell you if a woman comes with microvascular disease. Now, this concept may be new, but we all know that women do present with microvascular disease, and unfortunately, anatomical tests like CT are not able able to figure this out. So if we just pay attention to this slide, by using what we call quantitative stress CMR, we are able to tell you if that patient has the myocardial blood flow that is optimal or not. If the myocardial blood flow right here on the right side, if you pay attention, if the global stress myocardial blood flow is optimum more than 2.25, that patient has normal coronaries, both macro as well as micro. You can tell that patient that go home, this pain that you are experiencing is not cardiac, because you have told them both about macro and microvascular disease, versus if you have less myocardial blood flow, then you can figure out what exactly is the cause for that patient's INOCA, also known as ischemia without any obstructive coronary disease. So again, these are just some more, slides. So this is the normal microvascular reactivity. So you can see this is the rest CMR on the right side below. This is the stress CMR. And look at this abnormal microvascular activity. At rest, you have nice perfusion, but at stress, you have this rim of darkness in the endocardium, which is classic, for microvascular ischemia. Similarly here, a globally normal will shine up on the left side, and on the right side, the blood flow is low and it is globally low, and that can be responsible for microvascular disease. Now, why coronary CT is not a good modality, and I will debunk some of the ischemia trial beliefs that people have. Is this test going to tell you, what is the cause of chest pain for this patient? The answer is no. Am I interested in knowing what's the cause of the patient's chest pain, or am I interested in knowing how much amount of atherosclerosis does the patient have? I'm not interested in knowing what kind of atherosclerosis this patient has. I'm more interested in knowing, why does this patient have chest pain? My CT colleagues often use the argument that CT, using the PROMISE trial, that CT and PROMISE and the SCOTT trial, that CT led to better outcome. But we must keep in mind that CT led to better outcome because every patient got atorvastatin and aspirin. And my argument is, why can't we just tell all our patients with mixed hyperlipidemia to take atorvastatin and aspirin whenever it is appropriate? So why do a test and tell them that you have atherosclerosis? Why not just directly apply that preventive strategy, tell our patients to apply dietary and lifestyle modification? Now, the positive predictive value because of this reason for CT is not very robust. Is CT a gatekeeper for CAT? I would argue not. There are a lot of real world ER studies which have shown CT leads to more downstream CAT, which is not the point. And that's what does not make it cost effective, particularly in Indian subcontinent. And the argument all my colleagues make, I love coronary CT, but they like to make the argument of left main disease. Now, let me remind you, in community, the left main disease is only present in 1 to 2% patients. It is not very common. And a stress CMR would be a great strategy because it does not have balanced ischemia, as you can see with stress MPI or any of the nuclear modalities. So if a patient has left main, stress CMR is going to show you. So in my opinion, the ionizing radiation also makes a CT a safety point questionable. So for all that reason, a coronary CT for this patient, in my opinion, would not be ideal choice. So I have rested my case here. I've shown you why. Yes, I've shown you why CMR is safe, efficacious, appropriate, has management and prognostic implications, and it would be the best strategy for this patient. So I was going to show you some examples of the stress CMR. This is an example of a completely normal stress CMR. On the bottom, you have the resting images. On the top, you have stress images. As you can see, when the contrast agent comes in, there is nice perfusion of the entire myocardium. This patient also did not have any sort of, we could tell her EF and she did not have any sort of previous myocardial infarction. So one test that gave us a lot of answers. And then I will show you real quick what an abnormal stress test abnormal CMR looks like. This is a smoker, a male, substernal chest pain. And look at this patient's stress CMR. So pay attention to those arrows. As you can see in the endocardium, there is less perfusion, particularly the apex has less perfusion all over. And I will, in real quick, I will show you the CAT. This patient also did not have any previous infarct, and on CAT he was found to have multivessel disease, including significant LAD, circumflex, as well as RCA disease. Again, this patient had multivessel ischemia, no myocardial scar, viability was present, and surgeons were able to take him. So if you are interested, check out the stress perfusion series on YouTube by SCMR that we were able to put out. There are 6 sessions and would give you a lot of information about stress CMR. So in my opinion, dobutamine stress echo is not a good choice because it does not tell you about microvascular disease. It also has poor sensitivity. Stress MPI is not a good choice because it has a lot of radiation. It does not tell you anything about the EF accurately, and it does not tell you why does this patient has ST changes. Accuracy can be debated for stress MPI. CT coronary is not a good choice because of the radiation. It doesn't tell you the cause of the chest pain. It does not tell you the EF, and it leads to more downstream testing in addition to not giving you any information about the microvasculature in this woman who is at higher risk of microvascular disease. And of course, stress CMR, because of all the reasons I told you, is safe, appropriate, cost-effective, and evidence-based strategies. Thank you very much for inviting me, and I'll be happy to take question at the end.
Thank you so much, Dr. Purvi. And everybody would agree that it was a wonderful talk with a lot of information and insights. Thank you, Purvi.
Okay, now I would like to tell you that Dr. Andrew Choi has a pre-recorded session. So we'll be playing it now, right here.
Dr. Andrew has actually poetically made it an all-women session. As a mark of respect,
this is
what only
happens.
a pre-recorded session. Our students, play the video.
Hi, I'm Andrew Choi from George Washington University in Washington, D.C. And I'm honored to participate in CardioCon this year. I want to thank Dr. Sharma, the organizers, Dr. Parwani, and others for the opportunity to participate in this debate. I apologize that I can't join you this year, and I hope to be able to come back next year and hopefully even come to India. And so what we want to do over the next 10 minutes is to discuss in this debate, why is CT angiography not only a safe and reliable option, but the best option for our patient presented. These are my disclosures. And so it's presented as a 52-year-old woman with a couple of risk factors: atypical angina, normal heart ejection fraction, and severe bilateral osteoarthritis. And I think to understand why CT angiography would be the best test, we should think about our general goals of CAD imaging. We want a test that's safe, that's simple, that meets appropriate use criteria, allows for diagnosis of symptoms, enhances prevention, is supported by the highest quality randomized controlled trial evidence, aligns with guidelines, and allows for the best downstream decision making. And so as we know, and this audience knows very well, there's a high CAD prevalence in India, particularly in the north and in the south. And when we look across multiple data sets, CAD is a particular issue in young adults, even aged 20 to 40, that over 50% of coronary disease mortality occurs in individuals under the age of 50, and a quarter of acute MIs are reported in patients under 40 in the South Asian population. And in the United States, we can look to these examples of younger individuals, President Bill Clinton in his 50s who had a heart attack, even after a normal stress test. Rosie O'Donnell, an actress who suffered a heart attack at the young age of 50, and Carl Ruiz, who's a celebrity chef on the Food Network, who died of a heart attack at age 44. Where does CT allow us to do? It's a comprehensive assessment. Multiple studies have shown very high accuracy and high negative predictive value for obstructive CAD of over 95% in both stable and acute chest pain. CT allows for the evaluation of non-obstructive CAD for cardiac function if protocoled appropriately, myocardial assessment, mass, aorta, and LVAD. Multiple studies in the Protection 6 registry and JACC imaging have shown that it can be done at low radiation dose around the world and at low cost. About $180 is the reimbursement in Medicare in the United States. So it's at low cost. And so I liken a CT to a Tesla. It gives you all of the modern things that you want in a CAD test. Now, when we look at the spectrum of CAD, cardiac CT will allow for identification of both non-obstructive and obstructive CAD across the spectrum of CAD, and that we should point out that a normal stress test does not equate to the absence of CAD, because a stress test will miss the early or non-obstructive CAD. We know this is important because most ACS occurs in non-obstructive plaques. This is from a trial called ICONIC that did case control from the much larger confirmed registry. And on the left, when you look on a per patient basis, 2/3 of the patients in the ICONIC trial presented that had stable CAD with a later MI had initially 50% or less than 50% stenosis. And that when you look at the culprit lesions from those patients, it was 3/4 had non-obstructive or less than 50% stenosis. CT uniquely allows for evaluation of a sex-specific plaque signature in women. And this is from a review article on the left that we had put together. And women have smaller vessels. They have lower plaque volume and lower CAC score, and maybe non-obstructive, which CT uniquely allows you to identify non-obstructive CAD. Women are still at risk for major adverse events. And it has to do with the plaque type that's present. And from the SECT, we've been able to really identify higher risk plaque features that include non-calcified plaque, low attenuation plaque, that even with non-obstructive CAD have similar prognostic significance to obstructive CAD. Now, when we look at the evidence, there's been tremendous evidence generation in CT over the last 15 years. And this is from an editorial that we put together summarizing this, including a number of major trials, including the ischemia trial, the PROMISE trial. We have a number of guideline statements and education milestones. And so in 10 minutes, I can't go through all of this, but I do want to go through the Scott Hart trial. That, as you recall, this was 4,000 patients with suspected angina that were randomized to standard care, including stress testing, exercise stress testing, versus stress testing plus CT angiography. There was no difference in revascularization. There was an increased use of preventative therapies, particularly in the CT arm. And impressively, there was a 40% reduction in death or myocardial infarction in those patients that underwent CT angiography. And this is attributed to the identification of early plaque, the ability to start preventative therapies, as well as identify those patients that would be best suited for revascularization. And so why is this the case? Again, as we point out, these factors, including increased clinician attention to patients with CAD. When we look at a cost analysis of using a CTA-based approach to guide treatment versus recent drug therapies, based on the treatment effect, the cost would be about $400 per year if you account for the Medicare cost of the CT angiography plus the cost of aspirin and statin generic drugs. If you compare that to a PCSK9 inhibitor, $5,800 US per year. Canakinumab for inflammation, $16,000 a year. And aspirin, while very inexpensive, has not been shown to have benefit in primary prevention cohorts. Now, when we look at guidelines, the European Society of Cardiology guidelines in 2019 reminded us to assess symptoms, look at comorbidities, and assess pre-test probability, including the presence of LV dysfunction or other factors like an abnormal TTT or coronary calcium. And using the pre-test probability for the low to intermediate risk patients, CT angiography is preferred, such as the patient shown here, the 51-year-old, at low to intermediate probability and risk. And so it is a class 1 indication in the ESC guidelines for CTA being recommended as the initial test for diagnosing coronary disease in symptomatic patients if the CAD cannot be excluded by clinical assessment alone. And this is also based on your local availability and patient-specific factors. We can now point to the new 2021 ACC-AHA Multi-Society Chest Pain Guideline. And I was an official reviewer, one of the official societal reviewers for this guideline. And my congratulations again to Dr. Galati, who was the chair of this guideline, and others that were a critical role in bringing the evidence to the national guideline, like Dr. Blankstein, Shaw, Bullock Palmer, who's in this session today, and many others. And so one important point from Dr. Galati was what's new in the guideline is that the redefinition of coronary disease, that it goes beyond just not being just obstructive CAD, but also being non-obstructive CAD, so that those with lesser degrees of stenosis would benefit from optimized preventative medical therapy. When we take a look at intermediate risk patients with no known CAD, how do we now choose among the best imaging tests? Importantly, CTA has a class 1 indication for the diagnosis of CAD, which is new compared to the old 2012 US guidelines, as well as stress testing. And so what are the factors that favor CTA versus stress imaging? Well, if your goal is to identify both obstructive and non-obstructive CAD, you have high quality imaging, a favor towards younger patients. Now, the older age is not a cutoff for CTA, but it favors younger patients. If you're looking for other things like aorta or pulmonary artery evaluation, but uniquely, we can look at plaque composition, high-risk plaque features, lesion-specific ischemia through FFRCT, and we can guide decisions for goal-directed medical therapy and prevention for these patients. In an acute chest pain population, CTA has been shown to contribute to reduced time to diagnosis and prompt and safe discharge. When we think of the right diagnostic test, you might think about potential contraindications, and the guideline lays this out, and you can look at each society's guidelines for more specific details on contraindications. And certainly you might want to avoid CTA in somebody that is unstable, that has chronic kidney impairment, or has an allergy to iodinated contrast. And so the ideal patient by the ACC-AHA guideline is a younger age patient to be able to evaluate for plaque as well as obstructive CAD that has intermediate pretest probability, that might have a prior functional study that's inconclusive, that doesn't have contraindications. And if you want to have rapid diagnosis, safe discharge, and you have high quality imaging available to you. And so when we go back to the patient and why CTA is the best test, it's safe, can be done at low dose, is simple to do, is appropriate, allows for diagnosis of symptoms with high accuracy to rule out obstructive CAD, supported by high quality randomized controlled trial evidence. It aligns with both European and US guidelines. It allows for downstream decision-making, including allowing for identification of early atherosclerosis that would allow for prevention so that we can attack this problem that exists in South Asia and in India. And so in summary, CTA is now class 1 in 2021 ACC-AHA chest pain guidelines, and it allows for improved outcomes and goal-directed prevention by identifying obstructive and non-obstructive CAD. And the last point I'd make is, if it was your friend or family, what is the test that you would choose? And when I talk to many of my colleagues from South Asia and India, their choice would be a CT angiography. Thank you very much.
So after that wonderful speak from all three of you, it's my pleasure to have Dr. Renee. Dr. Renee, it's a pleasure to have you for the session, and over to you.
Great, thank you. Can everyone see my slides? Great.
Yes,
so I'd just like to, thanks. I'd just like to thank the organizers of this year's CardioCon meeting. This is my first time joining you guys. And I'd like to also especially thank Dr. Sharma for inviting me to speak in this session on why nuclear myocardial perfusion imaging is the best option for the presented case. I'm Dr. Renee Bullock-Palmer, the director of the Non-Invasive Cardiac Imaging Program, as well as the director of the Women's Heart Center at the Boer Heart and Lung Center in New Jersey. I have no disclosures, but like Purvi, I'm also multimodality imager, so I could debate on either sides of the debate here this morning. So for women, 60% of symptomatic women have no flow limiting stenosis. And despite this, heart disease is the #1 killer for women. There's emerging data that has significantly contributed to our understanding of the full spectrum of ischemic heart disease in women, which includes obstructive epicardial disease, microvascular disease, coronary spasm, and spontaneous coronary artery dissection. The role of microvascular dysfunction, vascular inflammation, coronary reactivity, and endothelial function and hormonal influences, as well as oxidative stress and coronary size, all have impact on the development of ischemic heart disease in women, and is being increasingly recognized. I'd also like to remind the audience that women have a higher prevalence of plaque erosion compared to more plaque rupture in men. And in older women, the frequency of plaque rupture increases with each decade. So with regards to the ischemic cascade, which shows, it shows here that myocardial perfusion imaging is able to detect ischemic heart disease much earlier than the other modalities that were debated here this morning. In addition to this, microvascular disease can be detected with PET CFR, with coronary flow reserve, and in addition with PET, you also have PET CT, where you can also detect subclinical coronary artery disease. And of course, PET does not have the limitations that other modalities have, such as MRI, where patients who may have devices are unable to have an MRI, or with CT, where patients have renal dysfunction or arrhythmias are not able to undergo CT. Additionally, there are a multitude of other reasons why nuclear stress testing may be useful. In addition to arrhythmias, patients may be obese with poor acoustic windows for echocardiography. They may also have allergies to contrast. And I'll remind you that with the newer software and hardware, we are able to do nuclear imaging with a very low radiation dose, and in some cases, even less than 3 millisieverts. And also, as I will outline later on in the talk, that myocardial blood flow reserve is very useful in women and can be detected with PET. So there's incremental prognostic value with SPECT, and this study that was led by Dr. Rami Dukhi in 2015 has shown that with SPECT, in addition to clinical variables, EKG variables, and myocardial perfusion imaging, you're able to adequately assess prognosis in patients in a stepwise fashion. Moreover, with PET imaging, you also have the additional left ventricular contractile reserve, which also helps in prognostication of patients, and in this particular case, in our female patient this morning. Now, with regards to coronary microvascular dysfunction, this plays a major role in determining myocardial ischemia in many cardiovascular conditions, including angina, with and without obstructive coronary artery disease, and also in cases of myocardial infarction, non-ischemic cardiomyopathy, such as amyloid, hypertrophic cardiomyopathy, Takotsubo syndrome, and heart failure. And many of these have a greater prevalence in women compared to men. Many molecular, functional, and structural mechanisms are also involved and are related to the underlying disease process. Now, coronary microvascular dysfunction is more prevalent in women, as in our case, and our patient presented, in hypertensive patients, also in our patient that was presented, and in patients with dyslipidemia, again, in the case that was presented. Other populations for patients with valvular heart disease, so particularly aortic valvular stenosis, infiltrative cardiomyopathies, all have a greater prevalence of coronary microvascular dysfunction. Now, the role of ischemia may be caused by epicardial and also microvascular structural and functional mechanisms. Epicardial causes determining ischemia includes acute plaque disruption with lumen occlusion and epicardial coronary spasm, myocardial bridging, and progressive obstruction with vessel narrowing of a previously present plaque. Coronary microvascular dysfunction can result from an abnormal vasodilator ability of the microvasculature and also compressive external forces affecting the intramural microvessels and, of course, microvascular spasm. Now, coronary microvascular dysfunction is not benign and has a greater implication for women with regards to adverse outcomes. In these diagrams that were published in the Journal of Nuclear Cardiology, led by Dr. Viviane Cecchetti in 2017, the diagram on the left shows the distribution of coronary cardiovascular risk by PET MPI, coronary flow reserve, and a coronary flow reserve that was greater than or equal to 2 is associated with a relatively low rate of annualized cardiac death. Conversely, coronary flow reserve less than 2 are associated with substantially worse prognosis, which may result from vasomotor dysfunction arising from a combination of pathophysiologic CAD phenotypes and also multivessel obstructive CAD as well, diffuse atherosclerosis, and coronary microvascular dysfunction. On the right, there's a log-adjusted hazard for major adverse cardiac events in females versus male patients, and it varies as a function of the PET MPI coronary flow reserve. Now, looking at the gender-specific differences, you can see that the effect of gender on cardiovascular events was modified, shows significant difference in outcomes for women compared to men, where for that particular coronary flow reserve, for example, a coronary flow reserve of 1.4 or 1.2, that women have a far higher prevalence of major adverse cardiac events. So bringing it back to our patient, it's a 52-year-old female. She has hypertension, dyslipidemia, which are cardiac risk factors. She also has severe bilateral obstructive arthritis of the knees, which could be due to a multitude of reasons. And also for this reason, she's not able to do an exercise nuclear stress test. So of course, a pharmacologic option is the only option for this patient. Now, the possible etiologies for this patient's angina could include epicardial macrovascular disease or indeed coronary microvascular dysfunction. So as you know, the chest pain guidelines that were published last year in October 2021 also helps to tease out the reasons why myocardial perfusion imaging is a choice for this patient. And as was mentioned before, this was chaired by Dr. Martha Galati, Dr. Philip Levy, and Dr. Mukherjee, and I was fortunate to be a part of the writing group. So in this document, the clinical decision pathways are very important for patients presenting with chest pain. With regards to the choice of testing for patients with an intermediate risk presenting with stable chest pain, these patients may be referred for functional stress testing or anatomic testing. But I will argue that functional stress testing is the option for this patient. Now, one must also remember that it is important to look at the patient-specific features, whether or not they've had an unestablished CAD or history of CAD. This patient has no history. Whether or not they've had prior test results available, and also test availability and local interpretation expertise at one's own institution. Now, in the guidelines, there are several clinical scenarios that were outlined that favor stress imaging, such as patients with an intermediate pretest probability in whom more obstructive CAD is suspected. And I would argue with this patient, 52 years of age, she's leaning more towards that group. And also, additionally, in clinical situations when ischemic guided strategy is required, especially in cases where there's established CAD or in cases where you're looking for coronary microvascular dysfunction, as I would argue for this patient. Now, cardiac PET with myocardial blood flow reserve also has the benefit of being able to detect coronary microvascular dysfunction. Now, in this patient who is unable to exercise, the options for her with regards to myocardial perfusion imaging is SPECT or PET. However, because we're looking for coronary microvascular dysfunction, I would argue that PET MPI would be the choice for this patient. And as I had mentioned before, that these patients are able to have this test with a very low radiation dose of less than 3 millisieverts with the newer software available. So with the chest pain guidelines in the evaluation of patients with stable chest pain, it's very important that the pretest probability is assessed. And in this patient who is 52 years of age, female presenting with chest pain, she's lying more in the intermediate range here, more towards the intermediate range here. Now, atypical is out with regards to the guidelines. In this patient presenting with chest pain, she would either be cardiac, maybe cardiac, or non-cardiac. And in this particular case, I would argue that she is in the maybe cardiac range. And therefore, in our patient, I do believe that she's at an intermediate pretest probability for having obstructive CAD. So what are the options for this patient? So with regards to myocardial perfusion imaging, PET MPI or SPECT MPI has a class 2A recommendation in these patients. And if PET is available at your institution, then PET is a choice for this patient. Now, this is a case in our lab where we had a patient that underwent a nuclear stress test, which was a pharmacologic nuclear stress test. This is a 72-year-old female, and you can see that she has a very large area of anterior septal, anterior defect that was moderate photon reduction, and it was reversible when compared to the supine rest images. However, in our lab, we do stress prone on most of our patients, and you can see that in the stress prone images, this defect completely resolved, indicating that this study was indeed normal. Now, also, this patient also had adjunctive use of coronary calcium assessment, and her coronary artery calcium score was 0. So why is this important? In the chest pain guidelines, they recommended that attenuation correction or two-position imaging is reasonable with a class 2B recommendation to decrease false positive findings. And I would argue that many labs doing SPECT or myocardial perfusion imaging should have a method of attenuation compensation, either with attenuation correction software or two-position imaging to improve your accuracy of your reading. Additionally, the chest pain guidelines recommended in patients who have no known history of CAD, this patient had no history, that these patients would benefit from adjunctive use of coronary calcium scoring and has a class 2A recommendation to further prognosticate the patient. Now, with regards to the chest pain guidelines, they had also included assessment of coronary macrovascular dysfunction in the guidelines, and also ways in which we can assess these patients. Now, it's very important that with regards to the myocardial perfusion of the heart, that we not just look at macrovascular disease with epicardial disease, but also looking at macrovascular circulation, which is a benefit of PET with myocardial blood flow reserve. And this is an example. This is the last case of a 49-year-old female who presented with recurrent chest pain, multitude of tests, including cardiac cath, which were all normal. And she had was referred for PET CT with calcium scoring. And you can see that the SCOUT images that was used for attenuation correction showed no calcium coronary calcification. Her perfusion was indeed normal. However, with the myocardial blood flow reserve, you can see that in all three territories, the LAD, the circumflex, and the RCA, the myocardial blood flow reserve were all less than 1.5. This is 1.3, 1.25, 1.43, and her global flow reserve was 1.33, indicating that this patient indeed had coronary macrovascular dysfunction. And with the guidelines, they recommended that PET MPI with myocardial blood flow reserve has a class 2A recommendation in these patients to assess for the presence of coronary macrovascular dysfunction. So I would argue that nuclear imaging with PET CT with myocardial blood flow reserve assesses the entire coronary tree from the subclinical atherosclerosis via the assessment of coronary calcification on the non-contrast CT images to the epicardial macrovascular circulation with MPI, myocardial perfusion imaging, to the microvascular circulation assessing endothelial function with myocardial flow reserve. And indeed, in this patient, I believe that this is the most comprehensive non-invasive assessment for this patient. So in summary, pathophysiology of CAD is different in women compared to men, and the women are more likely to have non-obstructive disease. In addition, the diagnostic test strategy for chest pain should be determined by the question that's being asked of the test, and also whether or not this patient has had established CAD or not. Now, one must also remember the availability of testing at one's own institution and the interpretation expertise, and not to forget that coronary macrovascular disease is very prevalent in women and should be further diagnosed with PET MPI if available. And it's also prevalent in not only women, but in hypertensive patients, patients with hyperlipidemia, cardiomyopathy, and also valvular heart disease, such as aortic valvular stenosis. And as I had indicated, PET CT with myocardial blood flow reserve assesses the full spectrum of the coronary circulation from macrovascular epicardial disease to microvascular disease. And I rest my case here. Thank you very much.
Thank you so much, Dr. Rene. And thank you so much, all the speakers, for your insightful and informative talk. I think that Dr. Purvi has convinced me that I think that MRI gives a lot of information on structure as well as hemodynamics of the heart altogether. So if we keep the debate apart, I think MRI would be the best choice considering its broad diagnostic capacity. But we cardiologists have our toolbox. And as Dr. Purvi rightly said, that we need to choose our tools wisely as per our patient's need.
Thank you, Pooja. I know you may be a bit biased because you got
yeah, so I think we need to bring out another aspect to this, and Purvi, being from Indian ethnicity, would understand. Moms are so difficult to convince, so are wives. You know, they would say, I don't have a pain. I don't want myself to be going to get a checkup. I'm doing fine. I don't want the day to be, you know, lost for my son or my husband. And usually they refrain from a checkup. That's a bigger social problem rather than what to choose in our side of the world. And the other problem that has now creeped in is the free access to healthcare when you're hospitalized, but outpatient you need to pay from your pocket. Which means if you're hospitalized, your angiogram is free with the various schemes that have come in, including the social healthcare sector, including in India, where you have Pradhan Mantri Yojana, the Prime Minister scheme, where everybody who's at below poverty line gets a free healthcare, which is 1/3 of in India. And if you want to get even a EKG done, you have to pay out of your pocket. So that is another aspect that also needs to be looked into. And I believe that's also the case with the reimbursement, probably in West as well, because you need to justify every imaging that you do on outpatient basis. I can have comments from Dr. Purvi and Dr. Rene as well on this aspect. Is the reimbursement an issue for procedures in West as well for whatever you do on outpatient basis, say cardiac MR or say CT or even nuclear imaging?
Yes, I agree with that. Our hospital, we actually serve, population, very high prevalence of Medicaid patients. And I do have that challenge sometimes that there are patients that definitely need the test, but they're not able to have it covered by the insurance if it's done as an outpatient. And sometimes if it's unstable angina, I'll just have to admit the patient and get the studies done. So I do agree with that. Thanks.
I would say, Kamal Bhaiya, the other side of the story that I had seen a lot before I left India is women are not paid attention. Their chest pain, often is considered, the money should not be spent on a woman. The money should be spent on the breadwinner. So that's the harsh reality of the India that I lived in. And I know that still in small villages, things have not changed much. So whatever you say, I think women are still ignored all around the world, but more in our countries than, other part, in my opinion. When it comes to stress CMR, I think access is a bigger issue than the reimbursement. I think that reimbursement in general, at least in where I am in Southern California, it's not been an issue with, we do all of the imaging. We do dobutamine stress echo, SPECT MPI, PET, as well as stress CMR, and it's not been an issue that much. That's all I have.
Our eminent speakers have given very impressive lectures. I have a question to all of the speakers. Do we have any approach to the diagnostic modality as a comparison between the Asian Indian women and the Caucasian women for this heart disease? What can be, is there a difference or is it the same everywhere? Is there any data about it? Any trials, any studies about it?
I don't think so. Sonal, you want to take it?
No, I don't think there are any studies, but the point, especially with a lot of East Asians and stuff, the coronary vessels are very small, and there's a higher prevalence of coronary microvascular dysfunction. And I would argue that in these women that PET and also MRI, I'll turn it to Purvi, would be valuable.
No, unfortunately, no head-to-head trial. Hopefully, one of the Indian centers can look up. I think there is something called Dr. Saxena. Can you please mute yourself, sir? Thank you. There is a cohort called Masala study out of UCSF that has studied South Asian population, particularly the Indian population, and they have suggested that coronary calcium is way worse in Indian population. But I don't think I have seen any gender differences. Dr. Walkman is also an expert on women's cardiovascular disease, so if she wants to comment something, feel free, Annabelle.
Yeah, no, as you know, we wrote the scientific statement paper on cardiovascular disease in South Asians in the United States. And unfortunately, the South Asian men and women have worse coronary artery disease than a lot of other races and ethnicities. Women definitely have, earlier heart disease than Caucasian women, but the men have really bad disease. They have early and severe coronary artery disease. And this is something that a lot of South Asian doctors know, but I don't think a lot of other doctors know. And that's why we wrote that scientific statement paper to raise awareness about the heart disease in South Asians. Whenever Americans talk about Asians, they lump all of us together with the East Asians who do have less coronary artery disease than South Asians and Filipinos. And so we wanted to highlight the severe coronary artery disease that we're seeing in young men and young women from South Asia.
Thank you.
Okay, ma'am. Thank you so much. Thank you.
So anything else, any other comments from the chair, or we move to Dr. Annabelle's session itself, which is another interesting session on atrial fibrillation. In India, the AF ablation is something that's not very often done. And that's why what Dr. Annabelle is going to talk about is going to be very important. And that's the debate that we have. So thank you, everyone. Thank you for the previous session. Thank you, Purvi, Dr. Sonali, Dr. Rene, and Dr. Andrew, all the chairs, Dr. Pooja, Dr. Neha, and all the moderators, Dr. Archana and Dr. Bhumi. So we move to next session. Can you have the slides? For the next session, I invite Dr. B.D. Shukla, Dr. Ashish Saxena, and Dr. Marmik Brahmbhatt, who are all leading physicians of the town, as moderators. And we have Dr. Anup Gupta, Dr. Chirayu Vyas, and Dr. Hiren Patel. All of the three guys are interventional electrophysiologists. So that's the interesting session, chair that we have. I would request Dr. Anup to introduce both our speakers first, and then the case scenario, and then hand over the session to the speakers.
Thank you very much, Kamal, for inviting me and giving me this responsibility of chairing this session. So the case is a 54-year-old man with a paroxysmal recurrent atrial fibrillation, past history of COVID positive, with a mild COPD, with a normal LV function, mild pulmonary hypertension, no coronary disease. So we are going to discuss rate versus rhythm control. So for rate control, Dr. Annabelle Wogman is going to speak. She's a MD cardiologist in Chicago, Illinois, and affiliated with multiple hospitals, including Rush University and Rush Oak Park Hospital. She is also a professor in Rush University, US, and more than 2,000 Google Scholar citations. So that's quite impressive, and special interest in atrial fibrillation. And for rhythm control, Dr. Rahul Bhardwaj, again from the United States, is going to speak about the rhythm control, particularly AF ablation, PV isolations and all. So Dr. Rahul is working in San Bernardino, California, and obviously did his internal medicine and then cardiovascular training and the electrophysiology training. And again, he has got a special interest in AF ablation. So we will have both the talks simultaneously, one by one, 10 minutes each, and then we will have discussion with Chirayu and Hiren also. So it's over to you, Dr. Annabelle.
Thank you so much. Let me try to share my screen. And can you see that? Okay. Thank you so much for the organizers, especially Dr. Kamal Sharma for inviting me to speak today, and Dr. Purvi Parvani for inviting me to come to this conference. I look forward to debating or discussing this case with Dr. Rahul Bhardwaj, and I heard that he had some music to go along with our rhythm strategy. So, I'm going to have to come up with something as well. Thank you, Dr. Gupta, for presenting that case. Just to summarize, the fact that he's a young man, 54 is young because I'm 10 years older than he is. He's a young man with paroxysmal, and I bold the paroxysmal here because that means that it's not that long of a AFib duration. We'll just define that. He has mild COPD, which can factor into the decision making of what drugs he should be on potentially. He has a past history of COVID-19, which we're going to talk about. But as you mentioned, Dr. Gupta, he has a normal echo. He has a normal coronary angiogram. So there's no doubt that the preferred strategy would be rate control. I mean, this is not that hard. It's so simple that it's as simple as what Michael Jackson said. So this is, okay, Michael, that's enough. So this is the European Society of Cardiology guidelines, 2020 guidelines for atrial fibrillation. A, of course, is to avoid stroke and anticoagulate. This man's CHADS VAS score is 0. And he's 54. So age does not factor in, it doesn't increase his risk of stroke. He's never had any stroke or any other confounding disease that would increase his stroke risk. So he should not be anticoagulated. But the question is, what is better for his symptom control? And that's where rate versus rhythm control factors in. And then C is for detecting and managing his risk factors and concomitant diseases. But the question of rate versus rhythm is always an issue. And we've studied this. I've been involved in many studies looking at whether rate should be the right way or rhythm should be the right way. For this case, it's rate control. So there's no doubt about that. But let me just make sure that everyone is on the same page, because every guideline seems to change the definition of atrial fibrillation just to make sure we're all on the same page. Paroxysmal means atrial fibrillation that terminates spontaneously or with intervention, such as the AV nodal blocks within 7 days of onset. If he had persistent or long-standing persistent, it may be good for him to have rhythm strategy, but we're talking about paroxysmal here. Please stop using lone atrial fibrillation or chronic atrial fibrillation as the ESC guidelines say. But let's just talk about what rate control means. It is the background therapy for all patients with atrial fibrillation. We need to decrease the risk of heart failure with fast atrial fibrillation. And so we need to control that AV node. And we control it with drugs or with ablation. But our goal is now a lenient rate control, because it was found that if we aggressively decrease the rate, that some of them were having dizziness and passing out. So now we have lenient rate control as long as the heart rate is less than 110 beats per minute on a 12 lead, which means that they're resting. They are okay. You can continue that treatment. However, if they're having symptoms, if they're short of breath, or if they're still having palpitations with that control of less than 110 beats per minute, that's when you lower the heart rate a little bit more. And then if they have a pacemaker controlling their ventricular rate, you can lower that rate as well. So only consider rhythm control if the patient is very symptomatic. So these are your options. We have many options in our armamentarium of rate control. We've got metoprolol, atenolol, esmolol. I like nebivolol for women especially. It lowers their blood pressure and they don't feel as tired. They don't have as many side effects as they do with metoprolol. These two drugs, carvedilol and nebivolol, are especially good for lowering the blood pressure in these patients. So you have those good options. If a patient has severe, as opposed to mild COPD in this case, if a patient has severe COPD, then only then would you try verapamil and diltiazem as the non-dihydropyridine calcium channel blockers. I hardly ever use digoxin anymore because it's been associated with increased mortality, especially high plasma levels of 1.2 nanograms per milliliter. And especially in women, I don't like to use digoxin because there is an association with increasing breast cancer as well. And if absolutely necessary, we can use amiodarone for rate control. I hardly ever use that because they might convert. And if you haven't anticoagulated the patient, it might not be a good idea. But if the patient really needs more rate control and they cannot tolerate the others, then amiodarone is an option. So like I said, the patient has mild COPD, so you can use the beta blockers. You should not hold beta blockers in somebody with mild COPD, especially the beta 1 specific beta blockers are fine. Now, he has a past history of COVID-19. What does that do for his case? We know that new onset atrial fibrillation has been seen, but it's low. It's 3.6 to 6.7% in patients without cardiovascular disease. However, in patients with cardiovascular disease, it's very high. You can see as much as 36% of patients with cardiovascular disease have atrial fibrillation during their COVID bout. And in the last COVID task force health from Italy, they showed that up to 25%, so a quarter of patients who did not survive COVID had atrial fibrillation. So it's a marker of increased mortality in patients with cardiovascular disease. So I hope I've convinced everybody that this patient should only be treated with rate control. Thank you so much.
Thank you very much. So, Rahul, you can deliver your talk.
Okay, how do I share my screen here?
If you hover on the bottom of your screen, there you go.
There we go. All right. Well, thank you for inviting me, Dr. Sharma, Dr. Parwani. And thank you, Dr. Voldman, for that great presentation, but I remain unconvinced. So my side of the debate is catheter ablation is the preferred strategy. My name is Rahul Bardwaj. I'm an electrophysiologist at Loma Linda University, which is in San Bernardino, California, or close to there. So the case scenario that I was presented, this is a 54-year-old man. He has had recurrent paroxysmal atrial fibrillation with the prior hospitalization. He had congestive heart failure diagnosed with preserved ejection fraction, New York Heart Association class 2. His medical history is also notable for COPD and prior COVID-19 infection. So the questions that were raised, should catheter ablation be recommended? Is rhythm control with catheter ablation as effective and safe as rate control? So to delve into that a little more, I asked myself a few questions. Is rhythm control better than rate control? And the answer is yes, rhythm control is better than rate control. How effective is catheter ablation compared to medical therapy? Catheter ablation is more effective than antiarrhythmic medications. How safe is catheter ablation? Catheter ablation is getting safer. It's safe and it's getting better. And what is the optimal timing for pursuing catheter ablation? Early catheter ablation is better. And I have some evidence to back this up. So a lot of the guidelines that were presented were based on seminal trials such as AFFIRM and RACE. So in 2000, MERIT HF was published, and 2 years later in 2002, AFFIRM and RACE were published. This is the same year Copernicus was published. To put that in perspective, that was shortly after Y2K. Devdas was just released, and it was 2 years before Facebook. And what has happened since then? A lot. So we've learned about Plavix. We've learned about the Courage trial for symptomatic control of CAD. We've had trials published on dabigatran, Eliquis or apixaban, and rivaroxaban. Force sensing catheters were approved. Watchman was approved. And in 2020, East AFNet 4 was published in 2020. And in the same time frame, a lot has happened in the world. A lot of Bollywood movies with Shah Rukh Khan have come out. And over the years, Shah Rukh has changed, and so has cardiology. And I'll confess, out of all of these movies, the only one I have seen is Devdas. So I'm living in the past, but I would urge that you wouldn't live in the past when it comes to the strategy of how you treat atrial fibrillation, because a lot has changed. And one of the things that has come up is that we've learned about problems with AFFIRM and that prior strategy. In AFFIRM, 4,000 patients were randomized to rhythm control versus rate control. They were followed for about 3.5 years. And the outcome was pretty similar in terms of mortality. But we do know that in that study, 2/3 of patients were on amiodarone or sotalol. Digoxin was used in a large percentage of patients. And a lot of patients weren't on anticoagulation. Only 70% of patients remained on anticoagulation in that study. And there was a lot of crossover. 38% of patients in the rhythm control arm crossed over to rate control. So we learned those lessons and we took them to East AFNet 4. East AFNet 4 was a study sponsored by the German Ministry of Health, and it was done across Europe, multi-center, with about 2,800 patients that were followed for about 5 years. The study was actually stopped prematurely because it reached the efficacy endpoint at the third interim analysis. And what they found was that there was a statistically significant reduction in the risk of death, stroke, or hospitalizations for heart failure or ACS in the rhythm control arm. And this is important because this trial is more relevant to modern practice as compared to the older trials that the guidelines are based on. The older trials, which include AFFIRM and Orbita, largely look at patients over 65, over 10 years older than our patient. And if you look at the efficacy outcomes, when they go to the different components, death, stroke, and hospitalization or death and stroke are both statistically significant. And how was rhythm control achieved? In this study, 40% of patients were on 1C antiarrhythmics, 20% were on amiodarone, and about 16.7% were on dronedarone. So this is far less amiodarone use than the older studies. And we know amiodarone doesn't do anyone any good if it's used in the long term. 8% were initially treated with catheter ablation, and after 2 years, that changed to 20%. And I guess I should add that a lot of symptomatic patients were excluded from this analysis, since we know that rhythm control is better for symptoms than rate control. And a large meta-analysis of PAF trials has been published. This is a recent one from 2021. And this demonstrated in this large number of trials since 2001 that there was mortality benefit with AF ablation. There's a decrease in hospitalizations with AF ablation, and there's an improvement in heart function. Another study looking at the same, but more recently and looking specifically for arrhythmia recurrence showed similar effects. That risk of arrhythmia recurrence was better with ablation. Risk of adverse events tended towards favoring ablation. Symptoms recurrence did better with ablation, and risk of healthcare utilization favored ablation. So what that tells me is that East AFNet 4 not only showed that rhythm control is better than rate control, They didn't even use the most effective and safe rhythm control modality in the majority of patients. So other benefits, quality of life. Dr. Voldman mentioned quality of life, and I think that's one of the most important things we do for AFib. And I struggled with finding just one trial to show you. So I have a bunch. So first, this is the Cabana trial. The Cabana trial was an important rhythm control versus rate control rhythm control with ablation versus antiarrhythmic therapy trial. It was international, multi-center. And what they found was across the board, using multiple scoring systems, ablation was better than antiarrhythmic therapy. Another study looking at force sensing catheter ablation showed similar effects. With catheter ablation compared to antiarrhythmic therapy, there was an improvement in the AFEQT composite score, which is a measure of quality of life. And this was similarly demonstrated by the Cleveland Clinic Group in their self-reported outcomes after catheter ablation. 80% of patients were super responders and had an improvement in quality. And the VisiTac study, which is looking at post-analysis of AF ablation, showed similar improvement. And again, the Cabana trial. And these are just a small number of the studies. All of these studies basically show in the general AF population, catheter ablation improved outcomes as compared to medical therapy, and also improved healthcare utilization in patients. So it's very clear that ablation improves quality of life compared to doing nothing or rate control, and as compared to antiarrhythmic therapy. This is a meta-analysis showing that. So beyond quality of life, there's other data that I want to present to you, and I'll be quick about this because this is still ongoing work. Dementia is something that's important in AFib. We know there's a significantly increased risk of dementia and atrial fibrillation. This is a large cohort of patients. And this happens for a number of reasons: cerebral infarcts, decrease brain volume, cerebral microbleeds, and a lot of that is related to comorbidities, but also because of AFib. And this is a study from the Swiss AF group, and I'll just brief that. Basically, a large number of infarcts are found on random MRI in patients with atrial fibrillation, large of them silent. So 20% of patients had large non-cortical or cortical infarcts, 15% were silent. And then a follow-up study in 2 years after initial baseline MRI, 5.5% of patients had new infarcts. That's 88% of patients who were on oral anticoagulants at the time. So we know that patients have worse neurological outcomes with AF. And there's preliminary data that's showing that rhythm control may improve outcomes. And this is one small study looking at 308 patients who underwent catheter ablation compared to 50 controls. And what they found is that the ablation arm had improvement in the cognitive outcomes. So this is interesting, but very preliminary data. Beyond that, there's improvement in outcomes in quality of life and hospitalizations and mortality in heart failure patients. And we know that heart failure and AF are often linked, and there's a high coincidence of the two conditions. And there are a number of trials, but I'll focus on ATTACK, which showed a significant improvement in mortality and unplanned hospitalization, and CASTLE-AF, which showed the same. And this is in 400 patients, looking at a composite of death or heart failure hospitalization. So I won't spend too much time, but I will mention that both the co-endpoints were statistically significant, hospitalization and death. And that is important to note that quality of life improved even when AFib wasn't eliminated. So I think in the interest of time, I'll just skip ahead. AF ablation is safe, getting safer. We've improved with vascular access, catheter design, ablation technologies. And overall risk of acute complications is low and getting lower. So timing-wise, early ablation is better. I think I'm running short on time, so I'll just skip to the conclusion. Catheter ablation should be pursued early in the disease course for this patient with symptomatic paroxysmal AFib and congestive heart failure. Catheter ablation is more likely to improve his quality of life, quantity of life, and potentially reduce the risk of other adverse cardiovascular events or dementia. Thank you.
Thank you, Dr. Rahul and Dr. Annabelle. So, now I would like to invite my co-chair Chirayu and Hirin and the moderator, Dr. Shukla, Dr. Saxena, and Dr. Brahmbhatt to discuss on the topic, which was very good. So, and I think we will have 8 minutes of discussion right now. So over to you, Chirayu and Hirin.
Chirayu, you need to unmute.
Yeah. Am I audible?
Yes.
Yeah. That's a very good topic to discuss, surely. But here is where I'll just like to put a point straightforward that rhythm control, especially in this patient, would be definitely much better, especially if taken early on. But the problem that we would face, if at all this patient is here in our setup, especially India and Gujarat and our locations, that is where the problems would just start creeping in terms of the patients getting very, very difficult to just understand the fact that this is a form of therapy which is going to get it permanently cured, because it has to be dealt with obviously in 3-dimensional mapping system, which is where the cost factor comes around and the insurance problems turn around. That's a major concern. We just lets these kind of procedures just stay away, and this is how the main problem starts, and that is how we just have to go unfortunately towards rate control.
Can I just say, I understand the difficulty all over the world where there's not a lot of access to catheter ablation, but I think that the one thing that we can do for our patients is to identify what is causing their atrial fibrillation. Just like, the C and the ABC, we have to identify and manage the risk factors. If he's drinking too much alcohol, that's an easy thing that we can encourage him to stop doing. If he's obese or if he has pulmonary hypertension, as the echo shows, he may have sleep apnea, he may have obesity, he needs to lose weight and do those lifestyle changes. The one thing we did not talk about, Rahul, is the shared decision-making, which is in all guidelines now. That shared decision-making is the best way to decide what is the best thing for the patient. So I agree with Rahul that early ablation is good, as long as you have the ways to do it and it's safe and the patient agrees to it, knowing that, Rahul, you have to admit that there is a recurrence of atrial fibrillation, especially after 4 years. You're going to have to probably do it again, hopefully with better tools, right?
Oh, yeah, that is a good point. And atrial fibrillation ablation is not really curative, I would say. As one of the leaders in our field, Dr. Natali would say, it gives us the best shot of AFib remission. And that does count for a lot. Simply reducing the burden of atrial fibrillation has been associated with improvement in outcomes. That was shown in Castle AF in terms of hard outcomes like death and hospitalization. And it has been shown in other studies in terms of improvement in quality of life, including that slide I flashed through from the Cleveland Clinic self-reported surveys. So even though we don't have a cure, I would say, with ablation, we do improve outcomes. Now, with regards to the question about tools, electroanatomic mapping is certainly not easy and widely available in certain parts of the world, but tools are improving and becoming cheaper. I understand cryoablation has now become more prevalent in India. And what we're all looking forward in EP is pulse field ablation, which also may not require 3D mapping. That probably wouldn't be cheap initially. But certainly these new technologies and techniques will improve outcomes, they'll improve safety, and I think give the best benefit to patients.
Rahul, couple of questions from my side. This patient has got a normal LV function with a mild COPD. So what is the threshold of suggesting upfront RF ablation rather than putting them on 1A or 1C medication along with the beta blocker to see how good the response of antiarrhythmic medication?
So that's a great question. The guidelines up until recently, I think actually the most current guidelines would say both are reasonable first-line approaches, but the paradigm in the field has shifted towards catheter ablation first because we know that outcomes are better the sooner you treat. And antiarrhythmic drugs are kind of kicking the can down the road. They're not as effective. And eventually a catheter ablation does become necessary. We know that AFib begets AFib. So the longer you sit in AFib, the worse off the patient will be because you get progression of atrial myopathies. Atrial myopathy occurs for a variety of reasons. There's growth scar with calcium channel changes in the atrial myocytes. But there are a number of reasons why AFib ablation becomes harder after you wait. Atrial gets larger. Basically, we know based on these studies that there's a finite window of opportunity that we have for getting the best possible outcome. So that's why I think the shift has become towards early intervention. Earlier ablation has better outcomes.
That's great. And the other thing is, what is the success rate? If you're doing an ablation, what is the success rate and how do you counsel the family? Probably require a second procedure after the first procedure.
So it depends on the scenario. So in terms of paroxysmal AFib, there's a variety of studies that give ranges between 70 and 95% success rate. And that's a 1-year outcome. 1-year follow-up. I generally quote around 80% with paroxysmal AFib. With persistent, I quote around 60, 65. And I tell them, look, this isn't curative, but when you look at 1C antiarrhythmics, the 1-year outcome is 40% success in keeping people in rhythm. If you look at amiodarone, that's 70% success, and that comes at a cost of higher toxicities. So I generally wouldn't do a 1C antiarrhythmic in most patients unless I had no choice. So when I talk to patients, I tell them that there's a 80% chance this could work. We don't really have good long-term outcome data. So there are old studies that look at 10-year outcomes, and that was done a while ago. Like there's registry data from Europe looking at, I think, a Danish cohort of patients undergoing catheter ablation back in 2003. But it's not really relevant in today's population because our techniques have changed so much with the advent of cryoablation, which I don't do, but catheter force sensing catheters, understanding how to do wide antral circumferential ablation. All these techniques have changed how successful we are. So I don't really have the data to provide patients, unfortunately.
But still, they say if you're going for cryo, you still need to put some RF ablation so that the recurrence is a little less.
Yeah, I don't do cryo, so
okay.
I do RF.
Okay, maybe one or two questions from the moderator. If any of the moderator wants to ask any questions, so then we will wind up the session. I don't think Hiren is here, right? Hiren is
any comments on pill in pocket? I was wondering if that would work because a lot of patients in India do tend to do that. They'll take a pill in pocket in the sense of flecainamide, which is easily available in India, and they would rather not get ablated. Comments from both of you?
Yeah, let me speak first, and then I'll let Rahul talk. I use pill in the pocket all the time for my young patients who have a cardio monitor and iWatch. Who can be told that they have atrial fibrillation because sometimes they have palpitations and it's just sinus tachycardia. But if it's AFib, they're trained to take their pills, and it works really well. So I think it is a great tool for certain people. I think that as catheter ablations improve, and it's available, I think it's an option that we should consider. I mean, I'm very happy with the recent trials that have shown that atrial fibrillation can be treated with either antiarrhythmic drugs or catheter ablations, because there's really no significant difference between the two, but I think catheter ablation will win in the end.
Great. So, Kamal, I think we will wind up the session because it's all.
I think there was a question that Dr. Parvani, which was very relevant about the inflammation that he had from the COVID.
Yeah, please go ahead, answer that, please.
I think that, we do need to wait. This is very similar to the stress that patients experience after surgery, after especially any cardiothoracic surgery. There is a lot of inflammation. But we do know that in patients who do go into atrial fibrillation will probably have atrial fibrillation again. They probably have the substrate that makes them go into AFib. So I would wait to let the inflammation go down. And if they have any recurrences, then I would consider more treatment such as antiarrhythmic drugs or therapy or catheter ablation. Rahul?
Yeah, I agree. I think that if it was just COVID and one-time AFib, I would probably not take action, but the odds are that it will recur. And in fact, in this case presentation, it did recur. It was recurrent paroxysmal AFib. I think the COVID thing was an acute issue that may have been the initial index event that led to the diagnosis, but he may have had it before. And that leads me to something about that previous question about pill in a pocket. I also use pill in a pocket for many patients who have symptomatic AFib. But I think it's important to remember that most patients with paroxysmal AFib don't feel every episode. In fact, they probably don't feel the majority of episodes. So what that implies to me is that while a pill in a pocket can certainly improve quality of life and restore sinus rhythm for patients who have symptomatic events, it may not do a whole lot to prevent progression of disease because they may be having a lot more AFib than we realize. And again, kicking the can down the road, the AFib may be harder to treat in the future.
I think if you have COVID, people do use Novax left and right. And I think that would tilt the table more in favor of Dr. Annabelle than Dr. Rahul.
Thank you.
Dr. Anup, I think, Chair, we can end the session now.
Yes. Wonderful. Thank you very much, both Dr. Annabelle and Dr. Rahul, and wonderful talk. Thank you very much.
Thank you so much for inviting us.
Thank you, everyone. Thank you, Chairperson. Thank you, moderators. Thank you, both the speakers, Dr. Annabelle and Dr. Rahul. Thank you for being with CardioCon this year. And now we move to the last session of the day.
Thanks a lot.
For this, I invite moderators Dr. Alok Shinde, Dr. Amit Patil, and Dr. Senthil, and chairpersons Dr. Professor Ajay Mahajan, Dr. Sangvi, and Dr. Rashesh Potiwala, my good friends. Welcome, good evening, and over to you, Dr. Mahajan, Dr. Sangvi, to introduce both the speakers next and move ahead with the case presentation scenario and then the debate.
Good evening, Kamal. Thanks for giving the invitation. This is one of the most informative conference. And today, both of my friends, now they are going to discuss very interesting topic at this interesting hour. Dr. Sanjay Shah is a thorough interventional cardiologist, true radialist, working with Dr. Tejas Patel sir. He himself is a big name. Dr. Sanjay Shah is a master in all kinds of radial interventions. He had done maximum radial interventions and he had published more than 70 papers. More than 79 abstracts, and we had written more than 15 chapters. And he is the best person to defend the today's debate as far as the radial route is concerned. So today's, can I introduce other speaker also? So another speaker, Dr. Sharad Jain. He is a very soft-spoken interventional cardiologist from Ahmedabad. He is a thorough gentleman, thorough interventional cardiologist, and he is very aggressive as far as both radial as well as femoral. He himself is a professor of cardiology at UN Mehta Institute of Cardiology. He is having various publications, and he is going to talk as far as this particular case is a femoral route. So today's case is very interesting. It is a 77-year female with a cardiogenic shock, with chest pain duration of around 5 hours, and she is loaded with clopidogrel. and she is having RV infarction with a complete heart block. Escape rate is around 34 per minute, and we have to revascularize her with primary PCI. So, which route we have to use? So that is the discussion, and this is the ECG of that patient. So may I ask Dr. Dr. Sanjay Shah to start his presentation?
Good evening, everybody. So, hello, can you hear me?
Yes, sir.
Yes, yes.
So, 77 years old patient with acute inferior MI, with RVMI, with window period of 5 hours, with blood pressure of 80 by 55 millimeter of mercury, with past history of hypertension and diabetes, preloaded with clopidogrel and aspirin, with heart rate of 34 beats per minute, has a complete heart block with symptoms of giddiness. His radials are people. The preferred route of PCI would be, of course, radial. Even if the temporary pacemaker is needed, even then the radial route is the preferred modality. Let me tell you, the internal jugular vein access is a default route for TPI at our center. TPI can be easily done using IJV. It is more convenient to the patient as there is a freedom of movement. Lead position is more stable compared to femoral vein. It is a good site for maintaining sterility compared to femoral vein. Let us see what literature says. So this is transjugular insertion of a temporary pacemaker a safe and effective approach? This was published in PLOS 1 to 2020. The aim was to compare the procedure time and complication rates between the transjugular and transfemoral approaches for TPI. Analyze 732 consecutive patients who underwent TPI, from which 361 were in transjugular approach and 371 were in transfemoral approach. The conclusion was the procedure time was significantly shorter in the transjugular approach group. The risk of reposition was significantly more in transfemoral approach group when the temporary pacing was continued for more than 3 days. This is another trial. It's a 5-year study with temporary pacemaker therapy in coronary care unit, published by Mayo Clinic Proceedings, where 1,022 consecutive patients who received temporary transvenous pacemaker in coronary care unit during the 5-year period were studied. And the conclusion was the right internal jugular approach was associated with the lowest complication rate. This was another study, a review of temporary cardiac pacing wires published in Indian Pacing and Electrophysiology Journal. The aim was to determine the best route of venous access for TPI and find the ways to reduce the complications. 3,700 patients from 15 studies were included. And the results were the internal jugular veins was associated with lowest complication rate and ease of access. The antecubital fossa veins have the highest complication rate. Internal jugular veins are the preferred route for the access, followed by subclavian and femoral veins. The right side should be used whenever it is possible. Guidelines from British Cardiac Society recommend the right internal jugular vein as a route of choice for temporary pacing. Now we all know the advantages of radial route for angioplasty, less incidence of access site, major bleeding and blood transfusions. Major vascular complications are rare. If anatomy is not suitable for PCI, thrombolysis option can be easily offered to the patient as the bleeding risk from Cadal site is negligible. This is very important because patient is diabetic since many years. Glycoprotein 2B3 inhibitors can be used without any hesitation. There is no restriction in limb movement after procedure, early ambulation, and the patient with severe LV dysfunctions are not confined to supine position. For experienced radialists, puncture in femoral radial is not a problem. Number of studies have shown morbidity and mortality benefit of radial route in acute MI with cardiogenic shock. Let us see the publications. These are the pooled data of nearly 7,000 patients from 9 studies where major vascular complications were studied, which shows TRI group major complication rate, major vascular complication rate was 0% compared to TFI, it was 3.8%. Radial versus femoral access for rescue PCI with RioPro use. This was published in Canadian Heart Journal. The conclusion was the no access site related major bleeding in radial group versus 9% complication in femoral group. The impact of bleeding, hematoma, and transfusion on the procedure outcome. So this study was published in CCI 2007. The access site hematoma requiring blood transfusion predicts mortality in the patients undergoing percutaneous coronary intervention. This was the data from the National Heart, Lung, and Blood Institute of Dynamic Registry. And the conclusion was the access site complications, especially hematoma requiring transfusion, remains a very important predictor of adverse procedural success and patient outcome. The in-hospital mortality was 9.9% in hematoma group versus 1.2% in non-hematoma group. Impact of major bleeding on 30-day mortality and clinical outcomes in the patient with acute coronary syndrome, published in JACC 2007. The results were patients with major bleeding had higher 30-day rates of mortality, 7.3% versus 1.2% in radial group, and more incidence of stent thrombosis, that was 3.4% in femoral group versus 0.6% in radial group. Conclusion, the major bleeding is a powerful independent predictor of 30-day mortality in patients with ACS managed invasively. Transradial versus transfemoral approach for the percutaneous coronary intervention in cardiogenic shock. This was published in Archives of Cardiovascular Medicine, 2015. 101 consecutive patients admitted for PCI for acute MI with cardiogenic shock were treated. 74 patients were in transradial group and 27 patients were in transfemoral. The rates of PCI success were similar in both groups. At the mean follow-up of 756 days, the death occurred in 54.1% patients in transradial group versus 81.5% patients in the transfemoral group. And the conclusion was the transradial approach in the setting of PCI for ischemic cardiogenic shock is associated with dramatic reduction in mortality and should be preferred to the transfemoral approach in the radial expert centers. ACC, AHA, and Society of Cardiovascular Angiography and Intervention guidelines place TRA for PCI in acute coronary syndrome as a class 2A indication with the level of evidence A, and European Society of Cardiology guidelines now place TRA for PCI in acute coronary syndrome as a class 1 indication with the level of evidence A. So clearly choice is IJV route for TPI and radial route for PAMI. Thanks.
Thank you. Now I'll request Dr. Sharad Jain to talk on transfemoral approach. Sanjay sir will always talk about transradial, that I know.
Thanks.
Dr. Sharad Jain?
Yes, starting.
Next year, we can try Dr. Sanjay to speak on transradial, transfemoral.
Definitely. Definitely.
So, good evening. First of all, thank you very much to Kamal for giving me this again an opportunity. And Kamal is just like a younger brother, and we are working together since 20 years. So it is always very good to feel when to come in this conference and present, because it's a very good academic feast, and Kamal is a thorough academician apart from his practice also. As far as Sanjay Bhai is concerned, he is the master of the he's the master radialist. We have learned a lot of things from him. He was just immediate senior to me. So as such, there is no debate as such. Sanjay is always a winner. But still, because this topic has been given to me, so I will just speak some few things for that. So femoral versus radial approach for emergency intubation, the case of femoral approach in radial first era. We all know that the radial first era, even I may go for radial first. So just coming, तुम्हारे उसूल तुम्हारे आदर्श किस काम के तुम्हारे उसूल. So this I will discuss it later also again. So as the scenario has already been discussed, 77-year-old female.
Your slides are not moving. We can't see your slides.
You can see now.
No, slides are not coming.
The stop sharing, it is showing the folder, Cardiocon 22, femoral versus radial, but it is not showing the slides. You have to first open the slides, then do the slides screen share. You stop sharing first, sir.
Okay.
Stop sharing, then open slides. Open slide again, close the slides, open the slides again, then do the slide share.
Okay, just a minute. Can you see now?
Yes.
Is it moving now?
Yes.
So coming to the case scenario has already been discussed. The important point is radials are feeble, although it is in the hands of Sanjay, it is because he's so expert. It is with the blood pressure of 80, he can take easily radials. For it is not easy for everyone to take the radial with this blood pressure in cardiogenic shock, especially in a 77-year-old female patient, especially with those, so many young cardiologists now they are there. So as far as this even as already been discussed, ESC and all recommends the radial as the first route. However, same has not been studied widely in the second setting of cardiogenic shock and high-risk PCI. Already, as Sanjay Bhai has discussed one study in which there are 100 patients with cardiogenic shock. But if you go through the literature, various trials that radial, survival, and all these semi-radial, all they excluded patient with the cardiogenic shock in the study. Exclusion criteria were this one. So coming to the PCI seminar, the management of patient with high-risk acute coronary syndrome. In a STEMI patient, we all know that the time is muscle. With your experience, you should estimate yourself own that whether you will be able to do with the radial, especially those who are less experienced. So in a STEMI patient treated with an aggressive antiplatelet and antithrombotic, we all know that radial reduces the bleeding complications were performed just by experienced operator. The use of the femoral approach is preferred in hemodynamically unstable patient, and when you need a very rapid fast recalculation, especially if the radial you need large catheters and need lot of support. The radial axis with 6 French sheath will not give that much of support.
So coming to a very important trial, which is published, which has been in the JCC 2019, the Safari STEMI trial, which was conducted at 5 centers in Canada, for seeing whether the aim was whether the determine if the radial axis improves survival when compared to the femoral axis in patient referred for primary PCI, because various previous trials suggest that radial axis is associated with lower mortality in STEMI patient. So just to confirm that. So the primary outcome of this trial was the all-cause mortality measured at 30 days, and the key secondary outcomes for the 30 days, the stroke, reinfarction, stent thrombosis, bleeding. So if you see the primary outcome, the 30-day mortality was almost similar in both the groups, femoral or radial axis in this trial. This trial included all kinds of patients and experienced operators, both for the radial and the femoral route. And the bleeding was definitely slightly higher, but not statistically significant in the radial group, in the femoral group as compared to the radial group. The conclusion of the trial was in patients with STEMI referred for primary PCI, we did not find a difference in survival at 30 days between the use of radial axis and femoral axis. Our findings suggest that adequately trained operators should be able to achieve similar results using either radial or femoral axis for primary PCI. So we all know the complications of various radial and the femoral routes, the common complications. But if you see the radial arterial anatomical variants, which are which might be cumbersome, especially in the emergency situation, in a 77-year-old female, like complex radial arterial loop, then anatomical difficulties, and then the tortuous and radial artery with spasm, and the prone to spasm, small caliber radial artery, and then this like lusoria. So this is this can be difficult to, if you see the literature, the anatomical difficulties in the radial approach, that radial anomalies you can find in up to 10% patients, and procedure failure rate is about 15%, those with the anomalies. So advantages of the femoral approach in the emergency situation in the setting of cardiogenic shock: easier to access, being large caliber and no problem of spasm. So it is, even if it is a newcomer, it is relatively easy. Easy delivery of large sheets, and especially if you required IVP in the emergency situation, and even as I said, the temporary pacing. As Sanjay Bhai said that the transjugular route is good for the venous temporary pacing, I agree with that. But many of us are not experienced of doing temporary pacing with the transjugular route, because we have been trained in that way that we always did pacing from the femoral route. So especially when you are fumble in the emergency situation, and if you complicate the puncture in the transjugular route, then there can be problems. If you data review on radial versus femoral in the emergency setting, radial versus femoral for rescue PCI, no difference in measure of bleeding fluoroscopy time, and contrast use were similar. And the times of first balloon inflation was slightly longer with the radial axis. Chinese study on emergency PCI found no difference in outcomes, however, less vascular complications in the radial group. We all know that. UK study on feasibility of radial axis. Then, so why femoral? Studies point to the fact that when radial axis is achieved, it is better in terms of vascular complications, but only non-inferior to femoral axis. But the important thing is you should get the radial. That may not be possible with everyone to puncture the radial. Once you puncture the radial, then definitely the vascular complications are less, especially in patient with cardiogenic shock and feeble pulse in a 77-year-old operator. So axis is, as I already said, operator and experience dependent. And if you do it with adequate care, if you do a femoral axis and if you do it carefully, then the produces the same stud result and there is no increased bleeding as compared to the femoral route. So, and if you see the intra-arterial BP and femoral axis, femoral arterial BP are more closely correspond to central BP. Radial arterial BP underestimates true blood pressure by 15 to 20 mm of Hg. And you see various studies, the crossover from radial to femoral axis during challenging percutaneous intervention can make the difference between success and failure. And it has been found that the crossover from radial to femoral in various studies is between 6 to 10%. And especially it is more common in the female sex and with the anterior wall MI are the predictors of the crossover. So with the crossover, as it takes more time so that your door to balloon time increases. So that as we said, the time is in muscle, so that time can get increased. The radiation exposure and vascular access in acute coronary syndrome, the sub-study from the matrix, that is the red matrix trial, they can just go to the conclusion. Compared to the femoral axis, radial axis is associated with greater operator and patient exposure, radiation exposure, when performed even by the expert operators in current practice. This is not very old, this is 2017 article. So exposure and risk operator, radial operators has more radiation risk as compared to the femoral, but it is also again controversial. Many studies have now shown that the radiation exposure is similar in both. So for radial, if you see the fewer axis complication, it's preferable in patient with peripheral vascular disease, patient with morbid obesities, patient having extensive inguinal scarring, severe back pain or shortness of breath, and patient on therapeutic anticoagulation, and patient request, of course, and failed femoral approach. Why femoral? Complex cases, larger catheters and sheaths are required. If you require LV support, tower, small radial size, AV fistulas, anatomy, and patient requests. The limitations of the radial route is unpredictable course of to ascending aorta, small radial artery caliber, challenging in cardiogenic shock, increased rate of crossover, radial artery spasm, main culprit to negotiate brachial loop, cardiogenic shock, independent predictor of transradial PCI failure, size of radial artery itself linked to sheath occlusion after removal. And radial approach usually requires more learning curve as compared to the femoral approach. No trial rival matrix compared ultrasound guided micropuncture transfemoral arterial puncture versus transradial puncture and reducing vascular complication. Routine use of radial axis create Compeu paradox. When we were the students, it was the femoral only. We have learned it from the femoral to the radial. But now, because of the started with the radial itself, the new residents and that those coming young cardiologists, they are straightway going to the radial route. So the loss of femoral experience, so more femoral vascular complications if you do not have the experience of the femoral puncture. So in conclusion, femoral axis is time tested, easy to apply, particularly in sensitive conditions like cardiogenic shock. Close proximity with femoral vein gives ease for temporary pacing if required, and deploying IVP and other devices can be achieved on femoral route due to large sheath requirements. And of course, with operator experience and due care, vascular complication may be made comparable to the radial approach. So as I already said, उफ तुम्हारे असूल तुम्हारे आदर्श किस काम के हैं तुम्हारे असूल. This is the dialogue from very famous movie of Amitabh Bachchan. So if you when the radial root catheter arrives late at a coronary ostium, I am not talking of Sanjay Bhai, he's so experienced expert, but I am talking of general cardiologists. So my intention not to teach you a method, but just to give good reasoning. Thank you.
Thank you, Sharad and Sanjay. So now the topic is open for discussion. So can I ask some questions to some points from other colleagues? Dr. Senthil, Dr. Sanjay.
I think there is no doubt that the radial approach is the better approach for those who are experienced in it. The experience is the most important thing. For those who have been doing femoral for years together, I think they'll be more easy to do from the femoral approach. Especially the radial is not palpable well and time is very important. But those who are very well experienced like Dr. Sanjay, definitely the radial approach, because we know all the benefits of the radial approach. The complications are less, even the mortality in meta-analysis has been shown to be less. And of course, the local site complications are much, much less in radial approach as compared to femoral approach. Recently, we had one patient of inferior wall MI who was done through a femoral approach, but the patient landed up with a hematoma, went into hypotension, required blood transfusion, had a longer stay in the hospital. So all those complications of femoral are definitely there. So most important is the experience of the operator, and it depends on how well he can do it.
Dr. Senthil, you are muted.
Senthil, we can't hear you. You're muted. You're unmuted, but the audio is not coming. Dr. Alok, meanwhile, you can comment your perspective.
Yes, sir. That was a great, great talk from both the speakers, and they are my teachers and they were my examiners also, and so it was nice to see them talk. So I think both had their own perspective, and they are right according to them. But I think it's highly operator dependent. I mean, the one who is more comfortable and with femoral approach may choose femoral approach. However, the statistics might be in favor of radial approach. But I think it is more of operator dependent. And whoever is comfortable with whichever approach, that person should choose that route. If a femoral is not necessarily harmful, if the puncture is fluoroscopy guided and a careful puncture, but definitely I think in every case the controls are not in our hands. Like in an obese elderly female, which has I think more prone for hematoma. I think you cannot prevent hematoma even if you take the puncture radiologically. So I think it is operator dependent, but the evidence is more in favor of radial approach. And yes, one should be more very very much acquainted and expert in taking jugular puncture. And in this event of emergency, I think if carotid gets punctured, that can be a nightmare.
Senthil, can you speak now? I mean, you were saying something. So I think we have audio issues at the Senthil. Majan sir?
I think the most important thing during the emergency, the jugular puncture. So preferably if you are very confident, then only attempt that, because if there is some mistake, then there will be a major problem. I had seen some patients with carotid hematomas, and that hematoma is getting extending to the neck and other problems. So I think when the patient is in cardiogenic shock, if we are very much accustomed with the temporary pacing through femoral, then we can tie over, because just after opening the artery, that temporary is not required. So in that case also, you can go temporary with the femoral and intervention through radial. So venous puncture from femoral and arterial puncture from radial. So then we can balance both of our today's masters, Dr. Sharad as well as Dr. Sanjay. So that is my take on this case.
So I think, sir, if there are no further comments or questions, we can end the session.
Yes.
Okay.
All right. Thank you very much. At the bottom of my heart, I want to thank each one of you, all the chairpersons and moderators, and both the speakers for wonderful deliberation and presentation. And every year I have to make radial cases more difficult. I have to come with one or the other jugglery to avoid that some way I can pitch it towards femoral. But now the radials have become so common and it's so easy to do that the cases, scenarios have to become more and more complex to make you do femoral.
But Sanjay will do all the complicated.
Yes. Thank you, Kamal. Excellent conference. Thanks for giving this opportunity.
Sir, my pleasure. Thank you for accepting it. Thank you, all of you. Thank you. Good night, everyone. Take care. We catch you up tomorrow again. Thank you. Bye-bye. Join us tomorrow.
Everybody. Goodbye.
Bye. Good night.
Good night.
Good night.
Ajay bhai. Kamal bhai.